Society, we begin with the session. With the aim of creating awareness among patients, society, and medical practitioners, Odisha Arthritis and Research Foundation Trust was founded in the year 2021. The overall objectives are to raise awareness about autoimmune and rheumatological diseases and their detrimental effects, and helping patients to get access to better treatment. OARFT welcomes you once again. May I now request our honorable dignitaries to please grace the dais. Chief Guest Shri Ashok Mahapatra, VC SOA University. Guest of Honor Professor B.G. Dharmanand, President IRA. President API Odisha State Chapter, Professor Dr. Jayan Kumar Panda. President OSOS Dr. Zahir Khan. Organizing Secretary OARC Update1, Professor Dr. Jyoti Ranjan Parida. May I now request our honorable dignitaries to kindly light the lamp. Sir, please kindly proceed.
Om Jagannatha Namo Namah Shri Jagannatha Namo Namah Jaya Jagannatha Namo Namah Jagataranatha Namo Namah Om Jagannatha Namo Namah Shri Jagannatha Namo Namah Jai Jagannatha Namo Namah Jagataranatha Namo Namah Om Jagannatha Namo Namah Shri Jagannatha Namo Namah Jai Jagannatha Namo Namah Jagataranatha Namo Namah Om Jagannatha Namo Namah Shri Jagannatha Namo Namah Jai Jagannatha Namo Namah Jagataranatha Namo Namah Om Jagannatha Namo Namah Shri Jagannatha Namo Namah Jai Jagannatha Namo Namah Jagataranatha Namo Namah
May I request everybody to stand for the national anthem.
Jana Mana Adhinayak Jaya He Bharat Bhagya Vidhata Punjab Sindh Gujarat Maratha Dravida Utkala Vanga Vindhya Himachala Yamuna Ganga Uchchala Jaladhi Taranga Tava Shubha Name Jage Tava Shubha Ashish Mage Gahe Tava Jaya Gatha Jana Gana Mandala Dayak Jaya He
I now request Professor Dr. Jyoti Ranjan Parida, Organizing Secretary, to give the introduction about the meeting.
Very good morning to all. Respected chief guest and other guest of honors, all our delegates from across the country. First of all, I would like to thank all of you and welcome you to the Temple City of India, Bhubaneswar, and attending this academic feast called OARC Update1. And this is the first time we have tried to have an interface meeting between two different groups of medicine. One is rheumatology and another is ophthalmology. This is organized by Odisha Arthritis Rheumatology and Foundation Trust, which is only 1 year old. But the basic aim and objective of this trust is to raise awareness and whatever little bit we can contribute to the society in spreading awareness, because this is a branch, rheumatology is a branch since long, is a very neglected branch. Many patients today are not affected, not suffering because there is no treatment. Gone are those days. But the main reason why they are suffering is actually lack of awareness, for which they are diagnosed late, they are coming late, and that's why we are not able to appropriately treat them in proper time. Because any chronic disease today, you take diabetes, hypertension, or arthritis for that, say, or any autoimmune disease, the time is the key, which today there is a very convenient word called window of opportunity. You will lose the opportunity and the time has gone. So besides doing other activities like helping patients, donating some patients who cannot afford their treatment, doing medical camps, OARFT has thought of bringing this medical education or to at least innovatively organize meetings which can help the newer generation of doctors at least to know about newer treatment modalities and interact with each other, because today medicine is not a compartmental science. This is not a scopy where you have to just look through a tunnel to treat one disease. You have to treat the patient, and as a rheumatologist, I will not be happy if my patient is pain-free, swelling-free, moving freely, but he has lost his vision. So all of them are from very prestigious institutes across the country and who have given their time in spite of their busy schedule and is today among with us. And I again sincerely thank all our delegates who have come from Cochin to Delhi across the map of India, at least to present their cases and to participate in this academic feast. I wish this will be have a great academic experience and you will enjoy this meeting. So now I'll call our chief guest, Professor Dr. Ashok Mahapatra sir, who is ex-director of AIMS Bhubaneswar and now the Vice Chancellor of SUA University. Sir will address us. Thank you.
Good morning. Jai Jagannath. In Odisha, we start everything with Lord Jagannath. And then, Dehi Saubhagya Arogyam, Dehi Me Parama Sukham, Rupam Dehi, Jayam Dehi, Jaso Dehi, Jasoji. When Markanda Rishi wrote Durga Saptasati and Orgala Stotra, he wrote Dehi Saubhagya. We are very lucky. You have a good destiny. But I don't know how many were Arogyam. So destiny has no meaning without Arogyam. And we are all for Arogyam, but we are all unhealthy. Dehi Saubhagya Arogyam, Dehi Parama Sukham. India is the most unhappy nation in the world. Out of the 180 nations, we are 170 in the happiness index. Gross domestic happiness index of India is 170th out of 180. So we are not happy. We are, I don't know, good luck. We are unhealthy, we are unhappy. And Rupam Dehi, Jayam Dehi, we have beauty. Of course, we have beauty. We are victorious because we are here. Without victory, we would not reach here. We have victory in MBBS entrance, MD entrance, super special entrance, and faculty also. So you are successful, but I don't know Bhagya. So let me start with all the dignitaries that our guest, Dr. Dharmanand, Dr. Panda, everybody know Dr. Panda, Colonel Professor Jahiruddin Khan. We are the student at Puri College almost 55 years back. We joined MBBS in 1970, and Dr. Parida and all the dignitaries, Dr. Ramnath, Sir, and all of the dignitaries, faculty coming from all over India. I think it's a wonderful occasion that we have a rheumatology and eye conference, because yes, if you go back to when we were MBBS student, there are neither rheumatology, there is no immunology, everything is taught by a professor of medicine. I remember, I think Okranda Sorangi was teaching us arthritis. And when you're talking about nephritis and nephrosclerosis, anything nephrotics, diseases related to immunology, this was no nephrologist. So I think PC Shah was teaching us, one of the associate professor of medicine. So definitely medicine has improved. If you look at the immunology of the world, we didn't have anything called immunology before 1959. But we had biochemistry, we have chemistry, we have antibody. Otherwise, penicillin would not have developed. We would not have read about how the bacteria is producing antibody. Generally, we would have produced the cars or the vaccine for the smallpox. That's a wonderful thing Edward Jenner did about 200 years back. 1797, first vaccine Edward Jenner. So if you look at the immunology, we will tell it immunology, but you will understand that something has to go inside the body. It has a body reaction. Some chemical process has to happen, and then the body has to react. But this modern term of immunology started by Fenner and Born and Fenner, something like that. But if you look at the immunology in India, it was AIMS started in 1970. And in 1961, the CSR was started by Pandit Nehru, first Prime Minister of India, Department of Science and Technology, CSR, Council of Science and Technology. 1971, DST started, Department of Science and Technology. 1985, Professor Ramachandran was a medicine biologist, became the director, and they said director and president of DBT, Department of Biotechnology. As I understand, there is no disorder in the body which is not immune mediated. Everything is immune, unless you talk about brain tumor, we are talking about immunological aspect of brain tumor. There's 10 of my PhD students at AIMS did something on immunology. What are the immune factors? First PhD, the T cells population in glioblastoma, 1985. Manoj Bhosle from Maharashtra. What he was studying in 1985, between 81 and 85, at AIMS Delhi, a T cell population at body. And today we are talking lymphatics in the brain, G lymphatics. We all understood probably no T cell in the brain, no lymphatics in the brain, nothing happens in the brain, brain is so close that nothing can touch it. No, it's not like that. Every disorder of the body affects every system, be it joint, kidney, eyes, brain. Most of your immunological disorder will affect brain, believe or not. Whether somebody manifests or do not manifest, it's a matter of concern. So I think it was a very wonderful occasion. The conclusion is that I was postgraduate committee chairman of NCI 2005-2012. Many people tend to NCI, DM immunology. So the conclusion, Dr. Sorin would ask us, the PG committee, how you differentiate rheumatology and immunology? I said, one is the trunk, other is the branch. Very simple. No, without no trunk, the branch cannot develop. Today, neurosurgery have 10 super specialties: pediatric neurosurgery, traumatic neurosurgery, functional neurosurgery, stereotactic neurosurgery, gamma knife neurosurgery, skull-based surgery, what not? Vascular neurosurgery, aneurysm, AVM, cryptic malformation. When I did neurosurgery 45 years back, neurosurgery, that is stem, the branches. You can choose whatever branch you want. So my point is that rheumatology is a very important branch of immunology. And coming to I was Indian Ophthalmology Association member for about 20 years, life member. I always attended Delhi Ophthalmology Society meeting because we operate. I was a member of Oculoplasty Society of India because my friend, my junior, Ashok Grover, when they started 1980s, Oculoplasty Society of India student surgery, Dr. Pradeep Sarkar, and before that was Professor Daya at AIMS Delhi. I don't know how many of you know Professor Daya. He was the first squint surgeon of India who was the first president of Oculoplasty Association of India. And they made me member because I used to operate orbital tumor. I was looking after the optic nerve injury cases which I first saw in 1980 and treated about 1200 cases of optic nerve injury. How many? 1200. So the question is that if you want to do something, you have to eye open. I will finish by telling you, Lord Krishna told in Bhagavad Gita, we are all blind and deaf. We do not want to see something which you do not want. I doesn't see something which I or brain doesn't want to see. So we are blind, physically, maybe physically okay, but our brain is blind and deaf to many occasions. So by and large, we are deaf and blind to everything. So we should keep your eyes and ear open because knowledge, I don't know how many of you saw one movie called 3 Idiots. I saw it many times. I never saw a movie, but I saw it because it has given wonderful situation that knowledge can be learned from everywhere. Today, in new education policy we are talking, knowledge is not only classroom. It is internet, blended education. You learn from the net, learn from the online education, take the course and get more credit points so that you are doing engineering, you require 140 credit points. If you earn about 400 credit points during your engineering, you spend 140 credit points for engineering, another 140 credit points for MBA, Master of Business Management. Then also you have around 20 or 30 credit points reserved. You can do diploma in human biology or a psychology diploma, because then your credit point will earn within 3 years of your engineering, you will get 4 degrees. And now new education policy say education should be not rigid. You are doing MBBS, you can do master in fine art, dancing. You can do MBBS, simultaneously you get a BA in dancing, music, economics, law. So question is that where do the education end? It should be boundaryless, it's a free, it should earn from everywhere, it's a credit point, and it should be utilized for the best benefit of humanity. So this conference is meant for educating the human being to be nice to humanity by all what you can learn from each other. Thank you very much. Enjoy your day. Jai Jagannath. Vande Utkal Janani. Thank you very much.
Before we proceed to our next guest, I think we'll have a short unveiling of souvenir which is made for this occasion. So next I invite Professor Dr. B.G. Dharmanand sir, who is President of Indian Rheumatology Association. We are very lucky that he is there today with us. Sir, please have some word of wisdom.
Good morning, Professor Mahapatra and colleagues in the dais and of the dais. And thanks, Jyoti, for this opportunity. And greetings from Indian Rheumatology Association. As Jyoti was telling, awareness about rheumatic diseases, autoimmune diseases needs to be improved in the community. And IRA as a society, we observed April month as a rheumatological disease awareness month with a lot of all pan-India campaign to increase awareness. And time is money. In rheumatology, time is joints, time is nephrons, time is heart, time is brain. So our diseases do affect almost all organs, and time is eye as well. Many of our diseases affect eyes as well. So unless the diseases are identified early and treated early, we may lose function and organs. And this kind of meetings where we interact with various other specialties, particularly eyes are dear to us. Ophthalmologists are one of the earliest specialists who probably identified that rheumatologists could help them in dealing with autoimmune eye diseases. And to many rheumatologists, ophthalmology referrals form a major patient population. So with these few words, I wish this function great success, and wish Jyoti and his trust many more meetings like this. Thank you very much.
Again, we are very fortunate that two societies, Odisha State Ophthalmology Society and API Odisha chapter, has collaborated with us for this function, and they have helped us. So now I will call Professor Dr. Jayant Panda sir, API Odisha chapter president, to tell few words. Sir.
Thank you, Professor Jyoti. Dignitaries on the stage and many known faces in the audience. Rheumatology has been a science which has been identified with excellent clinical reasoning, and any CPC, any approach to justify internal medicine ends in rheumatology. That's the weakness. From student life, I have been associated, though I'm a man of internal medicine test, rheumatology appeals me the most. And in internal medicine, out of all the disciplines, I'll tell here is a science, which already Professor Mahapatra has told you, basis of all diseases. And in COVID pandemic, we have seen how important is clinical immunology and rheumatology, which has not only come with treatment options, but a patient's immunological backup has proved the approach and the interventions. Let it be a cytokine storm, let it be a tocilizumab therapy, let it be a clinical stratification and intervention, all goes in this specialty. So I congratulate Professor Jyoti for this endeavor of having a session on a focused topic. What we do in internal medicine, already Professor Mahapatra has told, it has become very broad. And then the specialties are so many, we are unable to focus. And from internal medicine to clinical immunology, rheumatology, and from clinical immunology to eye, catching eye in rheumatology is very, very relevant. And I'm sure today there'll be a series of discussion where you can know about the eye and the clinical immunology. Similarly, say skin, similarly, say kidney, similarly, say bone. So many things are there, need to be discussed in a very specific manner. And I know Professor Jyoti from his student life. He's a proud student of ours. I have traveled to his village attending health camp, and then he has been always thought different than his contemporary society. So I'm sure the Odisha Arthritis and Rheumatology Center and the Foundation's Trust will do many more academics. You see a focused program, how well organized, with chauvinists, with stalls, with faculties across the country. So I congratulate the whole team of OARC, especially Professor Parida, and wish in Odisha, OARC, the Odisha Arthritis and Rheumatology Center and the Foundation Trust will disseminate knowledge like many other organizations, and Odisha will be in the limelight because we think of our physicians, we think of our land, and from this place, the knowledge has been disseminated throughout the country, throughout the world, in the past also, making a wave of awareness that we know Odisha has that potential by blessing of Lord Jagannath. And I'm sure today's program will be very informative. And not only that, the OARC, the OARFT will have series of programs with this focused impression for our youngsters, for postgraduates, for physicians, which will disseminate knowledge. Finally, I thank all the guests who have come to my land, Professor Dhammanand, and I see many known faces, Soumya, and then Dr. Sharma, and then many known faces, and the join of rheumatology, the father of rheumatology, clinical immunology of the country, Professor Ramnath Mishra here. So I congratulate the whole team, and I'm sure with putting hands together, we can march forward and disseminate knowledge and make every physician aware of immunology and rheumatology. Thanks for the invitation.
Now I request Professor Dr. Zahir Khan, who is President of Odisha State Ophthalmological Society, to address the gathering.
Esteemed dignitaries on the dais, Professor Ashok Mahapatra, the President of Indian Rheumatological Association, Dr. Ramanand, the President of API, Dr. Jayant Panda, and the Chief and Director of the Rheumatological Center, Odisha, Dr. Jyoti Parida, and the friends and delegates outside the dais. This is an occasion for the first time the Ophthalmology Society and the Arthritis Society come together to deliberate the recent advances in these two fields, and the eminent speakers throughout from the abroad, international as well as the national, will speak about this thing. Professor Ashok Mahapatra is a brilliant scholar. He's an eminent surgeon and international figure. Over this last so many decades I have seen, he has only increased, no change in his physique, but the increase is the silver appearance of his hair and the spirituality and the knowledge which he gained. And the relation of the ophthalmology and the neurology, everybody knows how close, intimate it is. And he befitting this occasion, he is the actually chief guest on this occasion, and he has told so many things about. Similarly, the rheumatology and ophthalmology having Choli Daman Rishta, because this eminent thing in this, that HLA 27 has brought these two departments together. So on this basis, you will listen to the deliberations about the eminent speakers from ophthalmology, like Dr. Jyotirma Viswas, Dr. Samya Vasu, and from Dr. C.R. Rathinam. They will enlighten you, and as well as the rheumatologists across India, they will highlight the things in relation to ophthalmology. I wish we all, both the fraternity will be benefited by this, and I wish all the success for this update. Thank you all.
So we'll not delay for the academic event. So before we finish, I must introduce Dr. Sakir Ahmed, who has actually made this beautiful scientific program for us, who is working as an assistant professor at KIMS and is the editor of our souvenir. So I again once thanks to all our faculties, all our respected chairpersons, and especially the delegates who have come so far to attend this conference. So now I think we'll start the academic event. Thank you, sir, for joining us.
We'll start with the scientific session for today. For the first session, I would like to invite Professor Dr. Jayant Kumar Panda and Dr. Anup Kumar Khilgaonkar to the dais. Sir, please. Dr. Anup Kumar Khilgaonkar, can you please come? Thank you, sir.
So welcome. Again, welcome to the scientific program. To start with, we have a international faculty, and I want the volunteers to connect him. He's connected. Dr. Rosenbaum is connected. The first presentation in our OARC update, Catching Eye in Rheumatology, is having a very important theme. The topic is uveitis in SPA from box to drugs by none other than Professor James Rosenbaum, who is the Senior Vice President for Research at OSOS, a US biotech company with an interest in immunotherapeutic. Until 30th June, Dr. Rosenbaum was Professor of Ophthalmology, Medicine, and Cell Biology at Oregon Health and Science University. He was chair of the Division of Arthritis and Rheumatic Diseases for 21 years at OHSU. He held the Edward E. Rosenbaum Professorship named for his father. He continues to be chair emeritus at the Legacy Devers Eye Institute, where he evaluates patients with ocular inflammatory diseases. According to Wikipedia, he is the world's only practicing rheumatologist to have headed a department of ophthalmology. And it's really interesting. We listened Professor Mahapatra, Ashok Mahapatra, who was our chief guest. He is a member of Indian Society of Ophthalmology. Similarly, being a rheumatologist, clinical immunologist, James Rosenbaum headed the Department of Ophthalmology. He is the author of more than 600 peer-reviewed manuscripts of book chapters and the receipt of a number of national and international awards in rheumatology as well as ophthalmology, and the recipient of 41 years of continuous funding from the NIH, and contributed immensely to the science. So for the topic uveitis in SPA from box to drugs, we present you Professor James Rosenbaum. I request my co-chair, Dr. Anup Khelgaonkar, to invite Dr. Rosenbaum.
Good morning, everyone. Professor James Rosenbaum has been a guiding light for all of us in uveitis, especially for seronegative spondyloarthritis associated diseases. And I would be very happy to listen to him today. So would be all of us. I invite the team to connect him online.
So the presentation is recorded. I request the volunteers to play the record.
Hello, my name is James Rosenbaum. I'm sorry I can't be with you in person, but I'm thrilled that you've chosen the eye as a topic for rheumatology meeting. I'm going to discuss uveitis and spondyloarthritis. I'm going to talk about both the microbiome and the clinical presentation of the disease. My plan is to begin with that clinical review and then seg over to the pathogenesis, which I believe is fundamentally related to the microbiome. I'll describe a puzzle, give you some background about the microbiome, share information about bacterial products and inflammation, and then see if I can juxtapose the concept of the microbiome to the pathogenesis of uveitis and ankylosing spondylitis. So we recognized the association between HLA-B27, which was once upon a time called A27, since 1973, when a group from London reported that there was a close association. About 50% of individuals with sudden onset anterior uveitis are HLA-B27 positive in England. Many of those individuals have associated spondyloarthritis, so that we know that spondyloarthritis is the most common systemic disease associated with uveitis in Europe or in North America. And I'll show you in a moment that it's common in India as well. So I was in communication recently with Dr. Biswas who's the first author of this report based on his experience in India. And here's a table from this paper from 4 years ago about the causes of anterior uveitis in an Indian population. And as you can see, the most common identifiable cause of anterior uveitis is indeed HLA-B27 related. I think from Dr. Biswas's and his colleagues' data, if you were to look at all anatomic causes or anatomic associations with uveitis, tuberculosis probably outnumbers HLA-B27. But that also might relate to this being a referral center rather than a community center. Now, in a lifetime, if you have ankylosing spondylitis, you probably have nearly a 50% chance of having at least one episode of sudden onset anterior uveitis. And conversely, if you are HLA-B27 and you have an episode of acute anterior uveitis, you probably have roughly an 80% chance of having some associated spondyloarthropathy. This is a paper that was published in the journal Ophthalmology about 6 years ago, and it was from a group in Spain, and they analyzed nearly 800 patients with anterior uveitis and collaborated between ophthalmologists and rheumatologists. They concluded that if you had anterior uveitis and you were HLA-B27 positive, your chance of having axial spondyloarthritis was 71%, and your chance of having peripheral spondyloarthritis was about 22%. Now, some of the individuals have both, and I've discussed with the authors how many had both, and they couldn't tell me. That's why you can't add 71 and 22 to get 93%. It's around 80% in this study. Fascinatingly, even among individuals who were HLA-B27 negative, if they had had recurrent episodes of anterior uveitis, they concluded that a sizable proportion, 19% having axial disease, 11% peripheral disease, a sizable proportion had also associated spondyloarthropathy, even though they were B27 negative. The uveitis associated with HLA-B27 is really quite characteristic, and certainly there are exceptions, but in general, it's an anterior uveitis as opposed to an intermediate or posterior or panuveitis. It starts suddenly, and often the patients will have a prodrome. They'll know a day or two in advance that the eye is about to become inflamed. The inflammation is described by ophthalmologists as being non-granulomatous, and there are cells that deposit on the back of the cornea. These are called chorotic precipitates. Generally, the disease resolves completely within several months. This is in contrast to, say, Behçet's disease, where the uveitis is recurrent, but generally the disease does not resolve completely between attacks. The attacks are almost always unilateral, but they can recur and sometimes recur in the opposite eye. Herpes simplex is a cause of recurrent anterior uveitis in one eye, but generally HSV is associated with a uveitis that raises the intraocular pressure. HLA-B27 is associated with a uveitis that tends to lower the intraocular pressure. And there are other associations with HLA-B27 associated anterior uveitis, such as pus in the anterior chamber, which is called hypopyon, or fibrin, or posterior synechiae, where part of the iris gets stuck to the lens that's immediately behind it. Now, I understand that there's very little IBD or inflammatory bowel disease in India, at least compared to what we see in the United States. But in the next couple of slides, I've compared in Portland, Oregon, how the uveitis associated with inflammatory bowel disease compares to the uveitis associated with spondyloarthropathy, namely ankylosing spondylitis. So for ankylosing spondylitis, we find that almost 2/3 of the individuals are male, whereas the uveitis that we see with inflammatory bowel disease, either Crohn's disease or ulcerative colitis, is almost always in women rather than in men. The uveitis, as I said, with ankylosing spondylitis is either in one eye, or if it is in both eyes, it's flip-flopping. It's not active in both eyes at the same time. It was bilateral and only 6%. Whereas the uveitis associated with Crohn's or ulcerative colitis in nearly 2/3 can be active bilateral. And HLA-B27 is associated with nearly 90% of the patients with ankylosing spondylitis having acute anterior uveitis, whereas it's closer to 50% in inflammatory bowel disease. And if I had made these same slides for psoriatic arthritis, the data for psoriatic arthritis tend to look identically to IBD. Only a small percentage of patients with Crohn's or ulcerative colitis get uveitis as a complication, whereas, as I said, up to 50% of patients with spondyloarthritis in a lifetime will have an episode of anterior uveitis. I think many of you are aware that the monoclonal antibodies that block TNF are very effective in preventing episodes of acute anterior uveitis, or at least reducing the possibility of developing an attack. Sulfasalazine, which is less expensive and affects the microbiome in the gut, is also equally effective as the much more expensive biologics. Now, let me leave the clinical overview, which is admittedly, I tried to be brief because my time to share with you is limited, but I want to talk about the pathogenesis and the role of the microbiome, or at least the putative role of the microbiome. I was very lucky to train with this gentleman who passed away a few months ago, Hugh McDevitt. And Hugh McDevitt, along with Baruch Benacerraf, wrote a commentary in the journal Science 50 years ago. And in this commentary, they wrote that the genes in the major histocompatibility complex, which we call HLA in man, that these genes, this type of genetic control of specific immune responses, may play an important role in susceptibility to a variety of diseases in both animals and man. When they wrote this 50 years ago, there were no known associations between HLA and disease, but it took about 18 months for their hypothesis to be confirmed. Now, I'd like to suggest to you that McDevitt and Benacerraf were only partially correct, and we wrote a commentary about this that appeared in the Annals of Rheumatic Diseases a few months back. They were only partially correct, perhaps, because the microbiome was really not known as a concept 50 years ago. And I'd like to believe that the microbiome is the link between HLA and immune-mediated disease predisposition. So the McDevitt-Benacerraf hypothesis was confirmed by that group in London who reported the association between B27 and acute anterior uveitis. And before they wrote that paper, they noted an association between ankylosing spondylitis and HLA. As I said, it was then called A27. A group at UCLA made a very similar observation. They published in the New England Journal the same month as the group from London. So what do we know about HLA molecules and disease susceptibility? Well, there are more than 100 diseases that have some sort of HLA association. The vast majority of these diseases are immune mediated. We know that HLA molecules are involved in the presentation of antigen to T cells. And these HLA molecules, therefore, control the immune repertoire. They control whether or not an immune response is made to certain specific antigens. So it would seem that a logical reason why HLA molecules would predispose to disease would be because of this effect on the immune response. But while this may be true, in virtually all of these 100 diseases, no such proof has been offered as yet. There may be some exceptions, perhaps cyclocitrullinated peptide in rheumatoid arthritis is one such exception, but for the most part, there's an HLA association, and it's not clear that there's an antigen to which the immune response is being shaped by the HLA allele. So let's leave the concept of HLA in the immune response and talk a little bit about the microbiome. I think you probably are aware that we have more bacteria in our body than mammalian cells. And if we were to look on an RNA transcript level, we have about 100 bacterial transcripts, unique bacterial transcripts in our body for every mammalian transcript. In other words, on an RNA level, a messenger RNA level, 99% of who we are is really bacteria. Only a fraction of that microbial world can be cultured, but we need those bacteria. We need them, for example, to make vitamin K, they make neurotransmitters, and they educate our immune system. So my own personal interest in the microbiome began roughly in 2010. And it was stimulated by an article that appeared in Science that showed that the metabolic syndrome could be induced in mice that lack the Toll-5 receptor. I think all of you are aware that there's an innate and adaptive immune response, that the Toll receptors are a vital component of the innate immune system that allow our immune system to react quickly to infections, but rather non-specifically. Toll-5 recognizes a protein that is unique to bacteria. It's called flagellin. And not surprisingly, if you delete Toll-5 from a mouse, the mouse has an alteration in the bacteria that are present in the gut. It's more surprising that these same mice develop metabolic syndrome. They become obese and they become insulin resistant. But that's not why this paper appeared in Science. The paper appeared in Science because if you take these Toll-5 knockout mice and grow them with their cousins who are genetically identical with a normal Toll-5, except for a normal Toll-5, and you put them in the same cage, if those Toll-5, the knockout mice and the other mice are germ-free, that is, they were born by cesarean section, they were never colonized with bacteria, the normal mice acquire the bacteria of the knockout mice because they eat each other's stool. The term for that is that they are coprophagic. And in so doing, the genetically normal mice get metabolic syndrome. Metabolic syndrome turns out to be a contagious disease. They get fat and they get insulin resistant. Not quite as much as the knockout mice, but nearly so. So that to me was fascinating, that diabetes might be a disease driven by the microbiome. Now, there's been a revolution in our understanding of the microbiome. And that revolution is because the cost of sequencing the genome has gone down dramatically. So here's the cost, or rather chip memory, which is called Moore's Law. And it shows you how chip memory has been increasing over the years from 2001 for the next 20 years. Here's how the cost of sequencing the human genome has gone down. And it's gone down even more precipitously than the expansion of chip memory. So that we can now sequence the entire human genome for under $1,000. And similarly, we can sequence bacterial genomes very inexpensively. And by sequencing, we don't need to culture the bacteria. We can identify them on the basis of their DNA. So here are a few examples of how bacteria educate our immune system. One example is that there are certain bacteria that determine how many regulatory T cells, FOXP3 positive T cells, are circulating in the body. And this work came out of Japan more than a decade ago, examining Clostridia. This is a study that appeared in Immunity from Diane Mathis's group at Harvard. And they showed that a bug called the SFB, the segmented filamentous bacteria, binds to the epithelium of the colon. This is seen in a scanning electron micrograph. And in so doing, it increases the number of T cells that make the cytokine interleukin 17. The Mathis group studies the GPI model of arthritis, in which an antibody to glucose 6 isomerase is transferred in the form of serum. And in this transfer model, you can quantify the amount of arthritis by ankle swelling. And here you see how much ankle swelling occurs in the control animals over days. If the animals are germ-free, as you see in the open circles, you get much less ankle swelling. Without gut bacteria, the ankle swells not nearly as much. And if you start off with a germ-free animal shown here, and then allow them to acquire intestinal bacteria, their ankles begin to swell nearly as much as the control animals. The Mathis group also looked at 53 different bacteria and showed that in germ-free animals, you could take these 53 different distinct bugs, monocolonize a germ-free mouse, and show immunologic effects. And similarly, if you raise an animal germ-free, you tend to get shriveled mesenteric lymph nodes and a shriveled spleen and an impoverished immune response. So we know that for virtually every rheumatic disease, rheumatoid arthritis, systemic lupus, scleroderma, there is a dysbiosis. There is a change in the gut bacteria. And we can define a dysbiosis as an alteration in the gut microbiome that's associated with the potential to contribute to disease pathogenesis. As I mentioned, germ-free mice have a weakened immune system and a markedly impaired ability to mount an immune response. And I submit to you that's because the microbiome is playing an absolutely vital role. There are trillions of bacteria in the human gut with tremendous diversity, and they educate the immune response. And without those bacteria, we don't have a very effective immune system. Now, more than 100 years ago, an ophthalmologist named A.C. Woods was doing experiments with the supernatant from cultured bacteria. And Woods wrote in a paper in the Archives of Ophthalmology that he could isolate poisons from these non-pathogenic ferment-producing bacteria, and they would have an action on the uveal tract in the rabbit eye. They would cause uveitis. So he would grow up bacteria in broth, he would inject that broth intravenously, and then he would observe histologically the rabbit eyes had a white cell infiltrate around the ciliary processes, which indeed is what we see in an anterior uveitis. This idea that an occult bacterial infection was the cause of inflammation was a predominant idea in the 1920s and 1930s, not just for uveitis, but for rheumatoid arthritis and other inflammations as well. So here's a paper from 1932 out of a group at the Mayo Clinic in Rochester, Minnesota. If you were referred to the Mayo Clinic for uveitis in the 1930s, they would look for foci of infection. Those most frequent foci that they identified were around the teeth, the tonsils, the prostate, or the cervix. And if you had uveitis and you went to Mayo Clinic and you were a male, you would have removal of that foci, a prostatectomy perhaps, or if you were a female, a hysterectomy perhaps. That was the thinking that dominated 90 years ago in terms of understanding the pathogenesis of uveitis and other forms of inflammation. I started my fellowship under Hugh McDevitt in 1978 and stumbled upon the concept that we could take bacterial endotoxin from bacterial cell wall, inject it into the foot pad or intravenously into a rat, and that would induce an acute anterior uveitis. Bacterial products can be very inflammatory, as shown in rodent models. So, does the microbiome contribute to the pathogenesis of ankylosing spondylitis? To test that idea, my colleagues and I first asked the question of, do the HLA molecules shape the microbiome? And the answer is definitely yes. This is work that was done largely by Mark Asquith, my colleague who passed away about 3 years ago from a cerebral aneurysm. But Mark showed that both the HLA allele that predisposes to ankylosing spondylitis, as well as the shared epitope that predisposes to rheumatoid arthritis, those alleles shape the microbiome in people. This was a collaboration with Matt Brown, a very talented immunologist who's now in London. So what I submit to you is a hypothesis. The hypothesis is that an HLA allele, such as HLA-B27, has an impact on the microbiome. That impact is to alter the ecosystem, which changes the permeability, which allows bacterial products to circulate and then can be targeted by the immune system. And that's what results in spondyloarthritis and uveitis. If this hypothesis, if this chain of events is really true, there are many implications. So this is an image that will appear in a forthcoming book chapter that my colleagues and I wrote. But if you start with this HLA association, as I said, that would lead to a dysbiosis. It would educate the immune system differently. And if that's really true, then perhaps we could correct the immune system to prevent this disease. We may be able to correct the immune system once the disease has started in therapy, such as by fecal microbiome transplant, or we may be able to just alter the microbiome by giving different substrates for the bacteria, by diet alone. And it's also really critical to realize that anything that we ingest is not only going to alter the microbiome is going to alter what we're ingesting. And that is true for medications such as methotrexate. And in fact, there's an emerging new field with Jose Scher being one of the leaders, Jose being at NYU, that he calls pharmacomicrobiomics, how the gut changes medications and alters their therapeutic potential. So in this brief overview, I hope I convinced you, as they said in science, there is promise in poop. What I've shared with you is largely a smoking gun. I don't think I've proven my series of hypotheses, but I think I've shown you some very circumstantial and persuasive evidence. HLA molecules indeed do impact the gut microbiome, and that may well explain why McDevitt and Benacerraf hypothesized, or were able to hypothesize, that HLA molecules were going to affect immune-mediated diseases. It's an area that we need to explore further. There is a lot that is unknown and follows from this hypothesis. while I suggest to you that the mechanism by which HLA-B27 causes a dysbiosis is via the immune response, it could be something else. For example, if HLA-B27 changes what's called the unfolded protein response, that too could cause some dysbiosis. I think that dysbiosis makes the gut leaky and allows bacterial products to translocate. It is known that you can find bacterial products, say in patients with inflammatory bowel disease, circulating bacterial products, but it's not actually proven, I think, in ankylosing spondylitis, although it's known that patients with ankylosing spondylitis do have increased gut permeability. We don't know if whole bacteria or living bacteria need to translocate, or maybe just a bacterial product like endotoxin. We don't know if some bacteria are more likely to translocate than others, but undoubtedly this is true because some bacteria live on the epithelium of the gut and others do not. And then there's a mystery because uveitis in association with HLA-B27 is highly episodic, whereas the joint disease, for the most part, is more monotonic. It just kind of grumbles along with mild flares, whereas the uveitis, as I said, comes and goes. Why should that be if the pathogenesis is very similar? I do not know. These are the individuals with whom I've been able to collaborate, but Mark Asquith in particular has been a star, and Tejpal Gill has now assumed Mark's role. Steve Plank has been my collaborator for 30 years, and people like Joel Torok and Rob Knight and Matt Brown and Bob Colbert have also been very instrumental in this collaboration. Again, I'm sorry I can't be with you, but I hope that this has been an informative experience, and thank you very much for your attention.
Actually, it was a very informative and mind-provoking presentation. What I met from his presentation, the gut microbiome and the HLA correlation, and also the relation with SPA and the ankylosing spondylitis, what he has told, it's very intricate, and he has been working in the field of rheumatology and ophthalmology for almost 4 decades by now. So it's very important data he has given, and I'm sure Professor Jyotirma Bishwas will be lighting more on this because he has quoted his article on the subject, and all the questions can be taken by Dr. Bishwas, and those who specifically ask Dr. Rosenbaum, you can give your questions to the organizers. They can mail and get your answers by end of the session. I request Dr. Anup to conclude the session.
Yeah, it's a topic of great fascination, how a disease that is predominantly clinically seen as non-infectious has in fact its origins in with infectious elements like gut microbiome. Deep thanks to Professor Rosenbaum for this lecture today. We'll go on to, I have a few questions for our uveitis and rheumatology faculty. We will take it after Dr. Bishwa's lecture.
Sir, I would like you to be seated for a while. I would like to invite Professor Dr. Bharat Panigrahi, sir, to please come up to the dais and present a token of appreciation to our chairpersons. Dr. Bharat Panigrahi, sir. After that amazing session, we would like to proceed for the second session. I would like to invite Dr. Sucheta Parija and Dr. Sanghamitra Kanungo. Please come up to this dais.
So good morning. We are starting the second session. It is on. We'll be calling up Professor Jyotirmay Biswas, and he is known in the ophthalmic field, a father of uveitis, specializing in uveitis and ophthalmic pathology since 3 decades in Shankar Nethralaya. He did his fellowship in vitreoretinal surgery from Shankar Nethralaya and fellowship in ophthalmic pathology from Doane in Institute, California, USA. He has published more than 497 articles in PubMed and 62 chapters in books of ophthalmology. He has presented more than 300 papers in national and international conferences and 5 books in uveitis and 1 book in ophthalmic pathology. He has mentored 45 uveitis fellows and also others who have interest in uveitis. He's received 43 awards, including Hariom Ashram Albanic Research Award from ICMR from President of India. He is a member of International Uveitis Society Group, American Uveitis Society, and International Ocular Inflammation Society. He is the founding member and past president of Uveitis Society of India. He was the first to describe ocular lesions in AIDS in India. Currently, he is working as the Director of Uveitis and Ophthalmic Pathology at Shankar Nethralaya, Chennai. Welcome you, sir.
At the outset, I'd like to thank Dr. Jyotiranjan Panda and OARC for giving me this opportunity. I'm sorry that I might be little disoriented because I was in the airport. I finished the TNA Tamil Nadu Ophthalmology Conference, and from there we came directly over there early morning. So I'll try my best and talk about anterior uveitis, clue to suggest autoimmunity. Outline of the talk is introduction, why immunology is important in the uveitis for the rheumatologists, juvenile idiopathic arthritis associated uveitis, Bloch syndrome, ankylosing spondylitis associated uveitis, psoriatic arthritis associated anterior uveitis, HLA-B27 associated anterior uveitis, HLA-B27 associated uveitis, rheumatoid arthritis, and uveitis and scleritis. I read this article which really impressed me. The acute anterior uveitis and spondyloarthritis more than meets the eye. In fact, nothing can be more true than that. There's a lot of things which you need to look into it, the anterior uveitis and spondyloarthritis. I'll be talking about first juvenile idiopathic arthritis and particularly juvenile idiopathic arthritis associated uveitis. This is close to my heart. I feel pained when I see that the eye become icicle in one eye of these small children who has got whole life forward, and is just a little bit of the our ophthalmologists and rheumatologists, we become a little more collaborative. We can see many of these eyes can be saved, and which is being saved nowadays with collaboration of the juvenile idiopathic arthritis of the uveitis to check it very early at the disease. What is juvenile idiopathic arthritis? It is nothing new for this rheumatologist. It is the most common childhood rheumatic disease, most prevalent systemic disorder in children with uveitis, arthritis of at least 6 weeks of duration without any identifiable cause in children younger than 16 years. Risk factor for the GI-associated uveitis, pauci-articular type, less than 4 joints involved, most common. Knee joint is commonly involved. ANA positivity and predominantly female, onset at less than 4 years. That is the preschool stage. Why is very important? It produces chronic anterior uveitis, and which is often not detected early enough, and subsequently lead to the band-shaped keratopathy, glaucoma, vitritis, cystoid macular edema, disc edema, and most important is the hypotony. And this hypotony can lead to the hypotonic maculopathy, and ultimately, which is very tragic, the eye becomes thisis. Cumulative incidence of uveitis is 8.5 to 25% in various studies. So I like to highlight one of the important side effect or complication, risk of hypotony in juvenile idiopathic arthritis associated uveitis. It's as high as 9.3%. Many of the uveitis patients, juvenile idiopathic arthritis associated uveitis, lose vision for hypotony. Children often do not complain of eye problems. When you see them, these are white-eyed uveitis, they are not aware of it. By the time they come to the ophthalmologist, already there's a band-shaped keratopathy, posterior synechial, complicated cataract, and sometimes even hypotony. So management is a challenge, and there are various steps and various drugs are available. The first treatment option is topical steroids with or without short-acting mydriatic cycloplegic agents or mydriatic. But 97% uveitis specialists are of the opinion that there is an indication for systemic immunosuppressive medication, which are using with the methotrexate as the first choice. The treatment with the systemic immunosuppressive medication was associated with decreased risk of visual loss in GI-associated uveitis. 73% of the pediatric uveitis specialists now favor additional treatment with the TNF-alpha inhibitor, adalimumab 49%, infliximab 24%. However, the cost is one of the barriers. This is a landmark article in the New England Journal of Medicine 2017, where they have found adalimumab plus methotrexate for uveitis in juvenile idiopathic arthritis. And this was by Professor A.V. Ramanan from Bristol, UK. 90 patients, multi-center, double-blind, randomized, placebo-controlled trial. The treatment with the adalimumab was significantly delayed the time to treatment failure as compared with the methotrexate alone. A significantly greater number of patients in the adalimumab group than in the placebo group discontinued topical glucocorticoids, which is a great advantage. So adalimumab in combination with methotrexate found to be an effective therapeutic option in children and adolescents with GI-associated uveitis, which has become now an ideal treatment. Surgical procedures are required in this GI-associated uveitis. There is a complicated cataract, roll of intraocular lens implantation is debatable. Lensectomy, vitrectomy is one of the options. I do prefer getting lensectomy and vitrectomy because in the long run they do well. Band-shaped keratopathy, where EDTA chelation is done, and penetrating keratoplasty when there is a corneal opacity is quite advanced, and secondary glaucoma trabeculectomy with mitomycin. This is a band-shaped keratopathy. How bad it is, you can see, and it can be reasonably cleaned with EDTA chelation. Our study has shown that juvenile idiopathic arthritis associated in India over this last 16 years has something different. It is a 40-patient polyarticular, more common in the male children, and RA factor anti-nuclear antibody is negative, and immunosuppressive showed better course as expected. We also did a study on phacoemulsification with intraocular lens implantation in juvenile idiopathic arthritis. Sudha Ganesh, my colleague, has done the study with Sudarshan. Study from a center showed 70% patient has visual acuity of 6/9 or better, but 30% patient has visual acuity of 660. So it's a very well selected cases we should choose to give the intraocular lens in such patients. I wanted to show one. I don't know. Mouse is there. There's a video in it. Can you play the video? This is a patient, very unfortunate patient, and you can see that she's hardly able to see and just searching everything. And this patient had got arthritis with uveitis. This patient history is that he had undergone lens extraction with also history on intravitreal steroid injection in right eye in 2017. She has been treated with the injection methotrexate 20 milligram, which is the maximum dosage subcutaneously, but not tolerated by the patient. Then she was shifted to adalimumab. Initially, she responded well, but after 2 years, she became resistant to the treatment. She has also been treated with JAK inhibitor tofacitinib, which worked only for 2 to 3 months. Recently, she has received injection of intravenous methylprednisolone for sight-threatening complication and injection infliximab, after which she felt better. And his right eye was BCVA was 1/60, hypotonia on digital tension, band-shaped keratopathy, aphakia, aqueous 3+, aqueous 3+, flare 3+. Although the left eye was little better, but still there is a band-shaped keratopathy, anterior chamber was quiet. Patient was put on infliximab injection and referred to the rheumatologist for follow-up because she was not responding to the infliximab. Advised the prednisolone eye drop to control the inflammation 12 times per day for a week in the right eye and 4 times per day in the left eye, and homeotropin 3 times for a week. We know that this is not enough for this patient. She needs something different to control the inflammation because she started not responding to the infliximab. What next? She has tried methotrexate, she has tried adalimumab, she has tried JAK inhibitor, but now what is next? So opinion from Professor A.V. Ramanan was from UK was short, and he suggested started on subcutaneous injection of tocilizumab, and he received the 2 injection of tocilizumab and patient felt better. From the juvenile idiopathic arthritis associated uveitis, we come to another disease which is called Bloch syndrome, which are increasingly we have started seeing it. Systemic features at presentation is the arthritis involving interphalangeal joints, maculopapular dermal rash, and this patient presented with chronic uveitis. And you can see the multiple Busakas nodules in both eyes. And this patient was treated with injection adalimumab with methotrexate, and you can see that such an elegant response is seen in both eyes, and we could preserve the vision of this young child. We published this in the Indian Journal of Ophthalmology in 2018, uveitic and sporadic blotch syndrome, long-term follow-up of refractory cases treated successfully with injection adalimumab. Now coming to the ankylosing spondylitis associated uveitis, which Professor Rosenbaum has highlighted, I just wanted to show our experience. It can have bilateral chronic sacroiliitis, only 30% at presentation, with fusion of both sacroiliac joints, up to 90% of the patients positive for HLA-B27. But remember, not all HLA-B27 positive patients develop this disease. One can have the bamboo spine as shown in this one picture and sacroiliitis. Sacroiliitis can be better delineated by MRI imaging as shown in the arrows, fusion of the joints, and these patients often presented with anterior uveitis. The features of anterior uveitis is that they develop synechia. They develop hypopion and fibrin reaction, severe fibrin reaction. 40% patients with acute anterior uveitis have undiagnosed spondyloarthropathy. Clinical characteristics and prognostic factors in ankylosing spondylitis associated uveitis is there is a retrospective study which showed male preponderance 70%, average onset 4th decade, HLA-B27 positive as high as 94.5%, unilateral uveitis 87.9%, 7.7% showed hypopion. Vitreous involvement or retinal vascular leakage was seen in 36.3% cases. 50% patients show recurrence, which is one of the common rule of this type of the uveitis. Psoriatic arthritis associated uveitis is less common. They can have erythematous macules, papules, and plaque-like lesions, gouty psoriasis. These are the dermatological manifestations. And then they can have arthritis mutilans, as seen in these pictures. Usually in the hands and feet, produces stiffness, pain, and progressive joint damage. HLA-B27 associated uveitis is one of the common uveitic entity we encounter in ophthalmology clinic. HLA-B27 gene is seen on the chromosome 6, and this HLA-B27 antigen is a major histocompatibility complex class 1 cell surface antigen. Its task is to present microbial antigens to T cells. Almost all nucleated cells in the body have class 1 HLA molecules. And what is very characteristic is the acute anterior uveitis with a lot of fibrin material. And you can see that such a huge fibrin material, if you don't treat aggressively, they will lead to the synechia formation and occlusio pupillae. So how do you see the HLA-B27 is anterior uveitis? Is little different in the two parts of the world. Western countries is seen 18 to 32%. We fortunately see a little less, 6 to 13% cases in Asia. Some of our studies have shown this percentage of the less than 12% of the uveitis of HLA-B27. Spectrum of HLA-B27, ophthalmologist it comes as acute anterior uveitis, but rheumatologist sees in many phases of the HLA-B27, ankylosing spondylitis, psoriatic arthritis, inflammatory bowel disease, and reactive arthritis. Undifferentiated spondyloarthropathy is the last one. Systemic association of HLA-B27 related uveitis in a study has shown frequent association with the seronegative arthritic syndrome. The activity of the uveitis is not necessarily correlated with activity of the systemic HLA-B27 associated disease. What are the key points? HLA-B27 related anterior uveitis. As I mentioned to you, it's young male, 20 to 40 years old, males being about 2.5 times more likely to be affected than females, recurrent and unilateral or unilateral alternating, which we call ping pong ball-like manifestations, acute pattern triad of pain, redness, and photophobia, high fibrin content in the AC, and hypopia in 12 to 15% cases. Recurrences, as is often the rule, characterized by full remission between the attack. Suddenly the patient gets another attack, and the patient gives typical history that I got everything all right, and then again it came back. It often becomes a challenge to the ophthalmologist to explain to this patient this recurrent nature of the disease and how to prevent the same. Possible triggers include infection with the gram-negative bacteria, stress, specific season, and trauma. Frequency of attack decreases with the age of the patient. So what is very interesting is that what I observed that the patient can tell they have got a premonition kind of thing that is very early stage. They can say that the eye is becoming heavy. Even if you don't see in the patient came, before the cells in the AC is detectable, the patient reports that there is a sign of, he or she is getting the attack again. So don't ignore and see the patients carefully for anterior chamber flare and cells and start treating these patients as early as possible. So posterior segment manifestations is often neglected and is about 20%. And these are the two studies, and one in 1999 and another is the 2009 has showed 21% of the patients with HLA-B27 has acute anterior uveitis, 75% has vitritis, and other studies showed 78% vitritis, 29% CME, and this study showed 43.5% CME. CME is cystoid macular edema, fluid in collection in the central part of the eye. Papilledema 8%, 13% papilledema in the other study, new study, 21.7% retinal vasculitis, and 4.3% can have pars plana exudate. So vitritis can be initial features of HLA-B27 associated uveitis. So always look for the fundus examination, posterior segment in such cases. I just want to present a case which I've seen recently. Is a 36-year-old female, history of pain, redness, and for 5 days, he was already under topical and oral steroid. Best corrected visual acuity while presentation, the right eye was 660, 66 and 260 in the left eye, no history of joint pain and low back ache. Anterior segment, we could start seeing that flare and cells 3+, vitreous cells 3+. When we looked at the fundus, we could find out there's a dense vitreous haze. And this was a patient which was an HLA-B27 positive uveitis. So we studied, Parthapatim and myself studied the ocular manifestation of HLA-B27 associated uveitis, 255 cases from our center. We found in 431 eyes of 255 patients, male preponderance was 75.7%, mean age was 35.6 plus minus 13.3 years, anterior uveitis 95.3%, anterior and intermediate uveitis 3.9%, intermediate uveitis 0.7%, retinal vasculitis 0.9%, and hypopia 11.6%. So associated systemic disease, we found 69%, recurrence was 85%, immunosuppressive agents added in 39.6%, biologic therapy required 4 patients, and I'll talk about the biologic therapy, our experience in HLA-B27 positive uveitis. Good visual outcome, fortunately, is seen 78.4% eyes. Moderate visual impairment was 14.2%, but 7.4%, about 32 eyes of the 255 eyes is showed severe visual impairment. So it should not be neglected. Posterior segment manifestation, retinal vasculitis can be one of the features. 9 patients, bilateral 89%. Peripheral retinal quadrants were involved in all eyes. Vessels of the posterior pole, 59%. Vascular occlusion, 47%. Neovascularization, 35%. Cystoid macular edema, 76%. And you won't be surprised that one can have vitreous hemorrhage also. So this is a case of posterior segment manifestation, and you can see this is a fluorescent angiogram picture, and you can see the cystoid macular edema. Eyes with the vitreous cells are approximately 3 times more likely to develop cystoid macular edema. 13.4% of the HLA-B27 associated uveitis presented with or subsequently developed cystoid macular edema. So take home message, always perform a USG-B scan if you are unable to see the posterior segment of an acute anti-uveitis with HLA-B27, dilated fundus examination, not possible due to the cataract, synechiae due to the dense vitritis. There's do a ultrasound in such cases. Why should we investigate and refer? 66% of the HLA-B27 positive acute anti-uveitis develop spondyloarthropathy after 9 years. What is 6.8 HLA-B27 negative AU patient develops spondyloarthropathy after 9 years? Such a huge difference. So it's really mandatory for ophthalmologists to refer these patients to the rheumatologist. Why should we investigate and refer? 78% of HLA-B27 positive associated uveitis has extraocular disorder. 65% were diagnosed as a result of ophthalmic consultation. If HLA-B27 positive, is it necessary to exclude other causes of uveitis? Answer is yes. There will be other causes of uveitis. Many individuals who are HLA-B27 positive never develop back pain and eye involvement. I happened to see one patient of HLA-B27 positive pan-uveitis. I was treating with the systemic steroid isomethyl prednisolone. The patient lost follow-up. When he came, the patient was an endogenous fungal endophthalmitis. So be careful about the other entity, and you should not close the eye just HLA-B27 positive pan-uveitis. You should rule out the other causes, which is very important. Many individuals are HLA-B27 positive, never develop back pain and eye involvement. Detection of HLA-B27 doesn't exclude another diagnosis. This is one of the take-home points I wanted to impress upon. Always correlate clinically. Management of HLA-B27 uveitis is simple. Topical therapy as frequent as possible. Topical steroids every 1 hourly, or sometimes I give every 15 minutes, depending on the degree of AC inflammation, and mydriatic cycloplegic agents. Management of HLA-B27 systemic therapy, sulfasalazine, which has been highlighted, methotrexate, biologicals. I'll be talking about our experience of biologicals. What do we try to achieve is the preservation of the vision, so remissions or recurrence can be prevented. How to do that one? I have studied, we have worked on that oral methotrexate for the patients who has got multiple recurrence, and we found 2.6% to 0 reduction in the recurrence rate. And these other studies have shown also that 3.4 to 0.89 reduction in the recurrence rate, 73% reduction in inflammation. Oral methotrexate can reduce the recurrence rate in non-granulomatous anti-uveitis, especially in HLA-B27 positive patient. This drug, as you know, that is got a lot of experience, safe and effective. Rarely it can cause complication. If you take that liver function test and total WBC and platelet count, you are often safe to monitor this patient. Oral methotrexate 15 milligram per week dosage I used to give accounts for the lesser number of side effects or mood compliance of the drug. So this is an article which said that can you prevent the recurrence of anterior uveitis? And the answer is an option. Methotrexate is an option for preventing the recurrence of acute anterior uveitis. they found recurrence rate from pre-methotrexate 3.4 per year. With methotrexate, it becomes 0.89 per year. So we have used the anti-tumor necrosis factor alpha agents in the management of HLA-B27 associated uveitis, which are recalcitrant, and this was published. And 14 patients of refractory HLA-B27 associated uveitis, age ranges from 70 to 53 years. Majority of the patients are ankylosing spondylitis. Subcutaneous injection adalimumab was given in 12 cases, subcutaneous injection golimumab 2 cases. Vision improved in 10 patients and maintained in 4 patients. And all the patients, not only their eye become all right, their ankylosing spondylitis was also very well taken care of. So rheumatoid arthritis very rarely cause uveitis, but they can cause scleritis or sclerouveitis. They respond well to the corticosteroids or immunosuppressive agents. And we have not used biologic agents that frequently in rheumatoid arthritis associated necrotizing scleritis. So we use the immunosuppressive agents like cyclophosphamide or mycophenolate mofetil. I prefer mycophenolate mofetil as the first line of therapy, and if not responding, switch over to cyclophosphamide. Take home message: various types of arthritis can cause uveitis, mostly anterior non-granulomatous. They can cause significant visual morbidity if not treated promptly. GI-associated uveitis needs aggressive therapy with immunosuppressive and sometimes biologics whenever needed, and it should be promptly switched over. Rheumatologists should be aware of this and promptly refer to an ophthalmologist of any patients who are seeing in the rheumatology clinic with the joint involvement, so that we can start the treatment early enough, soon enough, and appropriate enough. Thank you very much. I'll be happy to answer any questions.
Yeah, thank you, sir, for this wonderful talk. Yeah, the take-home message is definitely there that all HLA positive patients that we usually see the anterior segment, all the ophthalmologists present over here should always dilate the patient, as sir has elaborated, should see the posterior segment, and not HLA, all HLA negative patients also do not, I mean, they are not, they are not supposed to be treated by the ophthalmologist only. You should refer to the rheumatologist and get their opinion also. And JRA patients, the rheumatologist also should refer the patient early to the ophthalmologist. So both of us hand in hand can treat the patients much better. So if the organizers can allow, we can take 2-3 questions.
So I have one question to ask. So GI patients, you're saying it's better to start them with methotrexate. So what is the...
Better to start?
Start with methotrexate,
yes.
Those cases. So just when do we see that we should change over to biologics in those cases?
So if I see that methotrexate is not working for at least in a 3 months period of time in my practice, I switch over to biologics. I wait for 3 months to see that response, because methotrexate takes a little time to act. But if there's a vision-threatening complications like cystoid macular edema and hypotonia is growing, I switch over to biologics as soon as possible. Like injection adalimumab is my drug of choice, and biosimilar one, and which can be given subcutaneously. But many of the times now in our country, there is still a lot of people cannot afford biologics, and they can take 1 or 2 biologic injections, and after that they are often not able to take the biologic agents.
So as you very well said, we have seen this GI patients coming with us with hypotonia, and they are actually losing their vision. They have cataract and all. So one more thing is, what is the prognostic role of this ANA, anti-nuclear antibody, for disease process in this case?
So I don't really that much depend on the ANA. I look at my slit lamp examination and ANA positive, ANA negative, I treat in the same way. I've got a patients who are one I lost, another I treated with methotrexate. The patient uveitis is controlled. She passed MBBS and now doing post-graduation. So early enough, I started methotrexate to that patient and could salvage the vision, this young girl. So methotrexate is often useful, and in some cases, a percentage of the cases, you need to switch over to adalimumab.
So one more question, like these GI patients, if they go to the rheumatologist, and how often they should be, the screening procedure, how often they should be coming for once at least their eye checkup to rule out the uveitis. So that message should go. So if we see uveitis, we usually refer them to the rheumatologist. So henceforth from them also, if they are suffering from GI, they discover them first. So how often if they have a white eye?
So there is a guideline is there, but I usually tell the patients, tell the rheumatologist that let me see once in 3 months at least, if it is all right. And if there is any eye symptoms or eye signs, I do according to the signs of eye involvement until I see that the flare cells is not there, and give a long-term treatment for the flare of these patients with non-steroidal anti-inflammatory agents and giving methotrexate, and keep them close follow-up. Once the eye inflammation subsides, then I ask them to send it to me at least once in 3 months.
Any other questions, anyone?
Hello, sir. Jyotirmoy Vishwas, sir. Good morning. Actually, I have come to listen to your presentation today. As you know, Dr. Atul Kumar, Professor Atul Kumar, was our mentor in their IMS Delhi. He always tell about you whenever any uveitis things like started with discussions. So that was my motivation to come to today. As you have come and given your lecture, we got to know your experience. So thank you for that. My question is 2 to 3 questions. So thiacical eye, actually, you have done the study to 55% of ankle spondylitis. So what is, as you have shown in JIA, the thiacical eye percentage is something 9%, 10%.
Yes.
So the thiacical eye is more in ankle spondylitis or JIA, according to you?
No, it's in the children, that one, when you undetected uveitis in the children.
Okay, sir. Because in ankle spondylitis, in my experience, by little years of experiences, I have seen 3 to 4 cases of ankle spondylitis going to thiasis, where I couldn't do the cataract surgery because so thiacical, I couldn't save that eye. And sir, second question is like methotrexate, we should start as all. So as Dr. Rajanbaum, methotrexate plus adalimumab.
Yes.
If that will be better, or first we will start methotrexate. If not responding, then we will transfer.
What I do is that I start with methotrexate. If not responding, I go add adalimumab.
Okay. Sir.
So in our country, it's very difficult to have that injection adalimumab. Still, that one, though it's often ideal to put the patients on combination of both methotrexate and adalimumab as early as possible. But I try methotrexate and keep them on close follow-up. And if methotrexate doesn't work in 3 months period of time, I convince them or try to push adalimumab subcutaneous, 20 milligram once in 2 weeks in the children.
Okay, sir. And last question is, you have told do ultrasound in HLB27 uveitis. Obviously, we should know, we should do the posterior segment examination. That is a must for any uveitis workup to rule out intermediate posterior uveitis. But if you cannot see the posterior segment, we will do ultrasound. So what point do we want to see in ultrasound? Like, as you know, that CM is there, maybe vitritis. In ultrasound, what will pick up? Like vitritis?
I like to see that the vitreous haze.
Vitreous haze. Okay.
Yeah, I like to see the vitreous haze. How dense is the vitreous haze and how soon as soon as possible, I like to see the retina. I like to see the retina grow as soon as possible. If the retinal glow is not seen, then the vitritis is not that severe in case of HLA-B27 and panuveitis. But endogenous endophthalmitis, vitritis is severe, and there may be sometimes clumps of exudates. And that once should get a good history of immunosuppression, like history of IV infusion and history of some other septic foci on such cases. So these patients, incidentally, HLA-B27 is a very common antigen and gene. It can be positive in normal people also. Is normal percentage of the patient. So there is nothing prevents them to have HLA-B27 and endogenous endophthalmitis. So though HLA-B27 panuveitis is a definite disease entity, I think is a close differential diagnosis would be endogenous endophthalmitis. I have got one case and I burned my finger.
Okay, sir, thank you. But apart from we are giving like that topical steroid. So is there any management course will change? Like we want to give system steroid or intravitreal steroid like Kenacort, etc. In that, if we found that is dense vitritis.
No, I'll give it steroid.
What? Intravitreal.
In case of panuveitis, I'll give steroid. Systemic steroid.
System steroid. Okay, sir. Thank you, sir.
Systemic steroid.
Okay, thank you, Dr. Vishwas, for your nice talk. So I am Dr. Panigre. I am from Eli Prasad Eye Institute. I am not an ophthalmologist, but I am a physician working there. So you have shown a case presentation of blouse from your center and published in 2018. I'll just say we are also not lagging behind. In our center, we had detected one case of blouse syndrome in 2015 or 16, and Dr. Basu is there. So this is a very interesting case of 10 years old child, female child, presented to us with recurrent uveitis. When there are band keratopathy, there was postosenicia, and the child was almost, there was also cataract, almost blind in one eye and very much low vision in the other eye. The history goes like this. The history is very important because we may be missing patients also. The child goes, the history goes to 2 years. For 2 years, the patient was suffering from intermittent fever and rash. So that led us to see, to at least think of something like blouse, because the patient had for 2 to 3 hours only, the patient will have fever. The child, the child is very active, then the child is down like that. And there will be rashes, skin rashes, and she presented with just arthritis of both knees. And that led us to think of this blouse, because this is nothing but the early onset of sarcoidosis. And I discussed with Dr. Basu, and we went for this iris biopsy, and we saw the non-cageating granuloma in the iris, and subsequently put him on the genetic studies, and we found it not to gene mutation. And this is another new site mutation, which is not what we searched in the internet, that was not there in almost 90 or 95 cases has been recorded in the world. And there was we also published in 2016 or something like that. So this is our experience on blouse.
I just always try to impress my students that in uveitis always you say that, okay, we'll look at make the room light dim or room light off and see the patient flare and cells, room light off, inject ophthalmoscope. I say it's not enough. You should have a look at the eye, at the whole system as a look at the patient, whether they has got some other signs or symptoms. Not only the blood, like Bassett's, SLE, all these cases you can miss if you keep the room light on and just concentrate on the eye. So holistic method should be taken.
Right, I agree. That's need of suspicion. Unless you suspect, you can't do, because the child, the father was so active. He told, I have visited almost every center in this state from 2 years to 10 years. So that is the message that we should see. We should take a very good history, then only we can diagnose. Thank you.
Now tell Dr. Sangamitra to conclude the session.
Thank you, sir, for that elaborate and exclusive talk. We would end this session and call upon the next.
Excuse me, ma'am. Just one question.
Okay, the last question. We can take the last question.
Namaskar, sir. This is Dr. Nidhi Sinha. Sir, I recently started my practice. I just wanted to know what is the role of the Mantoux test and IgG positives and torch in the management of uveitis. Like I see a lot of patients who have positive Mantoux, but we are still not, clinically doesn't look like TB, and torch IgG positives, like in textbooks they say it's not anything significant, but a lot of patients come with that. So what should I do with them?
Very small children like neonates, there I take the value of this torch one. Otherwise torch is useless. So I don't take the herpes group of viruses. I don't put any value to the torch titer. And regarding the second questions which you are asking, that Mantoux test. Mantoux test alone is not helpful for the diagnosis. You look at the clinical phenotypes. There is a clinical phenotypes has been already described. With granulomatous anterior or intermediate uveitis, serpiginous like choroiditis, retinal vasculitis, broad posterior synechia. Along with that, if you see Mantoux positive or quantiferon TB gold test positive, then you combine that one and make a diagnosis of tubercular uveitis. So even in that, if my suspicion phenotype is tubercular uveitis, like miliary tubercle I've seen, I don't care what is the Mantoux test. It can be Mantoux negative also. And I treated the case of tubercular uveitis.
Question for Dr. Vasu, but Vishwas, but due to paucity of time, we'll move on to the next session. Thank you, sir.
Thank you very much. I'd like to thank Dr. Jyotiranjan Panda once more for giving me this opportunity.
Ma'am, Dr. Sucheta Parija ma'am and Dr. Sangamitra Kanungo ma'am, can I please request you to please felicitate Dr. Jyotirmay Biswas, sir? Ma'am, can you please wait? I would like to request Dr. Jyotirmay Biswas sir to please give a token of appreciation to Dr. Sucheta Parija ma'am and Dr. Sangamitra Kanungo ma'am. Thank you very much, Professor Dr. Jyotirmay Biswas sir, for such an informative session. Moving on to the next session, may I please invite chairpersons Dr. Ajit Surin and Professor Dr. Chandan Das on the dais, please.
I would like to welcome the next speaker. He doesn't need an introduction in the rheumatology world. But let me introduce to the other doctors. Right now, he's the president of IRA, that is Indian Rheumatological Association, Professor B.G. Dharmanand. He finished his MBBS in 87 from Madurai, did his MD Medicine from Mysore in 1992, and DM Rheumatology in 1996 from Chennai, and finished his fellowship between 2002 to 2004. And currently he's a consultant rheumatologist in Manipal Hospital. And right now, the president of IRA, that is Indian Rheumatological Association. It starts.
Thank you, Dr. Ajit. You are the first one to make me a professor. I was never a professor in my life. Thank you very much for this honor. And thanks, Dr. Jyoti and his team for this invitation. And I always envy ophthalmologists. We always, immunologists, talk about T cells, B cells. They are the only ones who can see the cells. We can't. So I'll always feel envious about them. And before I start the talk, I probably will discuss a case whom we had seen the last 6 months or so. The patient had recurrent anterior uveitis, which was not dissimilar to what we see with HLA-B27. He had 1 or 2 episodes of knee arthritis, and we made a diagnosis of HLA-B27 was negative. So we made a diagnosis of HLA-B27 spondyloarthritis and put him on sulfasalazine. He was in remission for a year. He stopped the treatment and had a articular recurrence. So he came to me. I gave an injection into the joint and gave him sulfasalazine again and added vitamin D as our prescription. We thought every rheumatic patient should require vitamin D. And within a couple of weeks, I got a call from my nephrologist. So your patient is admitted with hypercalcemia and renal shutdown. And we did, and pulmonologists were called and they did a CT scan. He had sarcoidosis. So sometimes what looks like a typical spondyloarthritis related uveitis, sometimes we do get surprises, and that's the reason we should always go beyond B27. Even when B27 is positive, sometimes, as Professor Biswas was telling, if the features are not typical, we should look beyond. This is for non-ophthalmologists. We always, as I'm looking at from rheumatologist perspective, we look at when ophthalmologist refers to patient, whether patient has got the deferral diagnosis, anterior uveitis, and a lot of terminology is used by non-specialist ophthalmologists. Sometimes we say it as iritis, iridocyclitis, anterior cyclitis, intermediate uveitis, posterior uveitis, and panuveitis. A lot of nomenclatures are used. Sometimes we see only choroiditis, choroidal retinitis. As a rheumatologist, we don't connect choroidal retinitis with uveitis that easily. So we need to understand the terminologies, and it took some time for us to understand these terminologies and relate. When ophthalmologist says chorioretinitis, it's still a kind of a posterior uveitis. And this is a picture which I liked it because it tells where the inflammation is. Intermediate uveitis, you see a lot of inflammation in the vitreous. And another terminology we look for is whether the ophthalmologist calls it as granulomatous or non-granulomatous, because our differential diagnosis is different. In a non-granulomatous, we look at HLA-B27 and other UVA causes, and granulomatous differential diagnosis goes towards sarcoidosis, tuberculosis, VKH syndrome, and sympathetic ophthalmia. Some of them are diagnosed by ophthalmologists. We need not break our head here. And these are the few illnesses I'm going to focus on. I'll focus a little bit on Behçet and Crohn's and psoriatic arthritis and JAA, which was discussed elegantly by Professor Biswas. And in posterior uveitis, I will touch a little bit on sarcoidosis and VKH. This is a busy slide, which includes almost all rheumatic diseases which we know, and many of them have uveitis. It's difficult to read and difficult to see, don't worry. And the purpose of putting this slide is to say that almost all rheumatic diseases can have uveitis as a common or a rare manifestation. And we always look at the common ones, but rarely, if If you don't find a cause, start thinking of the rare causes, particularly relapsing polychondritis. I've had two patients with relapsing polychondritis who had uveitis as well. So what is the rheumatologist's role? Infectious diseases, infectious causes are generally ruled out by ophthalmologists. So when the ophthalmologist refers the patients to us, we assume that infections have been ruled out. But having said that, if my treatment is not doing well, ophthalmologists are following them up, the patients are not doing well, I'm sure ophthalmologists will think of potentially other causes. And as a rheumatologist, we should also think of potentially other causes. Sometimes it turns out to be tuberculosis when the initial preliminary tests were, even when the preliminary tests were negative. And many times, nowadays, uveitis specialists have done all the tests which are required for non-infectious causes as well. And eye-specific autoimmunitis is diagnosis already made by them. So many times they refer to rheumatologists, immunologists for immunosuppressive support because of our experience with immunosuppressive management. And treatment is always done with dual monitoring. I can't see what's happening in the eye. So ophthalmologist sees the patient, say eyes are good, continue the same medicines. Then I will continue. If the eyes are not good, escalate the immunosuppression. So that is why it is done. Patient sees ophthalmologist, comes to us. That is the usual routine, because if they come to us, I don't know whether they're doing well or not. So eyes are monitored by ophthalmologists, and drugs and its complications are managed by us. And knowledge gap in this field is very common. As a rheumatologist, our focus is not always on eye diseases. And many general ophthalmologists are not familiar with how intense they should treat these eye diseases. And we have to familiarize with eye jargon as well. And we all know that eyes don't tolerate inflammation well. So there is an urgency here in managing these patients. Many times the time is lost because many times they go to 4 or 5 ophthalmologists before they get referred to a uvea specialist, and the uvea specialist make a diagnosis and they send the patients. They anyway start them on steroids and send patients for immunosuppressive support. And we investigate as per the referral diagnosis. We generally look at the referral diagnosis, anterior uveitis. We look for common causes for anterior uveitis. And if it is granulomatous, I look for sarcoidosis and other diseases. Intermediate uveitis, again, we look for tuberculosis and sarcoidosis. And posterior uveitis will have a differential diagnosis. We look for Behçet, we look for sarcoidosis and lupus, etc. And rheumatologists are experts in interpreting immunological investigations. Many times ANAs are positive, ANAs can be false positive. 5% of the population, at least 1 or 2 of us here in this room may be ANA positive without ever developing any autoimmune disease. So we need to interpret this disease intelligently and make sense out of it. And we try to help, and we try to look for a systemic cause for uveitis, as many autoimmune or many uveitis still remain unclassified, or no cause was assigned to them. So the other way is called idiopathic. Many of the idiopathic uveitis may still have underlying autoimmune disease lurking behind. Sometimes we have to proactively look for at the first visit and also at the every visit. And we manage a patient with the support of ophthalmologist and monitor the disease and drugs, and also follow for non-ocular manifestations, because uveitis can be the first manifestation of a rheumatic disease. The patients may develop other diseases subsequently. We see commonly uveitis, patient developing spondyloarthritis later. There is a patient who had HLA-B27 positive and a very classical sarcoidosis. He had a bilateral hilar-adenopathy, sarcoid uveitis. 3-4 years she was maintained, and after 4 years, after bringing down to azathioprine 25 milligram for 6 whole months, we stopped azathioprine. Eyes are quiet, but she developed bilateral sacroiliitis. So always there is something new happening in these patients because they are HLA-B27 positive. Sarcoidosis is in remission, but she has developed ankylosing spondylitis. So it's always good to keep them on long-term follow-up. And there are few rare diseases which we have picked up in the practice. Psoriasis alone presenting as uveitis. Some of the idiopathic uveitis, there was a small patch of psoriasis which was not looked at. So probably it was a psoriasis related uveitis rather than idiopathic uveitis. TNO is tubulointerstitial nephritis with uveitis, very rare. I've seen only one so far. And lupus is a rare cause, multiple sclerosis, and GPA. GPA generally produces more scleritis and sclerouveitis. This is a slide which tells that many of the anterior uveitis, we know the diagnosis, a cause can be assigned, either infective, non-infective, ocular syndrome, names can be given. But if you look at intermediate uveitis, majority of them remain idiopathic, and the number is lesser and lesser in posterior and panuveitis. This is one of the largest study I could think of. In this study, even in anterior uveitis, majority of the cases were unclassified, though many anterior uveitis were given a name, either P27 uveitis, can be infection, sarcoidosis, etc. But intermediate uveitis, predominantly, they are still idiopathic. So we always think of Behçet when a patient is referred to us with bilateral uveitis. Behçet can have anterior uveitis, posterior uveitis, panuveitis. It is usually bilateral. Even between the flares, eyes were never quiet. So it's always a smoldering inflammation. So it is essential to ask for subtle symptoms like recurrent orogenital ulcers and look for other evidence like periphlebitis, past history of DVTs, etc. And once eyes are diagnosed, then the treatment has to be aggressive. There is no diagnostic test. HLA-B51 is sometimes supportive, used, but it is never diagnostic. It is vision threatening, and steroids are the initial treatment. And the azathioprine and cyclosporine combination used to be the classic immunosuppressives used. This is one area azathioprine has a primary role. Nowadays, anti-TNF has been very effective, and wherever people can afford, anti-TNF is becoming the drug of choice. And remember that immunosuppression in Behçet syndrome is probably long-term. At least 4 or 5 years of immunosuppression is required. It has to be very slowly tapered in consultation with the ophthalmologist. And of course, other extraocular manifestation also determine the intensity and the duration of treatment. Sarcoidosis is again not an uncommon disease. Ocular complications occur in 20 to 60% of the patients. Whenever we suspect sarcoidosis in a multi-system autoimmune disease, we send them to ophthalmologists to look deeply by slit lamp for any evidence of uveitis as a supportive evidence of sarcoidosis when the picture is not typical. And uveitis is early and frequent manifestations. Most of the uveitis occurs early, within 1 year. And anterior uveitis seem to be more common in of African population or black population, and posterior uveitis is more common in white population. In our country, seem to be a mixture, and we have seen both anterior and posterior uveitis, and up to 10% can lose vision. And the uveitis here can be granulomatous and sometimes non-granulomatous as well. This is a nice, simple classification criteria. Any uveitis syndrome which is compatible and in any anatomic region with the evidence of tissue, evidence of non-cacheating granuloma or bilateral adenopathy on chest X-ray. If this is satisfied, you can make a diagnosis of sarcoid uveitis. And HRCT is much more sensitive in picking up diseases which are not obvious in the chest X-ray. Treatment again is steroid and intense steroids initially, and try to taper off by 6 months. And methotrexate is the drug of choice with azathioprine, mycophenolate, and cyclosporine, and nowadays anti-TNF, which can be useful as a steroid-sparing drug to control the inflammation. IBD, Professor Biswas did touch IBD. IBD is a rare cause for uveitis, up to 0.3% in many series have IBD. 0.3 to 3.5% of the uveitis can be due to IBD. Crohn's is more commonly associated with uveitis than ulcerative colitis. And it can be both anterior and posterior uveitis. And ulcerative colitis is more likely to have posterior uveitis. And it can be chronic, bilateral, female much more common in contrast to B27 associated uveitis. And there is a one unique syndrome where erythema nodosum, sacroiliitis and uveitis can occur, which is again can occur with IBD. Smoking generally is protective for IBD, but IBD guys who smoke are more likely to get uveitis. And treatment is again steroids initially, sulfasalazine, cyclosporin and anti-TNF. Anti-TNF works for both. Here we look at both the domains. Methotrexate can be a good drug for uveitis, but it is not a very good drug for the gut involvement. So anti-TNF is one drug which can work for both the domains. And I can't stop talking about microbiome, and Professor Rosenbaum did give you an elaborate lecture on elaborate talk on microbiome and autoimmune diseases. All autoimmune diseases probably have microbiome as one of the causes. We all knew from good old days that intestinal permeability is one of the causes for autoimmune diseases. We didn't know how it causes. Now we know that leaky gut, which was popularized by popular media, contributes to leaky gut is due to many reasons. Even NSAIDs can cause leaky gut. Many pro-inflammatory food can cause leaky gut, and which can change the microbial pattern. And so many microbial products get exposed to the circulation, and which can be picked up by T cells. And the T cells, if the antigen mimics uveal antigen, they can travel into the eye, particularly when the blood retina barrier is broken due to any other reasons like COVID infections, trauma, stress, sepsis. The antigens, these T cells get entry into the uvea and can cause autoimmune uveitis. So many so-called unidentified presumed autoimmune uveitis may have this as one of the cause. Psoriasis, again, I told you earlier, and we should look for psoriasis. Need not be psoriatic arthritis alone. Psoriasis itself has been associated with uveitis in a small percentage of patients, 2%. And methotrexate and anti-TNF, which we use to treat psoriasis and psoriatic arthritis, can cause paradoxical uveitis. And psoriatic uveitis is chronic and bilateral, unlike HLA-B27 related uveitis. And it can be anterior, and though 20% to 40% can develop uveitis. And axial spondyloarthritis patients, sometimes they develop what looks like initial HLA-B27 type of uveitis can become bilateral over time. So the phenotype of uveitis in psoriatic arthritis and psoriasis seem to be subtly different from HLA-B27 related uveitis. And methotrexate can be useful, anti-TNF is useful, and ustekinumab also may be useful, but the other drug which we use, secukinumab and etanercept, are not useful to prevent or treat uveitis in psoriasis. And BKH is supposed to be very common in India. I'm sure Madam and Biswas would agree with me. Compared to other countries, in some studies, up to 20% of the uveitis reported were due to BKH. It is a granulomatous uveitis, and it has very typical eye findings. So we always get the patient as BKH syndrome to us. And it's interesting to know that it has got 3 phases: prodromic phase, which is probably would be missed as any viral disease, dizziness, eye pain, photophobia, headaches, meningeal signs. They may go to a neurologist, may end up in a medical unit. But if you do CSF, you'll have a pleocytosis, there is a meningism. And an ophthalmology evaluation at the time might pick up some uveal inflammation and may help us to diagnose. But many times these patients may not even get an ophthalmology reference because it is self-limiting disease. It can last hours to weeks. The acute phase is generally characterized by panuveitis. during the chronic phase, this is a time the patient develop extraocular manifestations. So we, as a rheumatologist and physicians, we may have an opportunity to see these patients. Some of them may develop what look like autoimmune hearing loss, tinnitus, dysacousis. So if a patient whom you are treating as VKH develop these symptoms, give it a meaning rather than referring them to ENT and forget about it. And of course, depigmentation, vitiligo, poliosis can be a feature. And I have seen only 2 patients with who had a diagnosis of VKH who are following. One patient had a deep vitiligo pigmentation in the eyebrow and another had extensive vitiligo. And treatment is immunosuppression, methotrexate, cyclosporin, mycophenolate, azathioprine, anti-TNF, all are used. And the first line is methotrexate and mycophenolate. So mycophenolate has become almost the first line of anti-uveitis immunomodulators along with methotrexate. This I will skip. Professor had already discussed. As a physician, it is essential for us to talk about drugs. Any disease, if a clinician keeps drugs in the differential diagnosis, it also always helps. If somebody comes to me with musculoskeletal symptoms, if I think whether he was on any drugs which can cause that, it helps in differential diagnosis. There is something called Naranjo score, which is used to give importance. Higher the score, more likely that this drug can be associated with the disease. Cidofovir, which is an antiviral used in CMV retinitis and also for CME infections, both by oral and intraocular route. This has been definitely associated with uveitis. So if you are treating somebody for CMV retinitis, they develop another uveitis or a new type of uveitis. It could be due to the drug. Rifabutin, which is used in Mycobacterium avium intracellularis complex. Some of the sulfonamides, sulfasalazine, can be a cause of uveitis. Bisphosphonates, particularly pamidronate and zoledronic acid, can be associated with uveitis. These are a strong association. And anti-TNF, etanercept, has been associated with paradoxical onset uveitis, much more than other drugs. Fluoroquinolans can be a cause. And should not forget the new kid in the block, checkpoint inhibitors. These checkpoint inhibitors used by oncologists has revolutionized many cancer treatment. Hitherto uncurable cancers have been kind of cured with checkpoint inhibitors. They can produce so vast, so variety of autoimmune manifestations because by mechanism, we are unleashing our own T cells to attack the cancer cells. When the T cells, if there is a predisposition for autoimmunity, they can go and cause the autoimmune diseases which are they known to cause. And even the intraocular therapies, intraocular steroids are known to be associated with uveitis, and metipranolol, which is supposed to be a drug used for glaucoma, can also cause uveitis. These are few examples of checkpoint inhibitors causing uveitis. VKH-like syndromes, Behçet-like syndrome, and uveitis has been associated with many types of checkpoint inhibitors. So here, we should be, ophthalmologists and rheumatologists should be prepared. As more and more oncologists are going to use this drug, we are going to see autoimmune manifestations of these diseases. TINU is very rare, and I see that Ratnam's name here. In her studies also, TINU, there were no TINU cases in her series. TINU is rare, more common in children. Probably pediatric ophthalmologists or pediatric oncologists might be seeing few patients, maybe under-recognized. And every patient with tubulointerstitial nephritis, if they look intently for uveitis, some of them may have subclinical uveitis. And the presentation is generally bilateral sudden onset uveitis, and rarely other insidious presentation can occur. The diagnosis here is look at the creatinine, look at the urine. If a facility is available, look for beta-2 microglobin, which is a marker for tubulointerstitial involvement. And the treatment is topical, steroids, and immunomodulation only in refractory cases. Lupus ANA is because ANA is routinely asked test. That's why I included lupus. Lupus is not a common cause for uveitis. Lupus eye manifestations are predominantly dry eyes, sometimes cotton wool spots, and retinal vasculitis. And ANA test is again 5% of the population, depending upon the age group. Up to 20% of the population can have ANA positive. It has got a poor positive predictive value for SLE, particularly if you do this for uveitis purpose. So the routine ANA test is less productive, and very rarely it can be the first manifestation of lupus. So if you see uveitis, and if the uveitis is predominantly posterior uveitis, retinal vasculitis, if the patient has got lupus-like features, then we should go extensively looking for lupus. And lupus eye disease can be a marker of SLE, generalized SLE disease activity as well. So to conclude, ladies and gentlemen, there are many differential diagnoses to think beyond HLA-B27 and spondyloarthritis. There are few unique diseases with unique pathophysiology and very unique treatment modalities, sarcoid, Behçet, and VKH. And since uveitis can be the presenting manifestation of systemic autoimmune diseases, we need to be watchful for autoimmune rheumatic disease on follow-up. Idiopathic group is still the largest. New associations are being identified. As a rheumatologist and immunologist, we are well placed to look for new autoimmune diseases in these patients. So both rheumatologists and ophthalmologists need to be vigilant for new clues and refer to each other, complement each other, and for the betterment of the patients. Thank you very much.
Thank you, Dr. Brahmanand, for the lucid talk. It was really fascinating and very interesting to talk, to listen to your talk on uveitis beyond SPA. And you nicely told about the subtle nuances in the presentation of the disease and differential diagnosis. And when the ophthalmologist refers the patient to a physician or a rheumatologist with anti-uveitis, a plethora of differential diagnosis comes to your mind, and he talked about how to approach all those conditions. If you have time, we can, 1 or 2 questions can be invited from the audience. Yes, sir.
It's so nice, sir. You have understood uveitis so much. You talk like an ophthalmologist. I really enjoyed your talk.
So
yeah,
right. I would want a clarification from you, because there are several ophthalmologists sitting here, about how do we screen for sarcoidosis? Because the general tendency to screen for sarcoid amongst the ophthalmologists is to simply order serum angiotensin converting enzyme. I think we tend to forget one point, that if we test for serum AC among 100 patients with biopsy proven sarcoid, probably all of them are going to end up with a high serum angiotensin converting enzyme. On the other hand, if we test 100 patients of uveitis, trying to screen for sarcoidosis, the positive predictive value of this serum AC is very, very low, less than 20%.
Yes.
So if you can clarify the screening of sarcoid, because it's a very common cause of uveitis among.
Yes. Fantastic question, sir. Thank you very much. And ACE levels is not diagnostic. ACE can go up in tuberculosis. It can go up in diabetes. Simple uncontrolled diabetes can have higher EC. And ACE is generally produced by lung granuloma. Unless typical lung involvement is there, we don't expect a high levels of ACE. So ACE can be normal, and patient can still have sarcoid uveitis. So that is one thing. So if you suspect sarcoidosis, the simplest first measure is look for sarcoidosis elsewhere. So elsewhere is where look at the lymph nodes. Look at the particularly the cervical lymph nodes, particularly supraclavicular lymph nodes. Dip your eye into the finger into the clavicle. Sometimes you find a nice supraclavicular lymph node that can be easily biopsied. And look for lymphadenopathy. Auscultate the chest and look for any history of erythema nodosum in the past. These are, and look at the pulse rate. There can be sometimes undetected cardiac sarcoidosis in patients with uveitis. If this patient has got bradycardia, this irregular heartbeat, that can be a clue. So look at the clinical features. Then simple chest X-ray will be a screening tool. If it shows bilateral hilar adenopathy, prominent lymph nodes, I said the diagnosis is done there. Then we need a HRCT or something like that, look at the extent of sarcoidosis. Yeah, if this suspicion, if the eye is very typical of sarcoid uveitis, your chest X-ray looks normal or looks ambiguous, then we can do a high resolution CT scan of the chest. Ask the radiologist look for the mediastinum as well. Sometimes when they do HRCT, they miss the mediastinum. So I always ask for HRCT lungs with a mediastinal window. And contrast is not always required. They can pick up the mediastinal lymph nodes. Extensive bilateral mediastinal lymph nodes, plus or minus lung involvement is sarcoidosis. And if you have done a manto for any purpose, manto will be negative in sarcoidosis. So that is, it look like differential diagnosis between sarcoid and tuberculosis. Manto negativity can be a minor supportive role, not a major. Don't rely on that. ACE levels, manto negativity are minor supportive role. And the histopathology is the diagnostic kind of 100% diagnostic method. In the absence of that, bilateral hilar adenopathy can be very diagnostic. Sometimes we go ahead and treat based on that only when that diagnosis is difficult. Our patient refuses transthoracic biopsies. Hope I have answered the question.
Thank you, Dr. Dharmanand. I think we are getting delayed. The session is running late. If you have anybody has any question, you can mail the question to him, or we can write it down. We can discuss in the lunch hours. And with that, I think we'll wind up the session.
I would kindly request Dr. B.G. Dharmanand to be on stage. Can I please request Dr. Ajit Suryan and Professor Dr. Chandan Das, please felicitate Dr. B.G. Dharmanand, sir. I would like to kindly request Dr. Dharmanand, sir, to please give a token of appreciation to Dr. Ajit Suryan and Professor Dr. Chandan Das. Thank you, Dr. B.G. Dharmanand, sir, for such a wonderful session. Now I would like to request for the next session, Chairpersons Professor Dr. Bharat Panigrahi and Dr. Manoranjan Behera to please come to the dais.
Okay, good afternoon. So now we'll have the session 4, that is approach to retinal vasculitis, how to explore systemic causes. So the speaker is none than Dr. Basu. So Dr. Basu, please. So it's my privilege to have with Dr. Basu today. We have worked for about 5 to 6 years in Prasad ICU Bhubaneswar. And you know, this retinal vasculitis is again another important problem, which again for the rheumatologist and ophthalmologist, there are many systemic disease associations, and we'll hear from Dr. Basu and they will discuss. Now I request my co-chairpersons, Dr. Manoranjan Behera, to introduce Dr. Basu.
Dr. Basu is very known to people of Odisha. Is the uveitis and retina consultant at LV Prasad Eye Institute, Hyderabad, India, and head of the uveitis services of LV Prasad Eye Institute network. He received his medical training from the University of Mumbai, followed by Retina Fellowship at Sri Ganapati Netralaya Janala and LV Prasad Eye Institute, Hyderabad. He has also completed 3 research sub-articles with Professor Narasimha Rao and Dhoni Eye Institute 2010, Professor Jay Ambati at University of Kentucky, and Professor Lalita Ramakrishnan at University of Cambridge, UK. He has received multiple competitive research grants, mostly recently the Deputy Wellcome Trust Intermediate Fellowship in Clinical and Public Health Research. He has published widely in peer-reviewed international journals and certain national journals. He has also been the principal investigator for several multi-centric clinical trials. Over to Dr. Basu for his talk.
Thank you, Dr. Behra and Dr. Panigra. It's such a privilege to be back here in my professional hometown, Bhubaneswar. I've grown up in this place from 2006 till 20, and it's also a privilege to be talking in front of such luminaries from both rheumatology and ophthalmology, especially my teachers here, Dr. Biswas and Dr. Ratnam. It's a huge privilege, and I thank Dr. Parida for considering me for this talk. This is a relatively short talk that I have with me. I'll finish in half the time, which will help the organizers cover some time, but also it will give you a little more time to ask questions, so I look forward to that. So how to exclude systemic causes? So let's understand what is so special about retinal vasculitis. It's one of the most common forms of intraocular inflammation. Isolated retinal vasculitis without any other disease alone accounts for 10% of all uveitis entities. And besides that, there are several forms of posterior and pan-uveitis which also come with retinal vasculitis. So it's a very common entity that you'll find in an ophthalmology practice. Now, what makes retinal vasculitis unique? And there was a discussion on this from Dr. Dharmanand, that we are able to see what we are talking about. Now, while in rheumatology there is a facility to biopsy the tissues, whatever we are trying to treat, here we are able to see what we are talking about, and that is a major privilege. And also, there is a frequent association with both infections and systemic disease. Now, how is it different? These entities, infections and systemic diseases, are not very common in systemic vasculitis. So, there is only a rare association between systemic vasculitis and retinal vasculitis. Now, this thing has to be understood both by the rheumatology as well as the ophthalmology groups. Because we tend to think that whatever is causing, be it the ANCA-associated vasculitis or the other vasculitis, whatever is causing that in the rest of the body will also cause the same in the retina. It doesn't work like that. And the best example we heard Professor Rosenbaum start the meeting today. And so I selected a paper that he published and his group in about 10 years ago, that patients with retinal vasculitis rarely suffer from systemic vasculitis. So testing for ANCA just because the patient has a retinal vasculitis probably doesn't make much sense. Because while in his practice, almost 15% of the patients had retinal vasculitis, only 1.4%, 3 out of 207 patients of retinal vasculitis, and that too in a non-TB endemic country. Okay, just 1.4% of these patients had any evidence of systemic vasculitis. So I think this is a very, very important point that needs to be passed on to the audience here today. So how do you approach a patient? The first thing that you think about is what type of vessel are we dealing with? Because that will have a major impact on what kind of etiology you are going to treat. So is it primarily affecting the arterioles or the veins, or both the arterioles and veins? Then what is the size of the vessel that are involved? Now, all retinal vessels, irrespective of the level of branching, they would be classified as small vessels if we go by the Chapel Hill classification. But There would be different sizes of vessels that are involved. Sometimes the capillaries are primarily involved. Sometimes the larger vessels are primarily involved. Then the morphology of the infiltrates, and I'll come to that later in the later slides. You know, what is the extent of the perivascular infiltrates that you're looking at? And finally, and probably very importantly, what are the associated ocular signs? We cannot look at retinal vasculitis in isolation. We have to look at what is coming along with the retinal vasculitis. And just like any other uveitis entity, this is how we are going to make the diagnosis. And then what are the associated systemic signs? We are just hearing about erythema nodosum. We are hearing about, you know, sarcoid in other parts of the body. So these are, you have to look at the patient as a whole when you are looking at retinal vasculitis. First, we take up type of vessel that is involved. Now, most of the retinal vasculitis that we see in our practice is involving the retinal veins. And the two most important differentials when the retinal veins are primarily involved are tuberculosis and sarcoidosis. And also in some cases, Behçet's disease. It does affect the larger vessels as well. But TB and sarcoid are predominantly the most common etiology that you will associate with retinal vasculitis in our practice in India. When it's a primarily arteriolar involvement, the most important thing that we should rule out is that, is there a focus of retinitis hiding somewhere? Because those are the infectious retinitis cases that most commonly involve the arterioles. And therefore, ruling out viral retinitis or a toxoplasma retinitis will be very, very important. Really, the systemic vasculitis such as SLE or polyarteritis nodosa may also affect the arterioles. And finally, when it's a mixed involvement, the most important differential you have is Behçet, but the ANCA-associated vasculitis also very, very rarely can have a mixed vascular involvement. Now, let's look at the morphological patterns of retinal vasculitis. Now, I'll come to the slides in the next. Can we reduce the light, please? Right. So, the important things to note as far as the morphology is concerned is whether it's a skip vasculitis or whether it's a confluent vasculitis. I think the names are very indicative what kind of infiltrate you're looking at. And thereafter, patterns such as chireles, frosted branch, or occlusive vasculopathy, all of these will give you a specific diagnosis. You see, till now, I have not discussed about, you know, what blood tests to do in a patient of retinal vasculitis. These are all about clinical signs. Now, these are some of the morphologies that you see in the picture here. If you see the first one, this is a skip vasculitis. Yep. So when there are just patches of vessels involving the involved there, the other one that you see there is a confluent vasculitis where the entire stretch of the vessel is involved. Now, either of them are not going to tell you a diagnosis, but at least you can see the extent of inflammation that is there in the eye. Then there is a frosted branch angiitis, which is classically associated with CMV retinitis, but can also present in many other forms of infections. And there's a hemorrhagic vasculitis, which you see when there's a vascular occlusion, you see such kinds of hemorrhagic vasculitis. Now, chireles, as you can see, it's not a true inflammation of the blood vessels. There are plaques, intraluminal plaques that are formed there, which give rise to the chireles appearance. Now, these plaques are very well seen in the inset that you can see in this picture. They typically appear when the retinitis is resolving. That is when you get to see these chireles plaques, not indicative of any particular diagnosis. And they can be associated with any kind of infection, including the infectious retinitis. Now, besides those conditions where you see perivascular infiltrates, there are also inflammatory vascular involvements where you do not see obvious perivascular infiltrates. And these can come in a number of different diseases. For example, occlusive vasculopathy can occur in SLE. It can also occur in Takayasu arthritis. The picture you see here is of Takayasu. There is no perivascular exudation, but there is a gross retinal hypoperfusion, in this case also involving the macula. Now, this is another example which is for the rheumatologist to see that this is something that you will never, have the, privilege of seeing, which we can do by doing a, fluorescein angiogram and seeing what exactly is the area of perfusion of the retina, or how much of the retina is involved in a case of retinal vasculitis. The, the causes apart from SLE can also be, and Takayasu can also be the Susak syndrome, where there would be sensory neural deafness in the patient. The other pattern, and this is a very eye-limited pattern, there's nothing elsewhere in the body. There's no blood test where for this kind of patient, is called as IRWAN, idiopathic retinal vasculitis with aneurysms and neuroretinitis. The perivascular infiltrates you can see here all around. So those are the perivascular infiltrates, mainly involving the arterioles. Young, healthy patients, females more than males. The thing to see again in the fluorescein angiogram that you can make out there is, I can't use a pointer unfortunately, but you can make out the aneurysms there. You can, within the circle, which will tell you that you're dealing with an IRWAN. Also very characteristic of this particular condition are the macular exudates, very dense macular exudates, which are the primary cause of loss of vision in these patients. A very eye-limited condition with nothing to do with anything elsewhere in the body. Now, once you have determined the morphology of the retinal vasculitis, the next thing you would want to do is to look at other ocular signs. And this is very important for my ophthalmology friends who are sitting here. This is what is going to lead you to the diagnosis. You are not going to depend on a Montu test or a serum AC or whatever to make your diagnosis and treatment of the patient, or a HLA-B51. So the first picture is I take is for tuberculosis, probably the most important cause of retinal vasculitis in our population. Okay. These are the clinical signs. Some of them are described by others, but we published a paper a couple of years ago in Retina where we combine all of these clinical signs. The most important clinical sign, which will tell you that it's TB in a TB endemic country, is the presence of these subvascular lesions. No pointer here, but I think you can see the lesion. Sorry about that. So the lesion overlying the blood vessel, it could be active, if you see along the supratemporal arcade, an active retinitis lesion. Remember, these are not choroiditis lesions to start with. They start off in the retina, and we have shown that on histopathology as well by doing a biopsy of the retina, that these are intraretinal granuloma. Now, it could be typically active if you see along the supratemporal arcade, but most cases we come across these lesions where the choroid has also been involved and the lesion has healed. So you see those pigmented scars along the blood vessels. Okay, so these are two clinical signs. The moment you see them, you should really be chasing the diagnosis of tuberculosis in these patients. Many of them may turn out to be Montu negative. This was alluded by Dr. Biswas as well, that just because they are Montu negative, we should not rule out TB completely. We have had patients who are Montu negative, and then we did a quantiferon that turned out to be positive. We have had patients where both were negative, but on careful history taking, we found out that the patient had a strong risk of TB contact. It could be a migrant worker. It could be a patient, who had a TB, active pulmonary TB in the family. So all of those things, you really chase for them and make the diagnosis of TB in these patients. On the other hand, and we have discussed this in the previous presentations as well, if the clinical signs are telling you something else, I'll come to Behçet a few slides later. The clinical sign is very suggestive of Behçet, and you do a Montu to make a diagnosis of TB, and then the Montu turns out to be 20, 30 millimeters, anything, you're going to be distracted in the wrong direction unnecessarily. So this is a very important point that I hope my ophthalmology colleagues will take from here. Now, apart from the subvascular active or heal lesions that you see in the picture, the other things that might be indicative of TB and not necessarily seen in TB alone are occlusive vasculitis, which of course can be seen in many non-infectious conditions as well. And a new sign that we have reported, which is called as focal vascular tortuosity, which you see along the inferotemporal arcade in the lower left picture or the lower right picture. And this is much better seen when we see it in a red-free picture, the tortuosity within the area of vasculitis. That is very suggestive of TB. Again, in a TB endemic country, you're not going to depend on that for TB in non-endemic countries. So from TB, we move on to sarcoidosis, a very important cause of retinal vasculitis, but surprisingly, not a very common cause in our population. I think, you'll agree as well that most of our sarcoid patients come with anterior uveitis or intermediate uveitis rather than retinal vasculitis. So the signs you will be looking for, apart from retinal vasculitis and the textbook picture of candle wax drippings, typically non-occlusive retinal vasculitis, are these discrete hypopigmented patches, typically in the inferior fundus. You see that, think of sarcoid. Again, you see granulomatous anterior uveitis coming to you with peripheral anterior synechiae. If you see peripheral anterior synechiae as against posterior synechiae, again, a major indicator towards sarcoid, and that should be your, direction of thought. Behçet, not as rare as we think it to be, not always a silk root disease that you have to see it in, patients from that part of the world. You see it in any population in India as well. Typically involving the capillaries, you see the fern-like pattern that has been described in the textbooks for Behçet disease, and the mobile hypopion that you see in that picture, typically in a white eye. You don't see a red, painful eye, but a white eye with a mobile hypopion. Very explosive onset, but between the diseases not going away completely. There is kind of a smoldering inflammation that still remains in the patient. The other thing to remember is this is probably the only cause of non-infectious cause of retinitis. So if you see retinitis lesions with this kind of a picture, again, think of Behçet. Of course, the retinitis in Behçet is very transient. It will come and go. It won't remain for you to see when the patient comes back for a follow-up visit. So these were the associated ocular signs of the 3 most common causes of retinal vasculitis in our practice. But it's important that we don't forget when the retinal vasculitis is secondary to a retinitis lesion. For example, this was a patient who was seen by one of our fellows who saw the perivascular infiltrates that you see in the inferonasal quadrant there, but who did not see carefully for that retinitis lesion next to a pigmented scar in the supranasal quadrant. If we miss that, we'll miss the true cause of retinal vasculitis, which is actually a clinical diagnosis here, toxoplasma retinochoroiditis, and you have to treat the toxoplasmosis. This does not need a blood test for your confirmation. Sorry. This patient, now we have been talking about systemic vasculitis. Of course, it does affect the retinal vessels as well. This was a patient who came to us very recently. The left eye already had poor vision due to an old central retinal artery occlusion. The disc was totally pale. And the right eye had very small infiltrates, which I can't show you with the pointer now. The patient had already been diagnosed as anti-PR3 ANCA-associated vasculitis. When we did the angiogram, we see that there are multiple focal points of leakage along the posterior pole and also in the supranasal quadrant. So this is not the classical picture of retinal vasculitis that you typically see in your clinic. But yes, the vessels are also involved in ANCA-associated vasculitis. So how do you combine all of these points that we just learned to make the etiological diagnosis of retinal vasculitis? Let's look at the picture which I showed earlier. Now, if you see this picture, the most important vessels involved here are the veins. So it's predominantly a retinal vasculitis affecting the retinal veins, phlebitis. So that, puts you in a certain direction. Next thing you see, what are the sizes of vessels? Of course, if you look at the branching, you see vessels of the first order, second order, and even the smaller capillaries also involved here. Then the morphology is mainly skip and confluent vasculitis. There are some patches here and there, but there are also, if you see in the infranasal quadrant, the large confluent areas of vasculitis as well. So different levels of severity. But the most important thing here in this picture is the associated ocular sign, which are the subvascular lesions that you can see here pointed by the arrows. Some of them are healed. You see lower down, it's a healed subvascular lesion, whereas on the supratemporal quadrant, it's still an active subvascular lesion. So this really tells you what you're dealing with, and then the role of the blood test is quite limited. So these, this patient incidentally had a positive Montu test and a history of TB contact and a negative TPHA. Remember, the diagnosis of TB is not complete till you have ruled out sarcoid and syphilis. Okay, so a negative TPHA with these tests, then you know that you're dealing with tubercular retinal vasculitis, and treat the patient accordingly. So treatment is quite very straightforward. If there is an underlying infection, remember we told that unlike systemic vasculitis, retinal vasculitis is commonly associated with infection and systemic disease. So you treat the underlying infection, use anti-inflammatory therapy, including corticosteroids and non-steroidal immunosuppressives. And unlike other forms of uveitis, this very commonly requires some form of ancillary therapy, such as intravitreal anti-VEGF or corticosteroid injections, laser photocoagulation if it's a occlusive vasculitis, and pars plana vitrectomy. So this is one case where this was a TB retinal vasculitis that we had seen like this at presentation, and with 4 months of anti-TB therapy alone, the perivascular infiltrates and the macular edema has disappeared completely. So these are the points I hope you'll be able to take from this presentation, that retinal vasculitis is commonly associated with infections and systemic diseases, but rarely systemic vasculitis. The approach is looking at the type of vessels, what veins, arterioles, or mixed size of vessels, morphology. Please remember the associated ocular signs and also look for the associated systemic signs. There are different morphological appearances, some of which may actually tell you the diagnosis, such as Irwan, Chiariles, arthritis, and the associated ocular signs can also help you reach the diagnosis. The treatment is not only for the inflammation, but also for the complications. Thank you for your attention, and I invite all of you to the Uveitis Society of India annual meeting, which we are doing at Hyderabad between 14th to 16th of October this year. Thank you again.
Thank you, Dr. Vasu, for your nice talk. Yes, you are right, because during my association for the 9-10 years, what we have also found, because most of the time it is very difficult to diagnose that is systemic associations, because the ophthalmologist will give the clue. So unless, because we can't see the eye, we cannot justify, we can analyze the findings of the ophthalmologist, but the ophthalmologist will give the clue what are the real possibilities, because our own government of India recommendation is also there that if there is a highly, because ocular tuberculosis, there is no way to take any tissue biopsy and diagnose. So Government of India has also told that if there is a high suspicion of tuberculosis, ocular tuberculosis, you can treat with ATT. So that's why this tuberculosis, what Dr. Vasu has told, in most of the cases, we give ATT on the higher suspicion of tuberculosis by the ophthalmologist. The other thing, systemic diseases, yes, we evaluate, but very rarely we get association of the systemic disease unless somebody is suffering from some systemic disease and comes to us with retinal vasculitis, then that is different. But if a healthy person comes with retinal vasculitis, then the association of systemic disease, we evaluate whenever they give a suspicion that I suspect Behçet's. We evaluate on Behçet's, but we really found any association disease. That is what Dr. Basu has also told. So,
yes, you have very clearly told that retinal vasculitis is not synonymous with systemic vasculitis, and you have to see both the involvement of the artery, veins, or mixed, the skip lesions, confluent lesions, or the continuous lesions, and associated with other ocular signs and systemic signs, and investigations you have to add up of that. We already know that infections are the predominant cause of retinal vasculitis, like CMV, tuberculosis, syphilis, HIV also, and herpes virus, toxoplasma, and certain systemic disorders, both rheumatic, non-rheumatic. And another thing is leukemia-associated retinal vasculitis. You have not touched that. What is your opinion about leukemia-associated retinal vasculitis?
Those are not true retinal vasculitis. They come with different kinds of presentations.
Common classification.
Yeah. So you see different types of hemorrhages. Actually, leukemia doesn't have any single presentation that could be called as a leukemic vasculitis. But you see something called as Roth spots in the fundus. You know that will suggest a leukemic involvement. And again, looking at the patient profile, you know, very young patient, then you start thinking about leukemia.
Another important thing you told that regarding TB retinal vasculitis, local vascular tortuosity, whether that is associated with other manifestations or that is the sole manifestation.
No, it's usually associated with other findings. So this is something we noted when we were treating these patients. So these tortuosities are not associated with any focal ischemia. So these are just within the area of perivascular infiltrate, and they straighten up once the treatment goes on. So this was something we noted in our patients and we reported.
Thank you. Now the open for a few questions from the audience.
Yeah. Just like to ask you a question. See, I read when I was doing work on Hughes disease, Miles Stanford and Elizabeth Graham from St. Thomas Hospital from UK, they described about 200 cases of idiopathic retinal vasculitis. I don't know. When I try to look into that one and label them as well, idiopathic retinal vasculitis, majority of them I find either manifest positive or they have got foci of even they develop neovascularization, bleeding, that is what we call as the Hughes disease, which turns out to be the most common retinal vasculitis in our Indian subcontinent. I didn't find that kind of disease what they are describing in the literature. Those time about 200 cases. So what is your comment? Do you think still idiopathic retinal vasculitis is a good chunk?
So thank you for the question. Actually, I would rather prefer using the term undifferentiated rather than calling it idiopathic. Because one thing that we always believe on is that uveitis is a disease that always evolves. It will evolve in the eye and it will evolve in the rest of the body. And I remember a conversation with Ratnam Madam almost 13-14 years ago. And we're talking about similar patients in whom we could not make a diagnosis. So she told me at that time that do not call it as eels or idiopathic straight away. You keep watching the patient. You know, sometimes a patient with retinal vasculitis will, after a few years, come back with mouth ulcers, which will tell you that, you know, what was the cause of retinal vasculitis. or some other clinical signs, which will lead you to diagnosis. There's no one single point diagnosis that can be made in these patients.
Good answer. Excuse me. Good afternoon, Dr. Vasu.
Yeah.
Recently, I came across a case, a young female developed a recurrent anterior uveitis just 3 to 4 days after undergoing barrage laser for lattice degeneration. I did not, so I want to ask whether we can call it a coincidence, or do you really come across this type of cases of uveitis after laser?
Yeah, so there are two levels to answer that question. One is that laser itself induces inflammation, but then why should it induce inflammation only in the anterior segment and not in the posterior segment where the laser is being done? So offhand, it's very, very likely that it was incidental, that the laser happened and the patient also developed a anterior uveitis. But the other way to think about it, and it's very, very arguable, is that the laser disrupts the blood retinal barrier. Okay, when you do laser, so that has a risk of inducing autoimmunity in these patients. But then again, if there is autoimmunity, it will cause inflammation in the posterior segment and not in the anterior segment.
Yes,
so mostly incidental.
Yes, I forgot to add she has also very few 1 to 2 snowball opacity in the pars plana, nothing else in the posterior segment. Only
Yes, I think we should investigate the patient on those lines rather than associating with the laser.
Lasers. Thank you, sir.
Okay, last question.
Yeah, I think, quantiferon, this question would have come up several times in several meetings, but quantiferon is not telling you something additional more than the MON2 test. Where it's really important is that where you strongly suspect tuberculosis clinically, for example, the clinical signs I just showed, and your MON2 test is negative. I've seen so many patients being treated with steroids alone just because the MON2 was negative. And while sir mentioned about miliary TB as one of the causes of a negative MON2 test, a much more common cause is a poor quality tuberculin which was used for the MON2 test, or the injection being given subcutaneously instead of intradermally while doing them. So a poor quality MON2 test is itself going to give you a wrong result. And that is where quantiferon is very important, because you don't want to miss a diagnosis of TB in those patients. Same with supputinous like choroiditis. You don't want to miss the diagnosis. So you will do a quantiferon, but beyond that, it doesn't have any additional role.
So it has a very high sensitivity to pick up.
I think those issues are very, very irrelevant. Those blood tests or the lab tests are not telling you the diagnosis. The diagnosis is there in the patient's eye, and that's what you should be looking at.
Thank you, sir.
Yeah. Okay, Dr. Aman, give the mic.
Wonderful presentation, Dr. Basu. I'm Aman Sharma from PCI. Yeah. Just to add, I think if you look at the WHO recommendations also, these all IGRAs are not really supposed to be used for the making a diagnosis. So I think you just have to, as has been beautifully explained, to look at the total context.
Even they are not giving importance to MON2s, rather they tell chest X-ray and ESR. What they told in Indian scenario, because MON2s may in all patients can come positive like that. So what will you say?
I think this is a debate that we cannot get through now.
But Dr. Vasu, what you told actually, we know we got to know 2 to 3 points new. That like subvascular, that retinal inflammation with scar and that tortuous vessels. So look into that, can we start tubercular antitubercular drug if all are negative, like MON2 negative, quantiferon negative, ESR in normal range, chest X-ray negative. So because pulmonary medicine colleague asked us, if you tell, we'll start.
Yeah, I think.
So I want to know that, because we are in a multi-specialist hospital. So
you've already given the answer. If you tell, they start. And that's how it should be. Many of us, we refer to the patient about your opinion for starting anti-TB therapy. The opinion will not come from the pulmonologist or the physician. It has to come from the ophthalmologist that please start ATT. The moment we start asking for opinion, that's where the confusion happens.
It is very clear. Already I have told ocular tuberculosis is diagnosed only if the ophthalmologist highly suspects that this is a case of ocular tuberculosis, then we have to give ATT. And ATT now government of Odisha or government is giving free of cost. We write to CSC, PSC or district headquarters, please provide ATT to this patient of ocular tuberculosis. And they provide. So nothing like that. Let everything be negative. So that doesn't matter. So I think because of time constraint, we will close this session. Thanks, Dr. Basu.
May I please request Dr. Soumya Vasu sir and Professor Dr. Bharat Panigrahi and Dr. Manoranjan Behra to please be on the dais. Can I please request Professor Dr. Bharat Panigrahi and Dr. Manoranjan Behra to please felicitate Dr. Soumya Vasu sir. Now, can I please request Dr. Soumya Vasu sir to please give a token of appreciation to Professor Dr. Bharat Panigrahi sir and Dr. Manoranjan Behra sir. Due to the shortage of time, we will be skipping the tea break. I hope you have had your teas. Furthermore, to carry on with the program, may I please invite Mrs. Amrita Rai ma'am to come on the stage, please, ma'am.
Now it's time for our much awaited OARFT Tribute 2022. May I please request the legend in the field of rheumatology, ex-professor and HOD of SGPGI Immunology, an outstanding researcher and astute clinician, a man with a touch of magician, innumerable awards recipient, taught his students to be highly percipient. He delves deep into his patient psychology, inspiring students to follow his methodology. A great human of international recognition, Professor Dr. Ramanath Mishra, sir in himself is an institution. Sir, please come on the dais. May I please request Dr. Jyotiranjan Parida to continue with the proceedings.
So again, good morning all. So OARFT Tribute 2022. So this is something from our trust when we thought of this program. And when we talk about awareness, we always felt that we should also honor the people who have, the people who have given their everything to rheumatology. I think that will be the best thing. And when we have decided and when we have thought of this idea that who will be the best person whom we can honor, I think Professor Ramanath Mishra, who is my guru, mentor, teacher, he came to our mind and we thought not only in Odisha, I think his contribution to the Indian Society of Rheumatology is unparalleled. And his citations will tell everything about his academic achievements and everything. Here I am to introduce informally that what Professor Ramanath Mishra sir is for us. I have never seen a clinician like him. Actually, he has a very, very major impact on the lives and the clinical practice that he has taught. Whoever student have gone from him, I think There are many now starting their own departments, or they are now 60–70% of the rheumatologists, I think, in India now is students. And his association, I can tell one thing, how he can simplify medicine. One incident I can share because that I think can enumerate everything. There is one morning session in SDPGI where I was about to present the case, and I was in my first year. And that case was about systemic onset juvenile arthritis. There's a 7-year-old child, and Professor Mishra was the evaluator. He was the who will give me marks on my logbook. And I was very confident because during your DM and this post-graduation, you are very bubbling with knowledge. So I thought this is a very simple case. So I am going to score 8 out of 10 minimum. And after my presentation, which I thought I have done reasonably well, I have answered. He had just removed 8 and given me 2 out of 10. And the reason was his first question to me, you have described the history very nice manner, you have taken everything, but tell me, what is the name of the best friend of this little girl? I thought that has never been taught in our history. Now then you have not taken any history, because for a child of 7th or of class 2 or something, if you don't know the name of the best friend, that means you have not mixed with your child, you don't know about, you don't have any insight. So that day I was very unhappy because I got 2 out of 10, but later I realized that those 2 marks were so much important to my clinical practice. So for him, if you are taking osteoarthritis patient, it is not important how much deformity, how much pain, or how much swelling. It is very important that which floor that lady is staying, who is accompanying the person. And whenever in chronic disease we plan something today, you diagnose rheumatoid arthritis when the patient enters your room, because you are so much well versed with that hand. After seeing that hand, you know that this patient is rheumatoid. But what makes a difference is whether you are aware that patient can come for the second time to you. How many patients are taking that patient with a big taxi, or patient will be able to come in a bus. So I think those small things. So he had taught us that rheumatic fever, you'd never diagnose this from ASO titer. You never diagnose systemic onset JIA from ferritin level. You just remember, if the patient had gone to school in the daytime, this cannot be rheumatic fever. This is systemic onset JIA who is ill at night and going, because this is episodic disease. Forget about that beautiful evanescent pinky rose rashes. So those are the clinical, true clinician, although he has a very vast experience in the lab, because I think he's the very rare clinician in our country who have gone to do ELISA plating by himself, who have for myositis, antibodies and everything, reactive arthritis, cloning and everything. He had great laboratory experience. But for me as a clinician, what I have taught from, what I have been taught and what I have got from him is those one-liners, those humor factors. And he is a person, if you will sit in one OPD with him, you know the magic of medicine, you know how fun the medicine can be. So the art and science guru, I can tell him. So this is our great privilege and honor actually to give him the first OARC tribute 2022. So please have a great round of applause for him. And now I call Dr. Sakir Ahmed to read the citation. And I also invite Professor Dr. Aman Sharma, Secretary IRA, and Professor Dr. Jyotirmoy Biswas sir to give the felicitation.
The OARC Tribute 2022. Professor Ramnath Mishra has been a doyen of rheumatology education in India. Having completed his post-graduation from Utkal University, he strove ahead on a path not taken, never to look back again. He won the ICMR Talent Search Scheme and subsequently the Commonwealth Research Fellowship at the Arthritis and Research Council at the United Kingdoms. After working at the Kennedy Institute, Imperial College of Science and Technology with Sir Ravindra Maini, he returned to India. At the Sanjay Gandhi Postgraduate Institute of Medical Sciences, he helped set up the Department of Clinical Immunology that has given rise to numerous DM and PhD scholars over the last 30 years. His career has seen the best of science, including publications in journals such as The Lancet, development of tools such as the ITAS, the Indian Takayasu Activity Score, and work spanning from culturing fibroblasts in systemic sclerosis to metabolomic biomarkers in lupus. His path has been glittered with numerous awards, perhaps too few for such an illustrious career. Some of the most important include the WHO Scholarship at Oklahoma Medical Foundation, the Knoll Oration Award, the M.N. Pasi Award, Distinguished Teacher Award from CMC Vellore, the Samantha Chandrasekhar Award, the R.N. Rutt Oration, the Dr. S.R. Nayak Award for Outstanding Research. In 2019, he was elected as a Fellow of the Royal College of Physicians, London, and in 2019, as a Fellow of the Indian Academy of Medical Sciences. In 2021, he has been bestowed the honor of an APLAR, that is the Asia Pacific League Against Rheumatology Masters title. He has served as the president of the Indian Rheumatology Association and on the editorial boards of various journals. However, his students and friends know him best for the astute clinician he is. This, along with his love for teaching, has endeared him to generations of physicians. In this era of defensive medicine, he is a true inspiration for clinical acumen as well as truly translational research. We wish to congratulate him for his trailblazing life and thank him for his knowledge and wisdom he has bestowed on us and countless students worldwide. We wish for the best in his life so that he can continue to inspire and guide us.
And I'll request sir to bless us and tell some few words of wisdom.
Good afternoon, everyone. Actually, the citation was much heavier than what I thought. It is a pleasure to be with friends, colleagues, and sometimes I realize I don't deserve all these kind of words, because the real gratitude is being recognized by your colleague as a good human being. Rest is all whoever got the opportunity, as I did, they go in their path. I was not a very challenging or a brave person to start my own independent practice. like Inderjit does. Sometimes I feel we are victim of our brought up belongings or teachers. I was lucky to have teachers like Professor Malvia, Professor Maini, Dame Carol Black, and subsequently John Harley. And I believe very strongly that if you share what you know, and if you have the guts to tell that I don't know, that is helpful to patients. I have learned wherever I have become very stern and very adamant about my diagnosis, the patient suffered. It is better to see and treat. Whenever you meet a patient's problem, think that it is challenging you, and all these diagnoses that we have been talking about, the serological test, the Montu test, they have their limitation in making a firm diagnosis. And every day is a new day for learning. I enjoy with my colleagues, and I have been lucky to be at PGI Lucknow, knowing people, how difficult it is, how limited is sometimes our knowledge in interpreting clinical signs, course of the disease. So medicine is an exciting field. With these words, thank you, Jyoti, and every one of you here. It's a very humbling experience. Thank you.
Thank you very much, sir. It was indeed a very emotional movement. Moving on with the scientific session, I would like to request chairpersons Dr. Inderjit Agarwal and Dr. Manoj Chatrai to please come on the dais.
Well, Aman is a very dear friend. I mean, we can go on talking about him for an hour or so. You know, he is a great researcher, great teacher. He's marked his name in the field of rheumatology and in particular vasculitis. I think most likely he's got one of the largest series in the world for ANCA-associated vasculitis. So without further ado, you know, I would recommend that, you know, we should try and grasp as many things as possible in the field of retinal vasculitis from Aman. Thank you.
Good afternoon. At the outset, I'd like to thank Jyoti for this very kind invitation. And I'll also thank Dr. Inderjit Agarwal for a very generous introduction. I think over the 25-30 minutes or so, this is the outline of my talk. I'll introduce with some real life cases, then perhaps touch on the classification and etiology, and then also briefly touch on retinal manifestations, although that has been done previously. My job has been made easy by Dr. Basu. I think He's shown some beautiful pictures and some interesting cases. I hope you will enjoy the cases that I'm going to share with you. This was an MLA seen by Professor Amod Gupta, who would come with fever and this is a young girl with fever and diminution of vision, seen first in the uveitis clinic. And as you can see, Dr. Basu has shown that there was a focal vasculitis. Could we have these lights off, please? There were cotton wool spots. And then again, there were some hemorrhages and there was retinal infarction around the fovea. This girl, as a part of the workup, a mantu was done. And after the mantu, the girl started to have a rash over the malar area. And it was thought perhaps whether there was some kind of a BCG, the mantu reaction. But subsequently, she developed a florid malar rash. There was ANA positivity. ANA was 3+ homogeneous. And there was also progressive decline in the sensorium to the extent that she almost became comatose. CSF and MR and EPLA were negative. She had this classical malar rash and there was vasculitis over the fingers, and making a diagnosis of neuropsychiatric SLE with organic brain syndrome, which presented first time to the ophthalmologist with retinal vasculitis, was easy for us at that time, and we treated with steroids and cyclophosphamide. This girl did improve, and she's doing well. She's done her post-graduation and even pursuing a PhD program as of now. Vision has improved in the right eye. She developed optic atrophy in the left eye. So this is how these cases can present. Another case wherein she had a symmetrical polyarthritis, but she developed altered behavior to the extent that she was howling with pain, and she also developed decreased vision. There was I'm sorry for that. There was swelling of the eyelids. There was visual acuity was counting of fingers at 1 meter, and there was conjunctival chemosis. There were bilateral multiple flame-shaped hemorrhages in all 4 quadrants. You can see the disc edema, and then perhaps you might be able to appreciate this perivascular cuffing in this patient. This patient also had bilateral bulky heterogeneous extraocular muscles. I'm sorry, this laser is not helping me. And I think there was no signs of any infection. The ANA was positive, dsDNA was positive, low complements, APLA was negative. She did have some lupus nephritis. The patient was treated with methylprednisolone, cyclophosphamide. The edema did improve, but the visual acuity didn't really improve in this patient. In the first, the visual acuity improved in one eye, but in some of the manifestations, you might be able to undo some of them, but the other, you may not be able to help. Another patient presented to us with hemopsis, a sudden onset, bright red color associated with dizziness. In the past, this patient in childhood or early adulthood had seizures, DVT, then was detected to have oral and genital ulcers and eye vision with posterior uveitis, was only given steroids and colchicine and some methylprednisolone outside, not given the azacyclovir or cyclosporin combination on anti-DNFs. The steroids are tapered. Now the patient presented with this problem and had pulmonary artery aneurysm, which we are all aware that occurs with Behçet's. And in the eye, it was beautifully shown by Dr. Basu, and I think I'll probably try to highlight again. This is the fern pattern where the capillaries are involved. I mean, it's not the major arteries, retinal arteries or vein, but the fern pattern which is seen in Behçet's. This patient was subsequently treated with steroids and cyclophosphamide and well. And towards the next case, this was again a young male who presented with diminution of vision for 5 days with intermittent floaters. Visual acuity was counting fingers at ½ meter, and there was vitritis. And if you could see towards the right side of the disc, there is some focal vasculitis, and if you see superiorly, there is a diffuse involvement of the vessels and angiogram, and if you can see, there is a total cutoff of one side, and this is what you call as occlusive vasculitis. Perhaps the ophthalmologist can connect more with these pictures. And also to add to it, we were talking about TB. There was multifocal patchy areas of consolidation, tree bud appearance, and subcarinal nodes. And this was TB. So, lupus is very common, Behçet's, but infections, this spectrum has been touched by Dr. Basu. Our role comes into play because uveitis and rheumatology interface, and perhaps our seniors in PGI understood it more than Professor Bambri and Dr. Amod Gupta started the combined clinic, I think in early 80s, and it's still going on, that process, but that practice still going on. We've been shown that there is so much overlap, and that is why we are discussing this here. Dr. Basu has told you there can be various causes of retinal vasculitis. This is these are the broad major causes of retinal vasculitis, and we have been shown, and systemic inflammatory diseases do play a role, very important role in these. But we have to think about keep infections as also mimics of vasculitis, part of which has been touched. But again, starting off with infections, some of the new signs that the Hyderabad group has described has been touched by Dr. Basu. It is my duty to tell what the PGI group has shown and published. These are the broad presentations which are there in the literature. But as per our own publication in AJO, based upon the PGI data, broad-based posterior synecdoche retinal vasculitis with or without choroiditis, serpiginous-like choroiditis with latent, that is where the role of Mantoux or quantiferon comes into play, or manifest tuberculosis in endemic setting should make you think about ocular tuberculosis. We've not only shown this, but we've shown the multi-drug resistant tuberculosis on vitrectomy samples caused by TB per se, in treatment naive patients. In the subretinal fluid also TB has been shown in aspirates. So initially the thought was whether it's a epiphenomena or a reaction like reactive arthritis, or the TB bugs really are there. So from it being a reactive phenomena to really being an infection, I think we've traveled a long way, and talking about ocular tuberculosis itself perhaps would take a full session. But for those of you who are purists, you can look up, this was a classification criteria of intraocular tuberculosis that we published some years ago with Professor Amod Gupta as the lead. And there was some data shown on uveitis, and this is PGI data. Tuberculosis is the common cause as infectious, and HLA-B27 associated disease as the non-infectious cause of uveitis. And when we talk about retinal occlusive lesions, this again from our group at PGI, TB as infectious cause and Behçet's as the non-infectious cause, but the most common causes of occlusive retinal vascular lesions. I think it is very important to have own data. So it tells us the probability of having a disease. I think it's been touched upon by my previous speakers, and I won't go into the details, but we are all aware, and we must know that it's important to take history. Although, when we say that these things are common or these things are rare, it is always good to have a checklist, because given the size of our population and healthcare inequality, which is available, which is there all across the country, the clinics are likely to see some, there has to be a referral bias. And unless we tease out common and pick up even the rare, the patient is going to be at the receiving end. And that is why it is good to have these checklists there in your clinics, both for the uveitis clinics and for rheumatology clinics. And it's not difficult for the rheumatologists to pick these rheumatic diseases, but it is important for the ophthalmologists to have these signs and symptoms in the workup of their uveitis clinic files. I think it does help. Coming on to my specific topic, when we say SLE, this is the prototype retinal involvement with which the other rheumatological diseases are compared. I spent some more time on lupus. Potentially blinding ocular manifestations, prevalence depends upon what all you are looking for in various series. Well, the most important thing is they will generally have systemic manifestations, and many of them will have neuropsychiatric associations also, and it is pertinent for us to treat them aggressively, perhaps with cyclophosphamide if in a given clinical context. APLI is associated more with occlusive lesions, and there is a higher risk of retinal involvement. So unless we are looking for these, we perhaps may not work up for these presentations.
So mechanism of damage is microangiopathy, severe vaso-occlusive disease, vasculitis, and secondary hypertension. Microangiopathy is a milder form. You might just have cotton wool spots as I showed, or the microaneurysms which are shown beautifully by Dr. Basu. You can have hard exudate or dot hemorrhages. I'm just bringing these points up because of Dr. Dharmanan said that we have to get used to these. Many of our rheumatologists are not really very used to listening to these terms. Then there can be intraretinal hemorrhages and cotton wool spots. This is generally associated with a good visual prognosis. So if there are cotton wool spots or microaneurysm, don't be too much scared. But if you see something like this, where there is a severe vaso-occlusive disease, or there is a microembolization and which presents like personal like retinopathy, it's got a generally a poor visual outcome. The retinal vasculitis is clinically presenting fairly uncommon, but we may still see vascular sheathing. It's already been shown, and you might have their patient might be having lupus nephritis, may have hypertension, and the retinal changes might be coexisting because of the hypertensive changes also, which we are all aware. So all these things can be seen in patients with SLE. And most important for rheumatologists is that never forget that this might be, why it is important, if there is a subtle behavioral change, if there are, what we've seen in neuropsychiatric SLEs, patient might have some visual hallucinations or some auditory hallucinations or some change in the behavior before they go to full-blown organic brain syndrome, might be the time when you have to clinical pick up and treat aggressively before the patients end up there. But it is also important for us, both rheumatologists and ophthalmologists, that there is other side of the story also. Once you give the patient had multi-system involvement, more than one reason to give cyclophosphamide, given cyclophosphamide, coming back with loss of vision in one eye for 3 days, redness of the eye, no diplopia, no ptosis, no trauma, no lupus disease activity. But visual activity was hand movement at 10 centimeters. There was fibrin in the anterior chamber, suggestive of hypopyon, and there was yellow glow in the retroillumination, which suggested that there are some exudates in the vitreous. Wide field posterior segment photograph showed a yellowish white exudate at the posterior pole. After the post-pars plana vitrectomy, there was a large abscess, and you know what we got? There was an aspergillus fumigatus. So don't be in a tearing hurry to bombard with immunosuppression. Each time the clinicians, the rheumatologists must be in close sync with the ophthalmologist, because if we presume this is also part of disease activity and a bombard with more steroids and more immunosuppression, this is going to be catastrophic in such patients. Another patient, I'll give you an example of one patient and then perhaps talk about the rheumatic diseases. This patient came to PJ emergency with right lower limb DVT. He was a tailor. He was more bothered because the limb becomes swollen and he could not paddle the swing machine. Came to the PJ medicine emergency, and the residents noticed that there are oral ulcers, there were scrotal ulcers, there was superficial thrombophlebitis, there were erythema nodosum-like lesions, there was this is pseudofolliculitis. If you see carefully, it looks like a folliculitis, but there is no hair root. So this is pseudofolliculitis. And what the patient was not really worried was diminution of vision. He was more worried because of the swollen limb. And what the patient had was a hypopyon. There was a vitritis and peripapillary retinitis with hemorrhages. And also there was posterior hypopyon. So this was a patient with Behçet's disease, unless the physicians had picked up oral ulcers and asked about, many times the patient may not complain about blurring of vision, actually, unless you actively look for these. So that is why it is important for the rheumatologist to pick these up. So retina involvement is not only very common, but it is where it can be blinding unless we treat them very aggressively. Can lead to blindness in almost a quarter to even 30 to 40% or 50% of the patients. And it might be an initial presentation in almost 10 to 20% of these patients. Occlusive necrotizing retinal vasculitis with a chronic relapsing bilateral non-granulomatous panuveitis. And these are the pictures which have been talked by Dr. Basu, so I will not go into those details. You talked about this fern pattern where the capillaries are involved. If you see, unlike what we talked about, the focal vasculitis or diffuse vasculitis in the larger vessels, it is more of a, you see, these seem to be normal, but it is more of the capillaries which are involved, and which they call as fern pattern. It is for our rheumatologists to become familiar with. Hypopyon is only 30 to 40%, and fern-line pattern is supposed to be quite characteristic, but now our ophthalmology colleagues tell us there are other causes of fern-like pattern also. This is the PGI data many years ago. Nishant had published 49 patients, and you can see the retinitis and papillitis occurs in large number of these patients. Now we have, I think, more than 150 patients with Behçet's disease. Now coming on to very interesting patient, and I'll wish to draw the attention of the entire audience, and I'll probably, barring the ophthalmologist, if the people could tell me what are the findings. This was a sitting MLA from Haryana who was a diabetic and a hypertensive for 8 years, developed progressive painful vision loss for 20 days, initial normal vision, and then she was having difficulty in recognizing the relatives. There was one record of a very high blood pressure, 5 days, but the symptoms are there for 20 days. Saw Professor Mohd Gupta around 3:30 in the afternoon, 660 vision, cells in the anterior chamber, posterior synecdoche, and immediately he calls me up to see this patient. There were other symptoms also. Can anybody tell me what are these findings? Remembering the blood pressure, what would come to your mind? This is papilledema, or right there is disc edema. There are hemorrhages. There is something here. There is a macular star. So people thought perhaps could it be malignant hypertension? But if could you see some things here? These things are what the ophthalmologist called sarcoid granulomas. This patient had dry cough. This patient had breathlessness. And this patient also had atypical chest pain. I've taken out the picture. There were dynamic ECG changes. And then there was, the echo was done, the drop eye and all that, and exams were done. They were negative. Eventually convinced our cardiologist there was mediastinal adenopathy. And all of us are aware about these, you know, the septal thickening, the VGGOs. You can see the perivenular infiltrates and all that. This is classical of sarcoidosis. And then a biopsy was done, transbronchial biopsy, which showed a granuloma. And this patient, despite being a diabetic, despite being a hypertensive with one record, which was never really corroborative later on, was started on steroids. And this is what happened. The patient gained vision in 3 days. This was a papillitis because of sarcoidosis. And you can see the improvement. She did develop some disc pallor, but had a very gratifying outcome as far as treatment was concerned. So Dr. Basu had talked about some of the changes: intraretinal hemorrhages, periphlebitis, perivascular sheathing. These can occur. And these are the pictures probably akin to what were earlier shown by Dr. Basu. So these are also known, but rare manifestations like the one that I showed you. It is not uncommon to find sarcoidosis, perhaps as because the first series of sarcoidosis, for those of you who are interested here, of biopsy-proven sarcoidosis, 40 patient, was published by Professor Bambri, I think in 1987 in the journal Sarcoidosis, in close collaboration with our pulmonology colleagues, who were, all the 40 patients were TBLB bronchoscopically biopsy-proven sarcoidosis, when the world believed that sarcoidosis doesn't really occur in this country. So Dr. Basu talked about retina in GPA, and he's right in the sense that you shouldn't be doing ANCA in all patients of retinal vasculitis, but don't forget to ask the history of a nasal crusting or a nasal obstruction or a nasal bleed. It's not always that you will always have only scleritis, you will only have proptosis, which are more common. But occasionally you might have retinal vasculitis also. And when we looked at, this was our old series of GPA patients, 41% patients had eye involvement, and this is the paper that we are presently working on. 94 patients with ocular involvement, retinal vasculitis, as he said, in small number of patients. More commonly, as you are all aware, this is scleritis, which is more common, episcleritis, orbital mass. We know that the proptosis occurs because there is a pseudotumor kind of presentation. We have around, prospectively, we collected a data of 345 patients of GPA. And, but one thing, again, I'll draw your attention to another patient And perhaps for those of you who are sleeping at the back, maybe try to wake you up. This was a 55 years female who presented with fever, frontotemporal headache, diminution of vision of left eye, hand motion counting fingers, and RAPD. This patient actually first came to the medicine OPD because there were more visual symptoms referred to ophthalmology. I don't know whether Tendu was there at that time when the Dr. Amod Gupta called me up. He said, this is not like, there was some small patch of vitritis also. And ophthalmologists believe this is infectious cause and started IV antibiotics. Professor Gupta said, this vision loss is not explained by this. He called me up on a Saturday afternoon. When we saw, this is what they had documented. There was scalp tenderness. ESR was high. We did a Doppler immediately of the temporal artery. There was a decreased flow in the right and the left temporal arteries. Till that time, there was no other manifestations. So what all we will think of? We'll all think of GCA. And what we'll do a temporal artery biopsy. We do a temporal artery biopsy. The next day, the temporal artery biopsy is normal. So what do you do again? Well, we are all aware that these are skip lesions. The temporal artery biopsy may be normal. We do a temporal artery biopsy on the other side. And if you see this black thread, this is internal elastic lamina. There is a break in the internal elastic lamina. So we are relieved that this is, perhaps we have some evidence of giant cell arteritis. But what is on the way is that the patient develops a weakness of upper limbs and lower limbs. There is a distal more than proximal, and then there is a foot drop. And during the hospital stay, the patient did have some hearing loss, which was subtle, but not really picked up unless we dig deep into it. There was nasal stuffiness, post-nasal drip, no epistaxis or crusting. And there was also P-ANCA or anti-MPO positivity. The patient had ESR, which was high, and started to have this renal dysfunction, which was previously normal when the patient presented with fever, and then there was proteinuria. We did a kidney biopsy which showed glomerulonephritis, which was post-immune on immunofluorescence. So this was TAAAV. So ANCA-associated vasculitis can present with temporal arteritis kind of presentation. French vasculitis group published 50 cases, and this was what we published. Joydeep is sitting here, our DM student who's come to Bhubaneswar. This is, but the French group didn't tell whether the vision improved or not. We now have 3 such cases, 2 were published here. Why it is important to pick up? It is important to pick up because the drugs that we use for giant cell arteritis are very different from the drugs that we use for ANCA-associated vasculitis, number 1. And the systemic involvement, which might occur later, and the prognosis and the relapsing nature of disease in ANCA vasculitis is different from giant cell arteritis. And the other thing which we noticed in our patient, in both these patients, the vision improved to some extent, which practically doesn't occur if once a vision loss has occurred in giant cell arteritis. That's what our experience is. We have published our experience on the total published experience of giant cell. We have around, I think now, maybe 25, 30, 35 patients of GCA. We have patients of extracranial GCA also, maybe more. So unless we are looking for these things, we are very likely to miss. And unless we are looking for the subtle features, we are likely to either pick ANCA vasculitis when damage has been done, unless you ask for nasal crusting or nasal bleed. But this is a very important message for both for rheumatologists and also for ophthalmologists. So polyarteritis nodosa, it's again a very rare disease. But one thing which I wish to draw your attention to is what we published is a monogenic variant of polyarteritis nodosa, which is called DADA2. We have seen 2 patients who presented first with vision loss and then had other manifestations one was 2 had CRAO kind of presentation also. And eventually this is seen in Jain or Agarwal community in the northern India. They present with recurrent strokes. They can present first time to ophthalmologists with vision loss. The way to diagnose is to look for ADA2 levels, which are done in 2 research labs in the US, which were Kui Lee's lab and then one lab at Duke at Harvard, who are helping us. Or we can do the genetic testing at PGI. We have standardized these, and the genetic testing for this monogenic disease can be done at PGI. Out of the 33 patients, which is perhaps one of the largest cohorts, we had ocular involvement in around 20%. And this is Christian Penny French vasculitis group, completed total, classical polyarthritis nodosa, almost 8%. Somebody talked about relapsing polychondritis. I think I also have a special interest in relapsing polychondritis. In our series of patients, we had ocular involvement in 42% patients, and some of these patients did have, I think 1 or 2 patients had retinal vasculitis. One of these patients had scleritis. The retinine SPA is not really very common, and I think this subject has been dealt in detail by my previous speaker, so I won't really take too much time. So treating, I think there are two articles which all of you must read. One is the Focus Initiative, which again, Dr. Jim was a part of that. And the other was the Eyes Have It, a review written by Jim Rosenbaum in Arthritis and Rheumatology. All of you who are seeing patients with uveitis or rheumatological diseases interface with eye, it's must read those 2 articles. It will give you a perspective. And I think we are all aware where these drugs have to be used in the paucity of time. I don't think I can go into these details, but I think it is important for us to get used. How do we use biological is a different subject matter in itself. And I think with this, I'll wish to wind up by saying that retinal vasculitis is associated with severe rheumatological disorders and infectious diseases, especially TB. Prognosis depends upon early diagnosis and appropriate therapy. A multidisciplinary approach between the rheumatologists, ophthalmologists, and the physicians is very important for long-term visual outcomes. And with this, I would like to acknowledge the help of my uveitis colleagues, our guru, Dr. Amod, my guru, Dr. Amod Bambri, the uveitis guru, Dr. Amod Gupta, are my colleagues, Dr. Vishali, Dr. Ramandeep, and there are various young people who've joined now, Mohit, and I think Simar, and there are many more, the big active uveitis group. Thank you very much for your patient hearing, and I'll be very happy to take up any questions.
Thank you, Professor Sama, for beautiful presentation and with good, nice pictures. Now I invite any question from the audience.
I just like to ask, would you go differently and investigate the cases of prostate branch angiitis and the management of that? So prostate branch angiitis can occur in infectious and non-infectious, both entities. How do you approach this?
So basically, as you know, although perhaps the ophthalmologists would be better synced to answer, my domain is always to look for the non-infectious causes when our ophthalmology colleagues are sure that this is not infectious. So as a protocol in PGI clinic, they work up if there are no, the way to look at it is there is already a checklist of the yes and no's, whether there are oral ulcers, there are genital ulcers, whether there is a skin rash, there is a erythema nodosum, there are joint disease. If any of those boxes is ticked, you know which way you are going. If those are not ticked, and the basic workup that you do is you do a chest x-ray, you do a Monto, which you will in any case do for every patient. That largely defines the way, which ladder you will take to investigate further. If you get those soft pointers, and I think I did talk about those cues in the history. If you get any of those, you go that path. If you go don't have those, and if you just have Manto positivity or chest x-ray findings, then you go path for TB. If you don't go any, I think then we end up with maybe an idiopathic cause. That's how we simplistically try to put it, perhaps, but I would wish to know your approach to this also. Perhaps wish to learn from you.
Dr. Panigre.
Yes, sir.
You have nicely described almost all the vasculitis group also. So again, Dr. Basu is the fulcrum. I'll tell you one thing. So we have come across another case where patient presented to Dr. Basu again with retinal vasculitis, but the history goes like this. Young girl of hardly 20 years, a polytechnic student, and she came with multiple prescriptions from different ENT people. Okay, sudden hearing loss in 1 year, followed by another year, almost then followed by this retinal vasculitis. So the typical classical case of Cogan's is okay, this vestibular that is sensory neural hearing loss with interstitial keratitis, but any part of the eye can be inflammatory process, any part of the I can involve. So this is a case of retinal vasculitis with bilateral hearing loss, and we diagnosed case of Kogan syndrome. Okay, and patient improved in the vision, but she lost the hearing, and that is a poor lady, and still I think she is on follow-up. So this is
I
our
think
experience
incomplete
with-
Cogans is also a known entity, although Cogans is very rare.
Yeah.
But I think I remember in my last 20 years, I've seen only a handful of patients. One was from Calcutta, but perhaps that lady has been seen at most of these centers, whether that's the same patient or I don't know. I mean, because I remember that one lady is from Calcutta and there is one more patient that we have seen. So there is an entity, at least that's what made me read about incomplete Cogans also. I mean, you may not have all the features. And the Cogans can also have a variable vessel vasculitis. It can involve all the sides of Behçet, just like Behçet's disease.
Okay, thank you.
It is so strange that, I used to work in England for 25 odd years before again returning to India. And if you ask any medical student over there that, okay, what is the test that you will do if the patient comes with headache unilateral in an elderly patient, they will ask for giant cell arthritis and things like that. But, it is so uncommon to find in Indian patients, to have PMR or giant cell arthritis. But it is just that the geographical area that what you are taught at, and it gives you a clue that what kind of diagnosis that you will be expecting. Well, having said that, Aman's lecture is always something to read and learn and again enjoy. But, there are so many things that you come across in your clinical practice, like a patient with primary biliary cirrhosis who was referred to me with uveitis. And then because of the liver function abnormality, I just pursued the investigation to find the patient had a PBC. Recently, a patient who had Irving sarcoma, who presented with uveitis and raised ESR and CRP and things like that. So I think probably every day of the, can be a challenging, having an interface with the ophthalmologist and other, will be an important discussion point, because until unless the ophthalmologist gives you an opportunity to again look for the systemic causes, then only you can, because anything from sarcoidosis, they can present from head to toe. And from an ophthalmology point of view, it is very difficult to sort of say that whether it is TB or sarcoidosis, so which is where our input may be beneficial. So, you want to, I think probably we can take one more question and then we wind up the session.
Presentation.
Thank you.
I have a question for you on Behçet's disease. The question is, many times when we initiate treatment for ocular Behçet's, it goes on resolution, but the signs are so less to determine the background activity. And suddenly there is a recurrence with either a dyspallor or macular ischemia, and we in between have no clue that the disease in background is going on with that high EA. How do you manage this case? What's your approach to in between after resolution of the ocular uveitis part of Behçet's, and he is in the resolution phase, but how do you prevent this sudden?
I think it's a very excellent question, and it's a difficult, disease to handle. What are the general fallacies? The general fallacies are that when we give high dose steroids, there is a transient suppression of the symptoms. And if we give only drugs, a single drug, this is one indication where you will use a combination of therapy of either azathioprine plus cyclosporine, or you will give anti-TNFs upfront, right? Although we had debates some time ago whether you should be using anti-TNFs upfront in Behçet's in the USI meeting in Chandigarh. One has to be very aggressive. All that I want to say is one has to be very aggressive. The only thing that you have to exclude is that you don't use cyclosporine in somebody who's had a CNS Behçet's, because there it becomes a kind of a relative contraindication. And look at the challenges start that once many times people use only one drug instead of two. They don't use the drug in the dose that should be given, because 2 milligram per kg body weight to 3 milligram per kg body weight for azathioprine and 3 to 5 milligrams per kg body weight for cyclosporine. Many times when in Indian patients we try to escalate the cyclosporine dose, some of them they will come up with hypertension, other will start to have renal dysfunction and a lot. It becomes challenging. your question is you've controlled it. First thing is we don't really see that people out. Sometimes some people have not controlled it adequately. Once you let it go out of hand, it becomes difficult to manage. Number one. Number two, you've got it controlled, then you should not be in a tearing hurry to take your paddle off the foot. The most important thing is everything is gone quiet. You quickly take the foot off the paddle and it comes back with a bang. These are the diseases which would require perhaps very long immunosuppression. And then the duty is yours. Then you keep on follow-ups, keep it at the first subtle sign of your ocular relapse. Or if there are other, whenever there is an ocular relapse in clinical practice, they will have more oral ulcerations, they will have genital ulceration, they will have a skin rash also. Those things, so you have to be, I think you are an ophthalmologist. So you have to be in sync with both. Rheumatologists should also be closely looking. You should be looking from your perspective. Your rheumatology team should be looking for the disease coming back. Some erythema nodosa come back, some folliculitis has come back. The oral ulcer was controlled, they are not controlled now. So these are subtle things which you have to, and you have to be, proportionately aggressive dependent upon your threat. And if it is a posterior segment involvement, you go all out, as Dr. Bambari used to say, throw the book at the patient. You treat the patient as aggressively as you can and hope for the best.
I think we'll close this session. Thank you once again, Aman. Wonderful pleasure.
Thank you very much for the informative session. I would kindly request Dr. Indrajit Agarwal sir and Dr. Manoj Chhotrai sir to please felicitate Professor Dr. Aman Sharma. Now I would like to request Professor Dr. Aman Sharma to please provide a token of gratitude to Dr. Indrajit Agarwal sir and Dr. Manoj Chhotrai sir. Now we'll proceed for the last session before the lunch. Due to the hurry in time, I would request you to please complete your lunch in the next 40 minutes. For the next session, may I please call upon stage chairpersons, Professor Dr. Samir Sahu sir and Dr. Santosh Kumar Mahapatra sir on the stage, please.
Good afternoon. I have the pleasure to introduce Professor Dr. S.R. Rathinam. Madam had her FMS PhD in ophthalmology and head of UVIT services, is working at Arvind Eye Hospital and Postgraduate Institute of Ophthalmology in Madurai. Her basic epidemiological and clinical research over 27 years of UVIT clinic uncovered the cause, source, and pathogenesis for 3 new unknown infectious disease outbreaks, which include ocular leptospirosis, rheumatoid eye disease in children, and ocular West Nile virus infection. She has a teaching experience of 30 years and clinical experience in UVIT service for the last 27 years. She has invited faculty in American Academy of UVIT Society Day for the past 12 years. She is a visiting professor at L.V. Prasad Eye Institute, Bhubaneswar in 2017, visiting professor in UCSF San Francisco in 2017, and invited faculty in international conference for more than 34 conferences, and invited faculty in national conference for more than 100 conferences. With this, I would like to welcome Madam to deliver her.
Thank you, sir. Thank you for a nice introduction. Dear friends, this is pre-lunch and I'm 100% sure you all are very hungry. and you'll be waiting for me to finish. I'll finish as fast as possible. And there are some secrets in ophthalmology sites. Let my ophthalmology friends forgive me if I say some statement against ophthalmology. And the rheumatology colleagues has to understand few secrets from our side, which is extremely important for your practice and extremely important for your patient care as well. How do we handle ocular toxicity of drugs used in rheumatology in screening and prevention? I thank the organizers for giving me this great opportunity to be with you. I really enjoy this conference. Let me, one second, let me tell you the basic principle we studied in our second year or third year. What body does to the drug is pharmacokinetics. What drug does to the body is pharmacodynamics. And once the patient gets the tablet, what our system tried to do is immediately push it out. It starts fighting like a fighter because it recognizes as the foreign agent. So it affects the absorption. It will not allow to be absorbed. Even if it is absorbed, it immediately distributes to various places, not only in the places where you need the therapy, to the places where therapy is not needed. And also the liver starts kills the pills, or it metabolizes the pills, and urine eliminates everything. So immediately body wants to do this. Okay, that is pharmacokinetics. And this has to be remembered by us. One example is hydroxychloroquine, where if patient has liver disease or renal disease, this metabolism and elimination will be affected. So you may have to reduce the dose. If you are not reducing the dose, it may affect the eye because it is wrongly distributed to the eye where we do not need the chloroquine there. Okay, so this is very, very important to understand. The body is trying to get rid of the medicine. And pharmacodynamics, it is a wonderful thing. What drug does to the body, a case of retinitis granulomatosis treated, and eye has become so well. And the patient was saved from high mortality disease. So we have to understand the basic principles in order to know the toxicity. And I am not going to talk anything about this because it's already in your souvenir. And I am going to only tell you the most important 3 categories of ocular toxicity, which we all should be aware of. And I really salute Dr. Aman Sharma, wonderful presentation. And he talked about endophthalmitis. I am going to say the similar case, starting my talk with endogenous endophthalmitis. See, the timeline of ocular complication can be very early, like within 12 hours or within 4 days, where specifically when you give IV treatment, IV salimedrol or IV cyclophosphamide. And he beautifully presented. He told that patient will give only one history, defective vision or redness or pain. That's all. Only 3 symptoms they are going to say. And as a rheumatologist, you are likely to mistake that it is ocular complication of the disease, but it may be ocular complication of the treatment. So here we will see what happens immediately in some of the cases and what happens after 1 year or 2 years of steroid treatment in the form of cataract and glaucoma, because you all are aware of that. And another entity is CSR, which is very, very, very important. I'll touch upon that. And the third one is the long-term complication like hydroxychloroquine, where macular damage. And here is the place where we share many secrets in between the disciplinaries. Okay, now I am going to talk only about the immediate complication. Dr. Aman Sharma's exact case. IV cyclophosphamide was started. Patients started seeing some floaters, and unfortunately, rheumatologists thought it is SLE manifestation of SLE manifestation of the eye problem. So he continued to give IV cyclophosphamide and steroids. Within 4 days, the eye was totally a bag of pus. Bag of pus is endophthalmitis, endogenous endophthalmitis. And this was because of contaminated fluid. This often happens. In many villages, IV treatment is given like energizer. And many of those patients come to ophthalmologists with endogenous endophthalmitis. And this is because of lack of aseptic precautions. And we have isolated quite a lot of fungus, quite a lot of bacteria from such cases. So this is very important. We have to immediately send the patient to the ophthalmologist for anterior chamber washing, vitreous washing, and also vitrectomy and intravitreal antibiotic or antifungal. Otherwise, definitely I will go for phthisis. This is an immediate complication. Then late infections. Because we are immune suppressing the patient, they are prone for infection. And this patient will not have any symptom because the lesion is away from disc, away from macula, but it is a beautiful tuberculoma. And this patient started telling the rheumatologist that our eyes are burning. So we usually, when a female patient unfortunately says that eyes are burning, we think that she's a fussy female. No? It's very unfortunate. But she was very true, and she had herpetic blisters, which was missed in the initial presentation. And this was CMV retinitis. When we immune suppress the patient, they are likely to have CMV retinitis as HIV patients develop. And here is this patient after steroid. The macula is also got involved. At this point of time, patient became symptomatic. So when the patient gives ocular symptoms, immediately it is better to get ophthalmologist's opinion. And this patient developed very severe herpes zoster, and she lost the eye because of phthisis bulbi. Eye has gone for phthisis. And this CMV retinitis progressed to total retinal atrophy. In the case of all these patients were on very high immunosuppressions. So now we have talked already about infection. I'm not going in detail because this is just few lines and it can cause any type of infection, which whatever you can imagine. So now we are going to the moderate one, steroids, which can happen 1 to 2 years, between 1 to 2 years. And that causes structural damage. And it can be either reversible or totally irreversible. Structural complication, reversible is cataract and CSR. Cataract, of course, you all know, we can immediately remove the cataract and put an IOL, patient becomes 6/6 vision. When from hand movement, they become 6/6, so it is reversible. CSR is central serous retinopathy. If found out early, it is reversible. If it is not found out early, if steroid is continued, it is not reversible at all. I'll show you one example, very good example. Irreversible losses, once the glaucoma occurs, the disc changes comes and the vision lost by glaucoma cannot be gained. Okay, it is only last forever. And then retinal toxicity or macular toxicity of hydroxychloroquine. So we will see all these structural damages one by one. Okay, if it is cataract, I told you, you need not worry at all. Ophthalmologist can put a beautiful transparent lens. Here is the cataract in adult patient. The very next day we can do surgery and it takes only 4 minutes to put the IOL, and within 4 minutes we give the vision 6/6. But what happens if the same thing happened in a child of juvenile rheumatoid arthritis with joint pains? It's very, very unfortunate because in this particular case, I'm following this case for past 25 years. I have series of photograph of this girl. At that point of time, before 25 years, you all will agree with me, we didn't have rheumatologists. At least in Madurai, we didn't have many rheumatological drugs. And even when we start steroids, pediatrician will immediately stop the steroids. It is very, very disheartening to see that the cooperation we received from pediatrician. And what happened in this child is she was always undertreated, and because she was undertreated, this beautiful, clear, transparent cornea became like this because of a calcium deposition that often happened in JAA. Not only that, she developed uveitis, she developed cataract also. What will we do? Because disease is not under control. When it is not under control, if you do cataract surgery, what happens is inflammatory cell membrane will grow behind the lens and it will pull the lens and it displaces the lens. I invariably go for phthisis. Even if you put right type of IOL, when she grows, the power may not be all right. Okay, let us wait and do the surgery after 18 years. This eye will go for amblyopia, which is a lazy eye. If the child is not seeing for 4 years or 5 years, eye will become blind throughout life. So we cannot do early surgery when the inflammation is not under control. We cannot do late surgery because they go for amblyopia. So this case is presented because at the age of 13, she was very, very bold enough. She told, I don't need treatment. Your treatment is not helping me. I don't need treatment. Of course, 5 milligram methotrexate was given by the pediatrician, and I was not able to increase the dose at all because he was not willing. She stopped the dose. She is now 25 years, both eye blind. Glaucoma. Yes, it can happen in children also when we treat with steroids. See here, beautiful cup, white cup, and the rim is very pink. This is normal fundus, 30 to 40% cup, and here the rim is gone. You see the rim is gone. It is fully enlarged cup. This is a glaucometal cupping, and this is totally lost. There is no, almost 90%. If you see the size, you can compare. And glaucoma is a silent killer. Patient will not give you any history of defective vision, but slowly will be losing vision, become blind, and we will not know. So we have to refer these patients to glaucomas, at least ophthalmologist, to rule out glaucoma. Okay, now we are coming to central serous retinopathy. See here, very subtle sign of small retinal detachment. Very small retinal detachment. A very, very busy private practitioner seeing with the direct ophthalmoscope can easily miss the diagnosis. Definitely easily miss the diagnosis with the direct ophthalmoscope. The symptom by the patient is slight blurring in the central field. So it is not a very dangerous symptom, and the sign is also very, very subtle. So this patient by chance landed with a rheumatologist, and rheumatologist is treating with steroids, and the central serous retinopathy can become a total retinal detachment. Totally, the retina can get detached. I have 3 cases. All the 3 cases are blind in both eyes, and we have to do OCT as well as fluorescent angiography. Sometimes they even mimic bilateral CSR, mimic VKH. So misdiagnosed VKH in bilateral CSR causes bilateral total retinal detachment, and this is this complication. In fact, I want to show this picture. He's a demon because glaucoma takes time, but this will take away vision in a month, 1 month. Unless we burn our fingers, we will not know the seriousness. Okay, now we have seen 2 sections. So we are only going to see SCQ toxicity. Here is a area where we have to share our secrets. Okay, early SCQ toxicity have no visual symptoms at all. That is the most important thing. Patient will not know, doctor will not know. And there are recommendations beautifully published in AAO 2016. And the recommended screening test, here comes the most important thing. Automated visual fields is the subjective test, because patient will be telling, the light will be projected like this. Points will be projected like this. And the patient will say, I'm seeing the light, I'm not seeing the light. I'm seeing the light, I'm not seeing the light. So that is subjective test. that is not that reliable. So we have some objective test, which is spectral domain optical coherence tomography, SDOCT, multifocal electroretinogram. Again, I repeat, multifocal electroretinogram and fundus autofluorescence. These are all the tests that is recommended by the paper, and the paper also says that not recommended for screening. This is the most important one. The thing is, imagine that I have a very close friend or my student who is very, very close to me, and he has spent 2 crore rupees to set up his private practice. Okay, and his private practice will be definitely about glass prescription and cataract surgery. First, because they are the breadwinners. And he has set up a practice near Rheumatology clinic, and it is well posh looking clinic. And you will definitely believe that, okay, the ophthalmologist can rule out hydroxychloroquine toxicity. You are likely to refer to him. But think of his situation. I will show you. I will come to this slide again. This is his clinic, and he has a slit lamp. He has an auto-refractometer for the glasses. And when in his NEET exam or his final year exam, he has learned about hydroxychloroquine toxicity. He knows that it can cause macular bullseye appearance. That one he knows. And he knows that for macula, color vision is the test. And he knows that the field may be affected. And this is the only confrontation test he can do in his clinic. He cannot afford to have automated refractometer in private practice. Who is doing cataract and glass prescription? It is not his fault, because the ophthalmology has grown so much. He cannot have that particular instrument only for fields. And he himself will believe that the color vision will test the macular function, but not recommended test, the color vision also comes. Because color vision will be affected at the end of the bullseye when already patient is blind. And confrontation field is not indicated at all, because it is a very, very minute changes. It cannot pick up. Vision, he thinks that vision will be affected in the hydroxychloroquine, but early signs, there is no early sign at all. So vision will be normal, ocular pressure will be normal, cornea fundus will be normal. He may have color vision chart, because we are always asked by the transport people to check for the vision. And ophthalmologist, a private practitioner, will check for vision, confrontation field and color vision, and the fundus examination. Fundus, he will definitely examine with the fundoscope, direct ophthalmoscope. He will say that there is no ocular symptoms for hydroxychloroquine. But what I have shown you is this vision is not recommended, not fundus examination. I will show you further slides also why it is not recommended at all. Amsler slit, color charting and confrontation fields, fluorescein angiography. If the same friend has become little more rich and he wanted to see diabetic retinopathy also or hypertensive retinopathy, he has bought fluorescein angiography machine, which itself is very, very expensive. So maybe he will do that also. He will say fundus is normal, but fluorescein angiography will not have anything to say with hydroxychloroquine. Okay, and what is needed? It is fundus autofluorescence. That is a different camera altogether. That is again expensive. So a private practitioner cannot have that. It is not his fault. And imagine a government setup. A government hospital may have time domain OCT and full field ERG and EOG, which was budgeted 15 years back. And now if we ask the government to give spectral OCT instead of time domain OCT, government people will not sanction the money. You have one OCT, manage with that. And full field ERG is already with you, but full field ERG will not show you anything about hydroxychloroquine. You have to have multifocal ERG. So even a government hospital cannot tell you really the hydroxychloroquine toxicity. I'll show you with the example, then you will understand. I am not undermining prayer practice because it is not possible. If I start prayer practice, I will not buy. Because even for cataract and glasses, you have to have 2 crores. And how will you test, how will you invest an instrument? And also, they do not know. That is the most important thing. Awareness among ophthalmologists is not there about these minute points. I'll show you, then you will understand. This is the fluorescein angiography machine. Even to have this, the doctor has to invest, which is not useful for us. Okay, this is the automated Humphrey field test, which tests for glaucoma. Okay, this patient has glaucoma, and whatever you see as black is the area what she is not seeing. So she has clinical sign in automated visual field test, and this is the machine called OCT, spectral domain OCT. And what will it do? It is a wonderful instrument. You have read this, you have mugged up this layer of retina in your ophthalmology exam, and you have written everything in the examination, first layer, second layer, third layer, and your OCT machine will show this as if we are doing histopathology. So see here, this is the area. This is the area. That is the only area your hydroxychloroquine is going to affect. If we expand it, it is ellipsoid zone, interdigital zone, and also retinal pigment epithelium. Unfortunately, it is not working again. So these are the, I can show you here. Yeah. Even that is not working. So anyway, so this is the only area that is going to be affected, and our OCT, this machine is going to show the layers as it is. So this is that spectral OCT image, and this shows retinal pigment epithelium as the 4 lines. These 4 lines are very, very, very important to know hydroxychloroquine toxicity. These 4 lines. These are the names of the 4 lines. Because lighter is not working, I am not able to show. See here beautifully, the fundus is absolutely normal. The topmost picture is a normal fundus, normal spectral OCT, and 4 layers are seen clearly, and the fields are absolutely normal because it is not black. I have already shown you that it is not black. And the second B section in the arrow, very minimal thickening of retinal pigment epithelium, and there is a scotoma or field defect. But still fundus is normal. The 3rd grade, still fundus is normal, but here extreme thickening, thinning of the 4 layers. There is only 1 layer is seen in C, and field has started showing more scotomas. Okay. And the 4th picture is the bullseye. Very carefully you have to see the bullseye. The fundus camera also will not immediately show the bullseye because we need autofluorescence. That camera we need. I will show you that also. So in the D picture, all 4 layers are mingled and it is only 1 single solid layer. And the patient has become already blind. Okay, I will show you the picture of autofluorescence. Then you will understand. This is autofluorescence picture. Here there is minimal, very minimal. Even this is not working. Okay. In the blue arrows, you see the retinal pigment epithelial thinning on the other side. And this side blue arrow, autofluorescent camera has picked it up in an early stage. And this is that another patient where ST-OTT focal loss of the ellipsoid zone. Ellipsoid zone is this one. Only this is lost. And your spectral OCT has picked it up. See, there are 3 lines. 1 line is missing. So beautifully it is showing, and the field is totally lost. Multifocal ERG is absolutely lost. So we can pick up with these machines. And this is that famous camera, fundus camera for autofluorescence. And this will pick up bullseye. And this is the last stage. This is ellipsoid zone attenuation resembling bullseye appearance. Early detection is extremely crucial because the vision loss is usually permanent and cellular damage may progress despite discontinuation of treatment. Isn't it very, very important? Early detection you have detected, and in spite of that, in spite of stopping steroid, it is progressing. Yeah, this is the slide. In spite of stopping the treatment, discontinuation of the treatment, the cellular damage is not only irreversible, it is progressive. So this is very important to understand. And here is a patient who was taking 400 milligram for 40 years and she developed a bullseye. This is published in British Journal of Ophthalmology. So retinopathy is not only reversible, and there is no present treatment, and it is progressive. And this is the autofluorescence picture, normal and very early damage. And this is parafoveal, paramacular, and bullseye presentation. So this is that autofluorescence picture. And then comes the electroretinogram, multifocal electroretinogram. Long back we had just electroretinogram, which is a generalized one, which will give ECG-like wave, only one wave. Because for one fundus, there is one wave. And here it is testing in multiple areas and multiple focuses. So see here, only defect is seen in one particular area, such a specific mechanism. See in this normal fundus, but 2005 it is normal, 7 it is picking up slowly, and 8 it is there, and 9 it is becoming more, and ERG has picked up some more abnormal waves, and here there is only one point of attenuation, and your fundus autofluorescence has shown this. So unless you have everything, you will discharge that patient as a normal patient. And bullseye appearance will take very, very long time, and everything is positive. And there is only one line, not 4 lines. And this bullseye distribution of toxicity is infrequent in Asian heritage. In Indian patients, it is not seen often. It is seen in paramacular. Unless the ophthalmologist is aware, he is likely to miss that. So he has to see the paramacular area in both the tests, as well as in the SD40 whereas in Western patients, this area will be affected. All these things should be known to the ophthalmologist before he gives the comment. And 4 milligram per kg body weight gives the lowest toxicity, 4 to 5 moderate toxicity, above 5 is the highest toxicity. And this slide is not having any image, uninteresting slide, but most important facts are here. Risk of toxicity is dependent on daily dose and duration and cumulative dose. And recommended doses, first 5 years, less than 1% of retinal toxicity. Retinal toxicity is less than 1%, below 5 years. 10 years, just below 2%. 20 years, 20%. And if the patient is on a drug called tamoxifen, see here, concomitant tamoxifen, if it is given, it becomes 20 times more. This is given for breast cancer. By chance, our patient has breast cancer and this drug is given, hydroxychloroquine will have 20 into 20 times higher risk of retinopathy. As a baseline fundus examination, we should always have first ophthalmic examination before you start hydroxychloroquine to know that the patient is not having existing other macular diseases. Otherwise, patient will go to court that you have spoiled his macula. And annual screening is needed only after 5 years. So, our friend is very close friend. He is sincere, but it is not his mistake that he is not having the instruments. We will refer to the tertiary center and you specifically order automated visual fields, SDOTT, MERG, multifocal ERG, and fundus autofluorescence. When you write in your reference letter that you need all these things, he will say that I do not have this, refer to higher centers. Do you agree with me? Thank you.
Thank you, madam. Thank you, madam. A very brilliant presentation, a very pictorial one, conveying some very useful information. And as we know that the eye is a very vascular organ, and not only the rheumatic drugs, also the other drugs also attain a very high concentration. And because of the dose, because of the drug-drug interaction, because of the duration of the dose, there is toxicity. And one fact which I came across really startled me, that even as little as 5 milligram of prednisolone for as short duration as 2 months can result in cataract. And usually the duration, as ma'am told, is 1 year, but our reports were as little as 5 milligram of prednisolone per day for as short as 2 months can result in cataract. So that's the toxicity we are discussing, and it's open for discussion and questions.
I think this is a wonderful, you should get a round of applause. It's a very neglected area, and really been highlighted so well.
Thank you, sir.
In case of juvenile idiopathic arthritis associated with uveitis, when there is a cataract, I prefer to get lensectomy, vitrectomy done when the eye is quiet.
Yes.
Let it be aphakic. Later on, we can put in a scleral fixated lens.
Yes, sir.
But
Absolutely.
you know that doing a cataract surgery in the long run with the IOL is a disaster.
Yes, sir. Yes, sir.
I must say that it was wonderful to learn from you. It was, I got a small question as well as a comment. See, recently I had a patient who we diagnosed as having SLE. And this patient's sister happened to be a medical student who had read about ocular toxicity of hydroxychloroquine. So within few days of on therapy, the patient started having itchy eyes, so it may be or may not have been anything to do with hydroxychloroquine. So she went and saw one ophthalmologist who recommended all the tests, including OCT. And the patient came back saying that, she developed ocular toxicity, even though we are a rheumatologist for many years, hardly seen many cases. But I said, okay, let's have a second opinion about this OCT. So I sent the patient to another hospital to have another OCT, because I didn't want to, I did want to continue the patient on hydroxychloroquine. So the question is that the other ophthalmologist said, okay, nothing doing, and the patient has got. Was anything to do with the OCT machine, or it was simply a fluke of the machine, or what?
Yes, sir. The same point I was telling here. OCT machine matters a lot, because ST OCT only can pick up. If they have time domain OCT, it may not pick up. And ophthalmologists should be aware of these minor points, like they have to see that 4 layers and also the pigment epithelial layer. And unfortunately, in ophthalmology, this area is not discussed that much because it is very rare. One of the slides also mentioned that it is a very good drug. Hydroxychloroquine is very, very good drug. We should not unnecessarily stop it just because some ophthalmologists say that we have to stop. So it is enough if we do, if the dose is less. If the dose is less than 5 milligram per kg body weight, for 5 years, it will not cause any problem in the eye. Maybe it will cause in other areas, but in the eye, no. It's only 1%. And for 10 years, it's only 2%. And if you are very careful, annual checkup is done with all these instruments, we can definitely continue. One of the slides specifically says that if hydroxychloroquine is because it is a very good drug, it should not be unnecessarily stopped. When we compare with adalimumab and all other new biologicals, it is a good drug. We cannot stop.
Madam, I have a question and comment also. So I am not agreed to your point of clarification, like how many of institutions of India have multifocal ERG? One thing, first thing, and you told that the visual field is a gold standard machine for diagnosis of
perimetry or glaucoma. If you visual field is not a subjective, it is subjective test, but it is not falsification. If patients did mistake, etc., there is that the machine will tell that this test is non-conclusive, or there is high false positive test or cloverleaf pattern. So visual field is a gold standard test. I want to emphasize that with visual field machine, and yes, you have very beautifully explained that HDOCT, how the 4-layer, I am impressed that with that, but it is not that multifocal ERG required for the diagnosis, because the information will go to all ophthalmologists and rheumatologists that the institution which have automated visual perimetry and OCT, they will not screen the ocular toxicity of hydrocollosis plugin. Second thing, you should have a basic evaluation on the focus on the cornea, macula, as you've told. If you are saying that you have to exclude other macular disease, otherwise patient may blame on you. If I will not do the baseline evaluation of color blindness, color vision, then the patient will tell that he might have a color blindness, he might have other diseases of optic neuropathy, then later other doctor cannot catch that. So that's a basic evaluation. Cornea, you have to screen for what is keratopathy. I know that it is a very rare and later it will present, but the basic evaluation, the residents, the PG, the new doctors, they should know that you have to make a chart of all the evaluation, and in my opinion, multifocal ERG in how many centers. So that doesn't mean that the report is not sent to the patient to them.
No.
But
Here, we are not into that.
No,
Economic
actually, I
problem.
got the information, but visual field and spectral domain OCT, these are the standard. They should diagnose or screen the ocular toxicity of hydroxychloroquine. In later stage, you can see all your stages, the visual perimeter catching the diagnosis.
See, all these things are not my opinion.
Yes, ma'am.
It is a American Journal of Ophthalmology published
They have
opinion
published
only.
the paper.
And see,
No,
if the
Bhagavat, I think you have
rheumatologist
mistaken.
agree with
You have mistaken.
No,
Madam is trying to tell that these are the specific tests which will diagnose the early changes in a chloroquine toxicity. That does not mean that you will not do visual acuity or color vision or other tests. You do those baseline tests, but these are the tests which will tell you the early changes. That is what the message is.
That is the message. Economic, I am not getting into that. I am not going into the problem of a government hospital or private practice. I am just telling you the truth. Because I was also in private practice, I was also in government hospital, I am also in a tertiary care hospital. So I am just trying to tell you that what is right and what is needed. That's it. Thank you so much. Thank you, Chairperson. Thank you. Yes.
Step back, madam. So I have a small question for the acute phase. You have shown that there are some complications. So how do you differentiate whether it is due to drug or the disease?
It is not due to drugs, sir. It is mainly because of the IV fluids. IV fluid is contaminated in many places. In our hospital, we again autoclave before we use it for ocular use. So what I'm trying to say is, if by chance, if patient says that there is a blurring of vision after we started the treatment, it is better to send to ophthalmologist. That's all.
Thank you very much, Professor Dr. S. Rathinam ma'am, such an informative slides. May I please request Professor Dr. Samir Sahu and Dr. Santosh Kumar Mahapatra to please felicitate ma'am. Now, may I please request Professor Dr. S. Rathinam ma'am to give a token of appreciation to Professor Dr. Samir Sahu and Dr. Santosh Kumar Mahapatra. After that wonderful session, we all may now proceed to the lunch. I would request you all to come back here by 3:15. And before that, I would like to request those who are in the case presentation competition, please give your slides near the console. Please deposit your slides near the console. Thank you. May I please invite Dr. Niranjan Padi and Dr. Vijay Ketan Das on the dais, please.
Hello. welcome to your post-lunch session. Yes, it will be sleepy, but I think we have a good speaker now. Now I welcome Dr. Rajkiran Dodam. He has completed his MD in General Medicine from Gandhi Medical College, Hyderabad, then fellowship in Rheumatology from Nizam Institute of Medical Sciences, Hyderabad in the year 2005-2007. Presently, he is the Managing Director, Hyderabad Rheumatology Center, President, Rheumatology Association, Hyderabad, Executive Committee Member of Indian Rheumatology Association, and Joint Organizing Secretary, IRACON 2021 Virtual Connect, and Organizing Secretary of IRACON 2023. Now I welcome for your deliberation. Thank you.
Thank you, sir. Thank you for your introduction. So, welcome to post-lunch session. Don't worry, I'll make you more sleepy with my talk, so you can enjoy your sleep. I'll finish off quickly and I'll catch my flight. So, this is about immunosuppression in scleritis. So obviously we are going to talk about non-infectious scleritis. It's a vision-threatening inflammation which is associated with a life-threatening systemic disease. So most commonly associated rheumatologic diseases are rheumatoid arthritis and GPA. GPA is quite serious. RA we can manage. And there are also other diseases about which we need to know before we start immunosuppressing patients with scleritis. Diseases like relapsing polychondritis, polyarteritis nodosa, Behçet's, IBD, Crohn's among IBD can also present with scleritis. And most often, non-infectious scleritis is seen in middle-aged women, but in all varieties, in all age groups, it can be seen. Necrotizing scleritis is in older population, and children, among the scleritis in children, if you see posterior scleritis is found to be quite common. So as a rheumatologist, most of us should know, my colleagues, that whenever we also expect, like if we get a referral from ophthalmologist, we would like to know what exactly it is. Whether it is an anterior scleritis or a posterior scleritis, among anterior, diffuse, nodular or necrotizing, among necrotizing, whether it is with or without inflammation. Because this information helps us in identifying the disease. So with this, that will give us some kind of an information to what kind of disease we need to look at. And this will finally percolate into what kind of immunosuppressive therapy we will choose, and also what are the other areas in the body which we need to look for. So among non-infectious scleritis, diffuse anterior scleritis is most common. It's often bilateral, and 30% cases can be associated with anterior uveitis. Necrotizing scleritis has highest systemic association. So whenever an information is given to us that it's a necrotizing scleritis, so we will look more intensely. We look more intensely towards diseases like GPA or RP. And I have not seen much of children, but as per data which I have reviewed, it's said that posterior scleritis is common among children. And these scleritis, if they're not treated, they're associated with lots of complications. So early identification and when to immunosuppress them and how much dose has to be given and how long to be given is very, very important to be known. So if they're not treated appropriately, it might lead into raised intraocular pressure, scleral thinning, globe perforation, and lots of complications, and it can be sight-threatening. And some of the drugs which we use, topical steroids can lead into raised IOP, and oral steroids can lead into cataract formation. And most of these patients might, more than 50% of these cases might land up with cataract surgeries. So among all patients of non-infectious scleritis, rheumatoid arthritis, like it mounts around 10 to 20% of cases. But having said that, if you see patients with rheumatoid arthritis, among them, the incidence of scleritis over a period of time from last 20 years is coming significantly down. With the development of new drugs, availability of biologics, and of late from last 2 to 3 years with availability of JAK inhibitors. So the incidence of these complications are significantly coming down. So, but again, it all depends upon the treatment used for rheumatoid arthritis and the complaints of the patient, like how they have, whether they're compliant with the medications or not, the follow-ups, lots of things matter. But definitely from last couple of decades, the therapies in rheumatological diseases, especially in rheumatoid arthritis, have significantly improved. Necrotizing scleritis in RA, when we look into this area, it's really it comes with a package. A patient with rheumatoid arthritis who is having a necrotizing scleritis, it's almost like ends up with a scleromalacia kind of thing. And these patients invariably simultaneously, they can have an interstitial lung disease, very bad deformities, and most often they come in wheelchairs. So this set of patients present like this most often. So it's an ongoing underlying systemic secondary vasculitis can be there, so which needs to be treated aggressively. Unless the inflammation there, if it is not controlled, it can be life-threatening. And GPA, the scleritis sometimes can be localized. It can be restricted to eye in some of the cases. It becomes very challenging. So when scleritis comes as a part of GPA syndrome, it's not very difficult to diagnose. But when it's just scleritis alone in GPA, it becomes quite difficult, especially in TB endemic countries. So ANCA can be positive even in tuberculosis, and the chest X-rays might show the features someone like Professor Aman can easily smell GPA, but for others it might be very difficult to differentiate with only scleritis, ANCA positive, whether it's GPA or associated tuberculosis, or it's tuberculosis. So TB needs to be ruled out. We need to again do intensely investigations. Again, TB always comes as a differential in our country. And the pain in patients with GPA necrotizing scleritis is very intense, very severe, and it can be associated with PUK. So this is big data from Johns Hopkins. They have looked into all patients of suffering with rheumatological diseases. Around 5 lakh patients database has been collected. Among them, they have categorized into various rheumatological diseases. Like you can see, rheumatoid arthritis patients are around 19,000, and there is 6.8% of scleritis cases among the patients who have a background of rheumatoid arthritis. So what basically they did is they have a whole pool of patients. They have categorized into various rheumatological diseases, and they have taken scleritis and they have mapped both. In that, if we can see among scleritis patients, 6.8% had a background of rheumatoid. But among RA, if you see, 0.9% patients had scleritis. But among GPA, if you see, which has a highest percentage of developing scleritis. So around 5% of GPA patients, and sometimes it can be more if not treated properly, can develop scleritis. And there are also other diseases where non-infectious scleritis can be present with HLA-B27 association, and Sjogren's can also have scleritis presented in them. So apart from this, the most troubling disease which I felt is relapsing polychondritis, because like most often here, the few cases of RP which I have seen, patients have bilateral scleritis, and it's very painful and it's very disturbing to them, and the morbidity is quite severe. And the biggest problem is we treat them, but again, it keeps on reoccurring. When we taper steroids, it keeps on reoccurring. What I have seen is it's quite difficult in these RP patients just to manage with the conventional synthetic DMRs. I think at least 50% of them will land up with biologics or other immunocytotoxic therapies. Scleritis can be first manifestation in relapsing polychondritis. Again, it becomes difficult when scleritis alone is a presenting feature of RP. If they don't have other cartilaginous inflammations or other something to suggest vasculitis, if they don't have, and only this is an initial presentation, again, it might be difficult for us to pick it up. And there in RP, there can be associated anterior uveitis, peripheral keratitis, and increase in intraocular pressure. And there are a whole list of diseases in which there can develop scleritis, like Crohn's, Behçet's, Ricketts, Charcot, Takayasu, IgG4. So as a rheumatologist, when any patient before labeling as idiopathic necrotizing idiopathic scleritis, so RA and GPA are the initial things which we look. But apart from that, if we don't find anything related to RA, GPA, TB, we also try to look for these diseases. So as I was telling, this is one of our patient of relapsing polychondritis whom I have seen first when I was in Nizams, when I joined as a resident. So then she met almost all rheumatologists in Hyderabad, and finally again she landed up with me after nearly 15 or 16 years. So she was treated with almost all immunomodulatory drugs. She was on methotrexate, MMF, azathioprine. She received infliximab and she had some improvement in between with infliximab, but she could not continue infliximab because of the cost issues. Then later on, we tried tofacitinib a couple of years before when she came. She had a transient response with tofacitinib, but again, she could not, like the response was lost after a few months, maybe because when we have given tofacitinib, we have increased the dose of steroids and together it went on. We felt she might do well with tofacitinib because it was very economical drug which can be given. But again, she had to relapse, and recently from last 1 year, she is on tocilizumab. Like we spoke to company, and with reduced price, we were able to give her anti-IL-6 therapy, and somewhat she got settled, but we never know like how long she will maintain it. So we choose investigations as per our clinical clues. So we do a thorough clinical examination, as it is emphasized throughout our morning sessions. Like all of our speakers were repeatedly telling, it's all about the clinical examination. You check take proper history and examine, and then just decide about what investigation needs to be done. So the $1 million question is, if someone do not have any manifestations of rheumatoid arthritis or GPA, do we check RA factor or anti-CCP or for ANCA testing in these patients who present to us with scleritis? So it can be debated. There is some data about it, very few observations have been done in this area. So this paper, which is published in 2007, it looks at 91 patients of scleritis, idiopathic. We call, as I agree with Dr. Basu, who was telling in morning that these are not exactly, we are too early to label it as an idiopathic. It could be an undifferentiated disease or an evolving disease or an incomplete disease. So various terms we use in rheumatology, we can use these things. So this is, again, scleritis also could be a disease of continuum. Over a period of time, they might evolve, they might add up new symptoms, and finally they can come out with a complete syndrome. And if treated well, they might go into remission too. So this group, on 70 patients, they have tested for RA and ANCA, and 19 patients have tested positive for RF, and 7 patients tested positive for C-ANCA. So these patients were followed up for a period of 72 months. And those of 19 patients who had a very high titer rheumatoid factor. When I'm telling about rheumatoid factor positivity, it is about high titer rheumatoid, not just low positive, mild positive. So when those who had high titer rheumatoid factor positivity, 50% of them, they have developed rheumatoid arthritis. So that is almost with a mean period of 10 months. And those patients who had ANCA positivity, out of 7, 3 had developed GPA and 2 were negative for ANCA, but had a background of necrotizing scleritis, had developed GPA. So we never know, but as a practice, we are doing, my colleagues whom we are working with in with LVP and other of our colleagues, as a routine, we made it for all patients with scleritis, we routinely do at least these basic 2 tests. For rheumatoid and GPA, we try to look for. As Dr. Dharmananda was telling in the morning, before deciding about a therapy, we also need to look whether someone has any background drugs which are causing the disease. So if you're unaware of this, and if we don't have a knowledge about this, and we'll be unnecessarily immunosuppressing our patients. So scleritis, the drugs which we commonly use in rheumatoid for rheumatological problems, bisphosphonates can be the most common drug-induced causes of scleritis. It can present unilateral or bilateral, and most often they respond if you stop the treatment. And there are certain case reports of etanercept anti-TNF drug, fusion inhibitor, which has caused scleritis. And they have improved with steroids, and they have re-challenged by initiating etanercept. Again, the patient had developed scleritis. So etanercept has been found to be causative for some ocular inflammatory diseases. And anti-epileptic drugs like topiramate, anti-arrhythmic drugs, procainamide, and as Dr. Dharmananda was telling, checkpoint inhibitors, novel checkpoint inhibitors, which are used as a cancer therapy, or can also be implicated in the cause of various autoimmune diseases, and scleritis is one among them. So when we are dealing with this, so if we understand this background, we can try to stop this. But when it is inevitable, like in anti-cancer therapy or anti-epileptic therapy, you don't have an alternative. If you have to use means, then again we need to immunosuppress simultaneously. So always look for differentials, as Ratnam Madam has already said. Like we have identified a patient of scleritis with some background disease, and we started immunosuppressing the patient. While on immunosuppression, if a patient worsens, so we always need to look for secondary infections, especially when the patient on IMT went into remission and again relapses. So such has to be there always to rule out secondary infection. So this is important to know because as a rheumatologist, I treat these patients. Sometimes what happens is patients will be lost for a bilateral follow-up. They may not visit ophthalmologist. They might just stick to rheumatologist, or sometimes they might just stick to ophthalmologist and they might not come to rheumatologist. What I personally feel with my association with LPP and my other colleagues in Hyderabad is it's a double smash. So like it can't be just a single smash. So it has to be most of these diseases at least once in 3 months or 4 months. They need to be a consult from both ophthalm side and rheumatological side. So it's a tag team match which we have to play. So on IMT, if they relapse, we need to look for secondary infection. And if someone has sclerokeratitis and nodular scleritis, we need to evaluate for tuberculosis, and certain infections like Pseudomonas, staph, they can present as necrotizing scleritis, and very good and ophthalmologist who frequently sees these cases can easily identify these mimickers and help us in unnecessarily increasing the immunosuppression. So we had a tough time with this patient who had a GPA. So she is a 50-year-old female who had like pulmonary lesions, sinonasal disease, and as well as scleritis. She initially presented and she was started on cyclophosphamide, and on cyclophosphamide her lung disease and remaining symptoms have come down, but she had like the eye disease was not improving. So she continuously had a lot of pus kind of thing in the eye. So when I saw it, it was an infection. So a lot of pustular secretions kind of thing were there in eye, and eye was very painful. And my ophthalmology colleague, she did a complete examination and she said there is a dense vitritis, exudative retinal detachment, and vitritis. It's something like in progressing into endophthalmitis kind of thing. There lots of efforts have been done to identify the infection, scleral scraping, scleral biopsy, and aspiration. So lots of things have been done, but infection could not be identified. So meanwhile, I had to hold her cyclophosphamide and remaining other things. And but later on, the things, her systemic disease was increasing. She has started showing proteinuria and creatinine was increasing. So we had to take a decision, and because cultures were all negative from eye, so we have treated with rituximab, and she had significantly improved with rituximab. And on follow-up, we are continuing to give rituximab, and she is on rituximab maintenance. And there are also certain malignancies which might mimic scleritis, like nodulo-ulcerative variants of surface squamous epithelia, and certain posterior scleritis, intraocular tumors might mimic, and choroidal melanoma. And these, I think a good ophthalmologist can rule out these things quite easily. So coming to therapeutic options, before choosing your immunosuppressive therapy, so non-infectious scleritis, if it is a diffuse anterior kind of thing, a mild disease or mild to moderate inflammation, like we start with NSAIDs and topical steroids. Topical steroids alone should not be used. Topical steroids alone are generally discouraged in scleritis. So along with topical steroids, NSAIDs, endomethacin, naproxen, or 2 to 4 weeks or 6 weeks, 8 weeks, they can give a good response. Most of them, they might improve who are having mild to moderate disease with an anterior scleritis. Contrary to that, if someone has a severe inflammation and especially necrotizing scleritis or scleritis with vasculitis and posterior scleritis, these are the patients who have to be given an upfront systemic immunosuppression. Start with glucocorticoids, and very bad severe pain like a red eye and intense eye pain or headache, we generally give IV methylpred pulses. They do respond well. And if they improve with one cycle or one course, we taper the glucocorticoids and follow up them. But if there is a recurrence on steroid taper, most often what I observed is if they are on steroid monotherapy, once the steroids have been tapered to less than 20, 15, 10, they start showing problems. So in such cases, we need to consider immunosuppressive therapy. Similarly, if an anterior scleritis, mild, moderate inflammation, it's coming back again and again, so we push them to IMT. So there are lots of drugs, methotrexate, MMF, and azathioprine are our favorites. So methotrexate is most widely used, and if or anyone depending upon the patient's and physician's preference. And if they don't respond to these conventional synthetic DMRs, so biologics are the second choice of drugs. Among biologics, we change them as per the background disease. So here the background disease holds the key. Someone has a background disease of scleritis with systemic vasculitis, rituximab becomes a choice. So this understanding background disease helps us in choosing the drug. So these are various drugs which we use to treat scleritis: antimetabolites, methotrexate, AZA, and MMF, calcineurin inhibitors, cyclosporin, and cytotoxic drugs, and biologics. Anti-TNF, we have infliximab, adalimumab, certolizumab. Etanercept has got no role here. So it has failed in showing any improvement. And in fact, it has triggered some intraocular problems. New drugs, JAK inhibitors, are also used. There are certain short case series. I'll go into that. And methotrexate, this paper published in 2009, it has systemic immunosuppressive therapy for eyesight cohort. Here, what they have done is they have taken their entire cohort who have an inflammatory eye diseases, and they have taken the drugs what they were using. This inflammatory eye disease, they've included everything in that group, and the drugs they have included in one group, like whatever the drugs they have used, and they have mapped it, and they did a regression analysis into what kind of disease and what kind of drugs they have used. So among them, 56 patients had a scleritis. They were on methotrexate. And when methotrexate is given up to in 6 months, 37% patients had a steroid sparing effect. And in 1 year, almost 50%, roughly you can take up to 50% in various studies, up to 50% of patients, they can respond to methotrexate over a period of 6 months. So whenever you initiate methotrexate, this has to be kept in mind. You wait for like 6 months is a period we need to look for. So before that, you cannot judge that methotrexate is ineffective. But in real world, it becomes a big problem for us because we can tell 6 months, but patient cannot wait for 6 months. So we have to take certain decisions there. So azathioprine, 2 milligram per kg body weight dose, and methotrexate, we started using subcut methotrexate, and we noticed much improvement in parenteral methotrexate rather than giving oral methotrexate. Most of our patients, myself and Dr. Basus and our colleagues, if the patient is willing to take injections, we are straight away upfront starting on injections. And azathioprine also had shown some improvement. 20 to 30% of patients on azathioprine had shown improvement over a period of 6 to 12 months. And mycophenolate mofetil, we give up to a doses of 2 to 3 grams per day. Again, in this site cohort, they have observed that around 49 to 50% of the patients had shown improvement in 6 months. And there are lots of studies on MMF in scleritis, which were showing some improvement. So when these 3 drugs are compared, methotrexate, MMF, and azathioprine, it has been shown that mycophenolate has a quicker action. So 3 to 4 months, mycophenolate has started showing its steroid sparing agent. Steroid sparing effect means we are able to bring down the steroid below the dose of 10 milligrams. And azathioprine took 5 months and methotrexate took 6 months. And azathioprine had lots of side effects. And usually in our practice, we in our area, we see most of the patients on azathioprine tend to develop leukopenias. So that's become bothersome. But azathioprine is our favorite drug, especially in young women who are planning to have children. Because there we cannot choose methotrexate, we cannot give MMF, both of them being like teratogenic, and Aza will be our choice, azathioprine or cyclosporin or tacrolimus, these combinations we do. And coming to this combination thing again, like we use lots of combinations in rheumatology because we try our best as a rheumatologist to keep patients away from steroids. And in this, we juggle around and we combine various drugs, looking at their background mechanism of actions. So we try to combine drugs with two different type of actions, and we try to give, or if some drug we cannot give beyond a certain dose, so we try to combine. So methotrexate MMF we use in various other diseases. And of late, last couple of years with our LVP colleagues, we started using with very good benefit. Subcut methotrexate with MMF is, I would say, like in my experience, it's a wonderful combination. And we have found very good benefit in these patients. So we are collecting data, like we'll try to write a paper on that. But few patients, the number is very less, but there is a significant benefit with this combination. That's what we have observed. And MMF with tacrolimus is also a common combination which we use in our lupus patients. And azathioprine tacrolimus, especially in a pregnant women, we can plan for that. So coming to anti-TNF agents, both infliximab and adalimumab have proven efficacious, and infliximab has a very good response rate. Most of the patients, up to 90%, had a significant response with infliximab. But the problem with these drugs is, over a period of time, if you continue the therapy, they have an immunogenicity issue. So infliximab has a higher risk of immunogenicity problems. The effect of infliximab might not be there over a period of time. So we need to be careful. A good dose of 5 mg per kg body weight of infliximab is better to choose. Unlike in our RA, we go for 3 mg per kg body weight. So inflammatory control is good, and anti-TNF drugs can be better choices in patients with relapsing polychondritis, Behçet's, and sarcoidosis. As I said, in scleritis with vasculitis, rituximab would be my choice. So again, rituximab in, again, when you combine different studies, 26 scleritis patients had received rituximab. Among them, half of them had a background vasculitis, and all of them had improved. And rituximab could be a very good choice for vasculitis associated scleritis, especially in GPA. So like it's comparable with cyclophosphamide, and the gonadal toxicity issues will not be there with rituximab. So this is one young girl who had presented to us initially with very bad scleritis, and it's with PUK type of picture, and she doesn't have anything else, only scleritis, very high levels of anti-PR3. These are the presentation, and nothing else. And she had then, on retrospectively, when we asked her, she said she had a history of sinusitis and other problems. So then everything infection has been ruled out, and but she's a young girl, 21-year-old, is very not at all willing, not responding to methotrexate, not willing for cyclophosphamide. So we had to give rituximab, and she had responded very well to rituximab, and you can see there was complete resolution of eye. So like everything went well, and we were quite happy that she did well with rituximab. And anyway, we maintained her on methotrexate. Maintenance was given as a methotrexate. But what happened is, when patients become very well, they lose follow-up, they don't come. And same thing happened in this patient for almost 9 months. We lost follow-up. She stopped all drugs, like methotrexate was the only drug going. She stopped methotrexate, and after 6 months of stopping methotrexate, suddenly one day she came with headache. She had a hypertension. There was proteinuria, and a creatinine went up to 2.1. And just next day we have repeated, it went up to 3. And she landed up with RPRF, and we had to dialyze. And again, we had to give cyclophosphamide, rituximab, and plasmapheresis. After doing all these things, we were able to bring her down. And this time her eye is absolutely normal. So initially it was scleritis, then later on she had RPRF kind of issue. So there are certain case reports where tocilizumab is used. So very short series of cases, and tocilizumab is used mostly in refractory cases. Like when anti-TNF or basal depleting therapy is not working, tocilizumab is chosen. And tocilizumab, even in our experience of 2 or 3 patients and global experience with our colleagues, have shown a wonderful response, especially with patients with RP. And patients with juvenile idiopathic arthritis too can respond to tocilizumab. And we have one patient of Behçet's on tocilizumab who was not effective, in whom adalimumab was not effective, and she is on tocilizumab and doing well. But having said that, people are a little bit afraid to use tocilizumab upfront. Why? Because of certain case reports where it has been shown that tocilizumab had caused paradoxical nodular scleritis after a second dose, which has improved after stopping, but again had occurred after re-challenging. So coming to my last slide, this tofacitinib, the JAK inhibitors, which are favorites for most of the rheumatologists, and it is entered into the market, and within 2 years it has become a 1.8 crore molecule. So like it's a booming drug. Like it has multiple indications. So there are certain case reports where tofacitinib has been tried and with some good success, but again we need to get a good trial data on tofacitinib's usage here, because tofacitinib, even if it is a small molecule, it is associated with significant amount of infection related side effects. So we have to be quite careful when the patient is on tofacitinib. It requires more intense monitoring, and especially herpes zoster can be the most common side effect with the JAK inhibitors. So, but here the good thing is, unlike these are tablets, JAK inhibitors are tablets, unlike all biologics are injections. So here the response is very quick with these drugs. JAK inhibitors, the patients respond very quickly. 2 weeks, 3 weeks, 4 weeks is the maximum time they start showing the response. So patients, the case reports which they have shown, after a period of 1 month, so they were able to almost reduce the dose of steroid to less than 5 milligrams. And now tofacitinib is positioned internationally, where the oral glucocorticoids with IMT and biologics, once they're all failed, they're using tofacitinib, especially in scleritis cases. Whereas in rheumatology, the tofacitinib has climbed a little bit. Now tofacitinib is used when routine conventional synthetic DMARDs are failed. But in India, where biologics are not affordable, whether can we look into tofacitinib? It's really, again, we feel like looking at, but again, if you know the complications which can occur with tofacitinib, like you will be careful. So more data is required. This is one area where we can work on to see how effective this drug is. If it is proved that this drug is effective in this condition, then it can solve most of our problems in treating the patients with scleritis. So to conclude, ladies and gentlemen, scleritis is a potentially vision-threatening inflammatory condition which is associated with a life-threatening systemic diseases. Non-infectious scleritis can be idiopathic or associated with an underlying autoimmune disease. There should be constant quest to look for underlying disease. Scleritis sometimes can be an initial presentation, but having said that, once you treat it, still you need to follow the patient. So selection of therapy is based on underlying disease. So the understanding of background problem is very essential to manage scleritis. So NSAIDs and topicals for mild disease, systemic steroids and conventional synthetics, and if they are failed, biologics are the choices, and JAK inhibitors are the new kid in the block, which we are excited to know the data, which we hope it will come in next few years. So wide range of IMT drugs are there. Our favorite is methotrexate. So because it's cheaper, weekly once dose, and most of them, but the problem with methotrexate is more than 30% of the patients after 1 year, they become, they don't tolerate methotrexate. They feel uneasy, gastric problems, they fear taking methotrexate. So almost 30 to 40% of dropouts may occur after a period of 1 year. And combination of IMT is one thing which we are interested to look at. We are working as a rheumatologist, we are using combinations, and we are finding some improvement in these cases. But again, it has to be a randomized, structured fashion. We need to look into that. And biologics, we should, at least for now, we are reserving for refractory cases, and more studies are required to further refine the treatment algorithms for non-infectious scleritis. And with this, I acknowledge my colleagues with whom I'm working since last 10 years. So most of the cases I was working with my friend Somshila, and of late from last couple of years, Dr. Soumya and Abhilasha Bhupesh, and most of the ophthalmologists I'm thankful to in my city, Hyderabad, who were Both we were working, like as Dr. Dharmanand was telling, the eye part ophthalmologist was looking at the drugs, monitoring disease, those things we were looking. And now we strongly believe that it's a doubles game. So you can't play it alone. So if you play it alone, there are chances that you might lose the match. So it's a doubles game for medical legal purposes and also for the patient's benefit and better outcomes. With this, once again, thank you for your patient listening.
Thank you, Dr. Rajkiran, for your elaborate lecture on scleritis. How long to give these JAK inhibitors and how to monitor when you give long term? And what about episcleritis?
Sir, episcleritis, I don't think so. You require isolated episcleritis. You require any immunomodulatory therapy. Most of them, they should improve if there is no associated scleritis. That's what I feel.
Long-term use of JAK inhibitor.
JAK inhibitor. So regarding JAK inhibitor, yes, there is a long-term data of JAK inhibitors. JAK inhibitors, we have with the tofacitinib, we have a data of more than 10 years, which is available now. And we need to watch for certain complications on tofacitinib, like infections, viral infections, zoster is common, and thromboembolic problems, cardiovascular morbidity is observed in patients with tofacitinib. So whenever we are giving tofacitinib, we need to look for cardiovascular risk factors, whether the patient is having that or not, and we have to be quite careful. And if the patient is having a risk of a thromboembolic problem, like a rheumatoid patient who is a bedridden, so might have a thrombotic problem. So we need to look into these two areas when we are giving tofacitinib. And in relation to scleritis, because we don't have data how long to be given. But if there is a background disease, we need to give it for a very long. If we are not identified any background disease, if it is purely isolated scleritis, generally what we do is we push them into remission. Once they are in a remission, we continue for at least a period of 1 to 2 years, then we can think of tapering. The longer you keep the patient on the drugs, that is remission on drugs, if it is there for more than 1.5 to 2 years, what I have observed is once you taper the drugs, the relapse won't occur.
I just like to ask
Any
you.
question from the floor?
Just like to ask you, why cyclophosphamide is in the lower in your list? Because the cyclophosphamide is necrotizing scleritis, very gratifying results.
Yeah, no. Actually, because it's only 30 minutes time, I could not include most of the things I have not kept. Cyclophosphamide is our favorite drug. RA with scleritis, in GPA, in most of the cases, we do cyclophosphamide. Cyclophosphamide, it's almost comparable with rituximab, sir. Even in GPA also, if you see, and in other vasculitis also, if you see cyclophosphamide, I just skipped some slides at the last because of the time constraints. Cyclophosphamide, yes, we do use quite a good number of cyclophosphamide in our patients.
I also appreciate that you have told about the side effects profile of tofacitinib. It's a new drug, but we should not jump on it. We had an experience of an ophthalmologist who has scleritis, diffuse anterior scleritis, not respond to the steroid NSAID. I put the patient on NSAID, the patient became all right. Then after second visit, the patient came with herpetic keratitis. So the scleritis part is good. Then he started telling that I have got some problem in the cornea. When I looked at the cornea, there is a herpetic keratitis.
Herpes, yeah. Sir.
Thank you. Very nice and elaborate presentation. A couple of things. One is that we know that tofacitinib has been there for the last 12, 13 years, and we have got a lot of experience abroad as well as in India to use it. Obviously, in the last 2-3 years, since the price has come down, people have started using randomly without taking all the precaution that one has to take. Well, so long as the data is concerned at the moment, all these trials are on. And I think probably the recruitment just finished only a few months ago. So I think probably by the time we reach to a conclusion, it will take another few years. But in India, we are obviously, increasingly using it and with good results, barring few mishaps here and there. The point, the question that I was asking about is that, uses of IV steroid methylpred. Okay. Now, we are always trying to use a smaller dose. And what you think is the smaller dose of IV steroid? Because I'm not very convinced that we have to keep on using 1 gram of methylpred and so on. So what is your view?
Because it's very difficult to support it with any data. But even in lupus and other cases, we could not find much difference between using 1 gram and 500. But we wanted to be very sure because when we are dealing with an organ-threatening manifestation, if there is no associated infection and if the patient's body weight is not small, it is better to go with 1 gram. And your other question, I think if I'm not wrong, it's what about giving an intermittent pulse steroids rather than continuously maintaining on dose of steroids? Is it, sir? Yeah, people have tried because in Hyderabad, like we have KIMS, they rather than giving, even in eye conditions or any other conditions, rather than giving continuous oral steroids intermittently once in 2 weeks or once in 3 weeks or once in a month, they give a shot of depomedrol, which maintains like that. So I think lots of combinations people have tried, but it's very difficult to back up with any data. As of now, we are like scleritis, most of the guidelines, if you have a necrotizing very bad scleritis, start with 1 milligram per kg body weight and maintain. And very bad flares, we try to manage with IVMP.
Okay.
We are closing the session.
Okay, Dr. Raskran, one thing. So far as GPA and RA are concerned, okay, if somebody has got RA and GPA, and we have got the protocol of treating that, there is no problem. But you have rightly shown that isolated scleritis, anterior scleritis, nodular diffuse scleritis, and ANCA positive. So you have rightly told debatable. So we get a lot of cases like this.
Yes.
In our practice, we get a lot of cases like this. Again, if you enter Monto, if you enter again, it's a confusing. So Monto positive in this endemic country, Monto positive will be there. So again, you think of latent tuberculosis and how deal. But should we go, because should we take it all as a GPA? Because if you don't find any active tuberculosis symptoms or anything like that, then we can give a limited GPA and treat it in that line. So what we are also doing like that, because if we enter, yes, tuberculosis should be in our mind, but giving in just want to test and coming with positive, again confusion is there, how to go with that, because simply Monto positive doesn't give you that this is a case of tuberculosis. What is your opinion on that?
So I could not get it clearly. So it is Monto positive and
no, only this anterior scleritis, diffuse, recurrent, diffuse, nodular anterior scleritis, fine, and there is no other sign. It is a healthy patient presented with that, and we found with our investigation, this is a ANCA positive, PR3 ANCA positive, significant positive. So in those cases, you have shown in your slide that we should exclude tuberculosis. Okay. So again, if patient doesn't have any feature of active tuberculosis, should we go for this ANCA or quantiferon typical? Should we go for that? If we found positive, what you will do?
So in that clinical scenario, like what I understood is what you're trying to tell is a patient is having a diffuse scleritis, diffuse anterior scleritis or a nodular scleritis with ANCA positivity.
Yeah.
We try to look for tuberculosis, but nothing is there. What to do in such cases?
Yeah.
So if there is no evidence of tuberculosis anywhere, or there is no evidence of any infection, we treat it as an autoimmune scleritis and we follow it up.
No, you told Monto positive. If it will come out a Monto positive, then where you land?
Sir, just Monto positive, like we can't diagnose tuberculosis just on Monto positive. So that's, we also simultaneously, we also look for other evidences. Chest X-ray we might miss, so we go for CT, and still if we have doubt, neck ultrasound to look for other nodes, or if required, whole body PET. So we try
that is what
expand our investigations and try to rule out.
That is what I was telling, because you show in your slide that is what I want to tell. If patient does, a healthy patient otherwise doesn't have any feature of active tuberculosis, if we found anteroscleritis, tuberculosis and ANCA positive, I think we should go in a line of autoimmune disease rather than again going this Monto and become confused. Then yet, so we should clinically rule out. Yes, chest X-ray is sufficient to rule out at least if a patient doesn't have anything. That is why my point is that.
Thank you very much, Dr. Rajkiran Dudham, for such an informative session. May I please request Dr. Niranjan Padi and Dr. Vijay Ketan Das to please felicitate, sir. Now, may I please request Dr. Rajkiran sir to please give a token of appreciation to Dr. Niranjan Padi and Dr. Vijay Ketan Das. Thank you very much, sir. With this, we come to an end for the scientific session. Furthermore, we'll go down to the panel discussion. May I please invite on stage for moderator Dr. Pradeep Sharma. Dr. Pradeep Sharma is a senior consultant rheumatologist from Guwahati, Assam. Now for the panelists, may I please invite Dr. Abha Chaudhary, consultant rheumatologist from Kolkata. Dr. Anupama Mundu from Rourkela. Dr. Joydeep Samanto, assistant professor, IMS in Some Hospital. And Dr. Sakir Ahmed, assistant professor, KIMS Hospital. We will now begin with the panel discussion, 40 questions in 40 minutes.
My respected teachers, my seniors and my friends, good afternoon to everyone. First of all, congratulations Jyoti for an excellent conference, and thank you for making me this part of this conference. So basically what we'll do, this is a wrap up session. So whatever has been discussed since morning, we are repeating by simple questions, and most of the questions will be clinical based upon patient, and these are real case scenarios that we see in everyday practice. And if the audience has any comments in every question, they can just have to raise their hands, because our panelists are quite young, so you may not agree. So if anything to add, you can just raise your hand and we can have that comment. And one mistake I have made is that we don't have any ophthalmologists. That is a mistake on my part. So most of the actually The scenarios will discuss only the rheumatological perspective only, not the ophthalmological. So treatment part, whatever we'll discuss, that will be the immunosuppressive part, not the local eye treatment. So that we will leave it to the ophthalmologist. So first question is to Avra. So this is a 35-year-old male. He was diagnosed with seronegative spondyloarthritis since last 5 years. He is not on treatment, that is a common scenario. He presents with anterior uveitis of the left eye, and he has inflammatory back pain, significant morning stiffness of lasting 1 hour. There is no peripheral arthritis. His acute phase resistance are high with ESR of 120 and CRP of 200. So how you are going to treat? First question will be to Abra.
Good afternoon, everyone. So there are two aspects of management. One is the ophthalmologic aspect, and one is the axial spondyloarthropathy aspect. So ophthalmology aspect, most likely the patient will be following up with the ophthalmologist. From the spinal point of view, we'll be giving a trial of NSAIDs for around 4 to 6 weeks. If we can try 2 NSAIDs, if not responding to one, after 2 to 3 weeks, try another. By 4 to 6 weeks, if the patient is not responding to NSAIDs or we cannot taper off the NSAIDs, we will add other disease modifying agents like sulfasalazine or switch over to other biologics.
So this patient actually, important point is this patient does not have peripheral arthritis. So axial arthritis, probably if the NSAIDs fail, probably we have to go for biological. So sulfasalazine will act on the eye part, but this ankylosing seronegative spondyloarthropathy part, probably sulfasalazine won't be effective. But in India, mostly we still use sulfasalazine, even in these patients also. So next question is to Sakir. That patient, similar kind of patients, but he has peripheral arthritis also. Now, what is your option?
So the only difference here is the patient is also having active peripheral arthritis. So both sulfasalazine as well as methotrexate can be used from the arthritis viewpoint. But since the evidence for uveitis is slightly more for methotrexate than for sulfasalazine, for this patient, I would prefer to use methotrexate first. As sir had said in the morning, maybe for 3 months we'll observe not improving either the axial part or the eye part, then we can escalate to a biological anti-TNF.
So next question is to Joydeep. A 45-year-old female, she is diagnosed with ankylosing spondylitis for last 15 years. She already has developed a bamboo spine. There is no joint symptoms. She does not have back pain. There is no joint pain. Morning stiffness is minimal. She on sulfasalazine 1 gram twice daily. Her problem is recurrent uveitis. Her ESR and CRP are normal. How you are going to treat this patient?
Uveitis. So already we have tried sulfasalazine, it is not working. So as per the evidence, the next best available option we have is the biologicals. And among the biologicals, the maximum evidence is the TNF inhibitor. Among the TNF inhibitor, we have to remember that the two TNF inhibitors which have the maximum evidence is the infliximab and adalimumab. So any of these, as per the patient choice, can be choice for the treatment. And apart from this, among the other TNF inhibitor, etanercept should not be used. We must remember that because it has shown paradoxically increase the rate of uveitis. And also recently there are some data in favor of golimumab, but still now the main thing is that infliximab and adalimumab.
Actually, that there is a controversy, probably audience has not looked probably. So Sakir said that patient has uveitis, he can use methotrexate for joint disease. Then in this patient is already on sulfasalazine. Her problem is not the joints or back. See, her problem is uveitis. Why not methotrexate then before going for biological?
The study, which is the largest study on the use of immunosuppression in the eye conditions, it showed evidence of the many demands. And among them, there is also sulfasalazine and methotrexate. There is one head-to-head study of methotrexate and sulfasalazine. Actually, in a methotrexate group, they showed almost equal efficacy, except the part if there is a concomitant macular edema, it showed more improvement with the methotrexate. But sulfasalazine is, regarding the correction of the visual acuity and recurrence rate, it is almost similar. But if there is a concomitant macular edema, it more improvement with the methotrexate compared to the sulfasalazine. So already patients have tried sulfasalazine,
Rather than trying another demands, it will be better for the patient if we go for the biologicals, which will be TNF inhibitor in this case, and not other biologicals, because in ankle spondylitis many other biologicals approved like IL-17 or small molecules, but we don't have any evidence in favor of those biologicals. What evidence we have only in the favor of TNF inhibitor, and that too in the infliximab and adalimumab.
So next question will be to Anupama. What is the most common extra-articular manifestation of ankylosing spondylitis?
Everyone knows, I think, anterior uveitis is the
Yeah.
most common extra-articular manifestation of AS.
So it was a simple question. Because of time, we have kept some simple questions also. The next question is to Abra. Do you routinely send an asymptomatic in the sense of from the eye side, patient of ankylosing spondylitis for ophthalmologic evaluation?
We usually don't send because it's usually an acute anterior uveitis. So unless and until patient is symptomatic, we don't send for
So
ophthalmologic evaluation.
no ophthalmological evaluation is required unless the patient has symptoms. So next question is to Sakir, a 30-year-old male with axial spondyloarthropathy for last 1 year. So he's on infliximab 5 mg per kg for every 2 months for last 6 months. No response in his back pain. He has active disease with ESR of 80 and CRP of 120. He presents with acute interior uveitis. What you are going to do next?
So this appears to be a primary failure of infliximab. Neither the arthritis nor the uveitis is responding to it. In case of failure of one anti-TNF, we can always try another TNF. And as Joydeep has mentioned, the most evidence is for adalimumab after infliximab. So adalimumab may be a choice, or as he had said, even we can go for golimumab. If these fail, then we can try options for which evidence is comparatively less. If you look at a biological basis, even tofacitinib may be working, even something like tocilizumab, but I don't know, the spinal problem may not respond to that. Then people have tried thalidomide, tacrolimus, but if you go by the standard of care, either adalimumab or golimumab next. In case of failure of these two molecules, then only something else.
Can you choose a newer like IL-17 blocker or IL-23 blockers?
IL-17, there is a trial in uveitis. It did not improve the uveitis. And even the backache might respond, but uveitis cannot respond with IL-17 inhibitor.
Yeah.
So I would not go for.
So in case of active uveitis, really IL-17 blockers are not very helpful. Yeah,
and
that's.
in failure of one, we can always use another one.
Yeah. So next question is to Joydeep. A 50-year-old lady, she has aches and pains everywhere. She has back pain for last 15 years. She has sleep disturbances. Last 5 years, she is suffering from recurrent anterior uveitis. So X-ray pelvis, ESR, CRP, everything was normal. So the ophthalmologist do an HLA-B27 and that was positive. So what will be your advice?
Again, this lady has pain for last 15 years. So her age of onset is around 35 years. So although inflammatory markers are normal and X-ray is normal, we should not forget about the non-radiographic spondyloarthritis part, because it has been seen even last month there was one large trial come in the arthritis and rheumatology. In short, even in case of acute anterior uveitis, almost 50% patients had undiagnosed SPA, which is first time diagnosed when he come to rheumatologist for referred by an ophthalmologist in evaluation of AU. So that part is one thing. We should look for the non-radiographic saccularitis part, SPA part. And regarding the treatment, it is a very common situation. If there is a no SPA, only HLA-B27 positive anterior uveitis. So option will be again sulfasalazine or methotrexate for the recurrent prevention. If it was spine, otherwise we have to shift towards the biologicals, which will again will be TNF inhibitor.
Yeah. So next question again, Anupama is. Yes, sir.
Diagnosis with this evidence, it will be HLA-B27 positive acute anterior uveitis. But we need to rule out the non-radiographic part. We can do a MRI of the SI joint, bilateral, sacroiliac joint, to look for the non-radiographic sacroiliitis. Because X-ray is normal, but she has history of pain for. I'm not sure whether it is an inflammatory back pain because history is not provided. But we need to rule out because age of onset is 35 years. It can be fibromyalgia, but it is better to be ruled out.
Yeah, clinically looks like fibromyalgia. Yeah.
But
and 15 years non-radiographic, yes, some patients will remain as non-radiographic. That is possible. But 15 years, that is again. So most likely she has fibromyalgia along with HLA-B27 associated anterior uveitis. Normal.
Yes, that's why I said that you can do an MRI.
Yeah. Yeah. Most likely fibromyalgia, we have to see non-radiographic as sequelitis and anterior, that is HLA-B27 associated anterior uveitis. So next question, Anupama is again getting a simple question here. So what is the pathognomonic of sarcoid uveitis?
Actually, we can look for coip nodules and vascular nodules we can see. But it can be present in tuberculosis also. So we have to look for other features suggestive of sarcoidosis, any systemic feature suggestive of sarcoidosis. Then only we can say.
Probably ophthalmology can better explain. Is there any pathognomonic sign of the sarcoid uveitis? Okay.
Hello. AP nodule, Vishaka nodule can be in the tuberculosis.
Okay.
They are almost similar.
Okay, thank you, sir. Then next question is to Abra. What is the utility of angiotensin converting enzyme level in the evaluation of a patient of uveitis?
It is just a supporting test, as we discussed in the morning, that neither elevated ACE levels prove sarcoidosis nor normal ACE levels rules out sarcoidosis. So it's just a supporting test. It can go in.
So Abra, is it a supporting test or a confusing test?
More like
it
a
can
confusion.
happen in sarcoid, it can happen in TB. It doesn't help in diagnosis. It doesn't help in prognosticating.
It is confusing this, so better to be avoided probably.
Our conventional teaching has been to avoid it. Avoid doing it in the diagnostic algorithm.
I am not getting.
Not to do.
Not to do better.
Not to do is better.
So in case of anterior, it is better not to do AC converting the S level. So next question is to Sapir. What are the drugs that can cause uveitis?
Sir seems to like Anupama more than me. He's giving me some difficult questions. So what I know of the sulfonyl group of drugs like sulfasalazine have been implicated. Then today morning, Rhamanand sir has mentioned one anti-CMV drug, that is cidofovir. Then possibly rifabutin.
Yeah.
And among anti-TNF, some say that even etanercept may precipitate uveitis. Other than that, commonly what we use bisphosphonates.
Yeah.
Among bisphosphonates, the pemidronate has been implicated mostly, and even the others in the pathogenesis of uveitis.
So it is most pamidronate mostly. Other bisphosphonates, it is rare. Topiramate. Okay. So next is to Joydeep. How you treat uveitis associated with Behçet's disease?
Behçet's uveitis, it is a sight-threatening condition. So one important thing is the steroid. If there is a very severe involvement, we need to use the pulse steroid, and along with otherwise oral steroid starting with a 1 milligram per kg dose. And regarding the immunosuppression, the thing is that starting with either ethafrine or cyclosporine or combination if there is a severe side threatening. And if not working, then second option will be the biologicals. And among the biologicals, as per the ULA recommendation, they recommended for the infliximab or adalimumab. There are also recommendations of the interferon, but most commonly the TNF inhibitor is used. Except that there are some evidence in favor of golimumab. There are some odd reports in favor of refractory recalcitrant cases, like use of the cyclophosphamide or tocilizumab, even rituximab also. But these are not in the guideline. But usually first is the steroid along with the ethafrine or cyclosporine or combination, and if not responding, then TNF inhibitor, either infliximab or adalimumab.
So next question is to Anupama. A patient with recurrent uveitis, HLA-B27 is positive. Her MON2 test and TB goal is also positive. There is no sign of systemic TB. How do you proceed? And how to diagnose ocular tuberculosis?
as there is no systemic feature suggestive of tuberculosis, and if we are planning to give biologicals, then we have to treat for latent tuberculosis because TB Gold is positive. So before giving biologicals, we have to give treatment for latent tuberculosis. Otherwise, we can treat with DMARDs like methotrexate and sulfasalazine. And second part, how to diagnose ocular tuberculosis. I think we have to look for other systemic features suggestive of tuberculosis. Along with that, as sir said, some ocular findings as posterior broad synechiae and choroid tubercles, if they are present, then we can it is not like a diagnostic, but it is suggestive of ocular tuberculosis.
But it better send to probably to Aman Sharma sir, because they are doing excellent work in ocular tuberculosis.
Yeah, I think it will need it. Basically, you're largely right. I mean, I think what we'll do, we'll have to do an imaging. Depends upon what generally one would look for X-ray, or there is high ocular signs highly suggested, then perhaps do a CT chest or CT chest and abdomen. Many times you may not get an evidence only in the chest. You might get the evidence in the abdomen. I mean, TB is something you might get. We have seen, you know, paravertebral or abdominal, not only in the chest, but so for that matter, sometimes you might get clues from somewhere. Rarely, when we were struggling, I don't recommend it to do it in every patient, but PET has also helped. I mean, why it helps is it not only lights up, but our people are very well used to doing a PET guided biopsies from where we've yielded and shown tuberculosis. So that has to be a one-off case, but it has to be chest X-ray followed by perhaps CT.
Yeah.
Yeah, of course, if the ocular signs are suggestive or suspected, the vitrectomy sector, there was a paper published in Ophthalmology from PGI, Kusum and Rima were the joint first authors, wherein the PCR positive, the positivity of multiplex was shown to increase the sensitivity of PCR from 30%, which was reported in the PGI study in the late 90s, to more than 70%. So that is in the Journal of Ophthalmology. The drug resistance and all that also can be detected a priori, but that depends upon, you know, the expertise available of taking the vitrectomy sample for somebody presenting like that. Because if I remember, Dr. Mohit Gupta used to say, I'm putting my neck on the chopping block by taking those samples. So
yeah. Yes, sir.
Number one, it is a granulomatous uveitis or a non-granulomatous uveitis. If it is a non-granulomatous uveitis, then we should not think of this TB Gold. So that is there. If it is a granulomatous uveitis, even if HLA 27 positive doesn't matter, then we should think of as a tubercular.
Yeah.
That is I think that point we should
clear. Yeah. So next question will be to Abra, a 70-year-old diabetic gentleman. He was admitted for septic arthritis of the right knee joint. So now he complains of sudden onset of pain, redness, and blurred vision. So what will you think first?
We'll think of infection in the eye, metastatic bacterial endophthalmitis. Most likely this patient had bacteremia leading to infection of the eye.
So next question is to Sakir. What is the condition? It is an autosomal dominantly inherited triad of granulomatous inflammation of the uveal tract, skin, and the joints.
I think one case was presented of Blau syndrome.
Blau, exactly.
Sir has also mentioned here.
Yeah.
Dr. Panigiri sir.
So next we'll then come to hydroxychloroquine toxicity. Madam has beautifully discussed. So this is to Jaideep. How common is hydroxychloroquine ocular toxicity?
So regarding the hydroxychloroquine ocular toxicity, it depends on the dose and the duration. It increases progressively with the duration. It has been seen around 6.5% after 5 years of use to up to 20% or more than that after 10 or 15 years of use. Regarding the Indian data, we have very scarce data. So there is one study from South India which found of the ACQ retinopathy after it is up to 10 to 20% even with the 5 to 10 years of use. And subsequently there is one study from the KGMU which found around 10% of ACQ retinopathy And recently there was one study from Delhi which showed around 6% patient had retinal toxicity, basically retinopathy.
And as Madam has discussed beautifully, that depend upon other conditions like renal failure or
other
liver disease,
risk
then
factors,
toxicity may be
concomitant
more common. Yeah. Next question is to Anupama. When should we evaluate for hydroxychloroquine toxicity?
Once we start hydroxychloroquine, we can do baseline examination of the retina within 1 year of the starting the drug. And then we can annually we can repeat retinal examination test.
So first, before initiating, will you do hydroxychloroquine, this eye checkup?
Yes, sir. Within 1 year we can do. Within 1 year.
So is there any point in doing every year from the beginning, or you'll do it after 5 years? Because initial 5 years, the risk of toxicity is less.
Yes, sir. After 5 years, definitely it's more, so it is around 20%.
Yeah.
So we have to do more frequently after 5 years.
Yes, probably yearly after 5 years. That is baseline. Then to Abra, in routine clinical practice, Madam has again discussed this beautifully. How do we monitor? How should we monitor? The question I will reframe. How should we monitor hydroxy? After Madam's talk, I'll reframe the question. How should we monitor the hydroxy?
Generally, we do eye screening at baseline, and then after 5 years annually.
What was the test we had? That is she has here.
Generally, we used to do field testing, automated field testing, and OCT. But as Madam has told, that spectral domain OCT and this
multifocal
electroretinogram and fundus autofluorescence we should be doing.
But problem is the availability. Even those things, how frequently those will be available in every center, it is doubtful. Next to Sakir, what is the optimal dose of hydroxychloroquine so that we have maximum effect and little side effects?
So this dose has been controversial. Maybe in the last 1 decade, they were saying 6.5 per lean body mass, but lean body mass is difficult. But now it is very clear it should be 5 milligram per kg body weight. That is total body weight. Madam has also mentioned it. And I would also like to mention one ACR study, I think published 2018 across the US. Since they have adopted this 5 milligram per kg body weight, they have screened maybe millions of people using hydroxychloroquine, and they have found only 1 case of bullseye retinopathy and maybe 10 other cases of early.
Okay, that is very reassuring.
For 5 milligram per kg is actual body weight. 6.5 was previously mentioned for 500 kg, then it will be 500 milligram. That is the optimum dose. If we use 2 lesser dose, then it may not be so effective. And if we use higher doses, the one thing is that dose per kg body weight, other is the cumulative dose. So if we use a slightly higher dose, maybe 10 years down the line, he may develop retinopathy.
So next question is to Joydeep. In SLE patients, usually we want to continue hydroxychloroquine lifelong. When we have to stop hydroxychloroquine?
So again, there is a role of the screening. After 5 years of use, we should check annually. And as there is a screening test, as per the latest RCO, Royal Society, College of Ophthalmology Society, they said the usual screening test will be the first will be the autofluorescence and spectral domain OCT. If both are abnormal, then label as a retinopathy and stop. If one is abnormal, go to the Humphrey visual field testing. If it is abnormal, then stop. I mean, if there is evidence of retinopathy, stop. Otherwise, you can continue. And the dose must be 5 milligram per kg body weight, actual body weight. And there is no such recommendation for dose modification depending on the existing other comorbidities. However, Euler said that in patients of lupus nephritis with renal failure, dose can be reduced by 50%.
But we have to be cautious. Even if we don't reduce the dose, the point is we have to be more cautious. So next, coming to steroids, it is to Anupama. A patient with class 4 lupus nephritis has central serous retinopathy, as Madam has discussed. So in these patients, usually we use high dose steroids. So
Yes,
this
sir.
patient, how you are going to treat?
If patient has already developed central serous retinopathy, I would go for steroid sparing agents. like other drugs are available, so I will go for.
No, my question is, we will give steroid in all these patients will be receiving either cyclophosphamide or mycophenolate.
Yes,
So
sir.
about the steroid dose.
I can give him biologicals like rituximab. We can give.
I'll ask the audience of what you will do now. This is central serous nephropathy,
Yeah.
class 4 nephritis.
Stop steroid immediately. Stop steroid immediately and continue other immunosuppressants.
Yeah. So if the patient has glaucoma, then what we will do?
Again, stop steroids. Only immunosuppressants.
Yeah. Problem is that till now we don't have studies which shows that lupus nephritis without steroid. What will be the response? There was one long back 2013. So without steroid, we are not treating lupus nephritis actually.
Even in eye, there are some conditions like intermediate uveitis where we definitely need steroid. We even go up to the level of treating glaucoma either medically or surgically and then give steroid. Because in case of glaucoma, we have a treatment at least, a surgical treatment and medical treatment.
Yeah.
So we do that and then we give steroid.
Then okay. And what about central serous retinopathy?
Central serous retinopathy, no steroid at all because it's very, very difficult. The total retinal detachment will occur.
Okay, but our concern is also the kidneys also, because if that part is not tackled, then later on you will develop chronic kidney disease.
IV cyclophosphamide.
That patient anyway will receive. Patient will receive either cyclophosphamide or mycophenol, but initial part usually we give high dose steroid. So whether we can use that part or not.
No. For CSR, no steroid at all.
Sir,
okay.
We have experience of one case at SGPGI. Lupus patient rapidly progressing renal failure also had central serous retinopathy. So we tried a rituximab loop protocol. Pulse steroid was given 3 days and then rituximab was given. Then I think steroid was kept for 15 milligram per day for 1 month. Then brought down to 5 milligram per day. And regularly
probably that rituximab. Even in rituximab, probably we don't have to give even oral steroid also. 2 pulses, 15 days apart. That is protocol. Yeah, that is the protocol actually.
But still we use that 5 milligram. We are not confident.
Any dose of steroid in CSR.
Okay, you cannot use even pulse steroid also. So only probably rituximab and cyclophosphamide combination or rituximab and mycophenolate combination will be a good size probably.
Even skin creams with steroid is harmful.
Okay. So probably rituximab with something will be.
I understand, but we have to tell the patient choose between your kidney or your eye.
That will be a million question.
No, every time we give steroid, it will come back.
So what? So the summary is probably question is that glaucoma. Yes, first ophthalmologist will treat, then we can give steroids. CSR we should not. So and we have to go fast because time will be limited. So next question is due to Abra. Yeah, that was answered by Anupama. So next question will be to Abra. How common is uveitis in juvenile idiopathic arthritis in India?
So the most common variety of GIA in India is enthesitis rated arthritis. So of the patients which we see, we don't see that much of uveitis, but then data is very scarce. But this data again may vary from what the ophthalmologists see, whether they have idiopathic uveitis or not. So the data will vary according to where the patient first presents.
Because there is no proper screening program.
There is no screening program.
But that oligoarthritis ANA positive variety is lesser in our country. So that's why probably uveitis will be lesser in our GI patients. So to Sakir, what type of uveitis occurs in these children?
What I've seen in the discussion today, people are talking of GIA, but GIA is not actually one phenotype. It has very different phenotypes and we need to differentiate between them. If it is the commonest type ERA will behave just like ankylosing spondylitis. So they will have acute anterior uveitis and that is painful. Usually the child will complain or the parents will notice that one eye has become red. But in most dangerous type is the oligoarticular, because oligoarticular is associated with posterior uveitis and the child will never complain because there is no pain. the parents will not notice there is no redness. So and this occurs in especially girl children less than 6 years of age. This is very exclusive disease. So maybe in our country we are not picking them up. They have arthritis only one knee. They limp for some time. The limb gets better, but the eye is lost forever.
No, sir. Actually, in children, it is bilateral non-granulomatous uveitis in white eye. It is only anterior uveitis, but they will not have redness. It's not posterior uveitis. Only anterior.
Oligoarticular is associated with posterior uveitis.
No, sir. No.
It is
only
actually anterior, yeah, but it is asymptomatic anterior uveitis.
And HLA-B27 in boys, it comes as unilateral acute redness. In girls, it is bilateral white eye uveitis.
ER phenotype is associated
Yes,
with
anterior uveitis. So next question is to Joydeep, how frequently these patients are to be sent to an ophthalmologist for evaluation, and how long you will monitor?
So there is again one recommendation which came in 2019 by American College of Rheumatology. So as Dr. Sakir was saying, the high risk variant like oligoarticular, ANA positivity, duration of illness less than 4 years, age of onset less than 7 years, or RF negative polyarticular variant. These are high risk variant. There should be screening should be every 3 monthly, and it should be immediately at the diagnosis. Patient should be referred to ophthalmology colleague for the evaluation of the uveitis, because as we know, it can be chronic anterior uveitis which can be painless and silent. So later, if not treated and not diagnosed early, it can have catastrophic complications. And other low risk variant, we can screen every 6 to 12 monthly. And when patient is already on treatment, patient should be screened every 3 to 6 monthly. And if there is any change of therapy, if there is a change of the systemic therapy, within 2 months, patient should be screened for any recurrence or flare of the underlying uveitis. And if there is any change of the topical therapy, within 1 month, patient need to be seen by ophthalmology colleague for screening.
So how long? Lifelong?
Usually said up to 7 years after the diagnosis of uveitis.
Okay.
After that, 6 months, once in 6 months.
So next question is to Anupama. Is there any relation between joint symptoms and eye disease in juvenile idiopathic arthritis?
Usually in JIA, eye symptoms are usually asymptomatic. Usually uveitis is usually asymptomatic. So patient may not complain of eye symptoms, but joint pain will be there. So we should go for screening, sir. I don't think there is any eye symptom and joint symptom simultaneously.
So actually, yeah, there is no relation between joint problem and eye disease. So even in asymptomatic patient, if the patient is asymptomatic joint, even those patients also need screening. So next category is dry eye. First question is to, so now it is really rapid fire. We'll go rapidly. So to Abra, 5-year-old lady, diabetic and hypertensive, complaints of xerostomia and xerophthalmia, referred by ophthalmologist due to positive Rho and La at high titer, 3+ both. What you are going to do now?
So the diagnosis, primary Sjogren's syndrome, and we'll add hydroxychloroquine and plus topical therapy as per the ophthalmologist.
So can we diagnose these patients without a salivary gland biopsy?
Yes, only based on the symptoms and positivity of ROLA positivity, we can diagnose.
Okay.
We don't need salivary gland biopsy.
So if you do a salivary gland biopsy, if it is normal, so it is treatment will be same. That means this is to suck.
Yeah,
it is
the management won't differ.
So this is to Joydeep. The tear film is a balanced composite consisting of 3 layers. This is a theoretical question. Lipid, aqueous, and mucin. So next, we have skipped one question because that was actually answered by Abra. No, salivary gland biopsy, we have skipped this question.
I can tell that. So our previous question, we would always like to do hepatitis B, hepatitis C, and HIV. They have to be ruled out before making a diagnosis of, because they can mimic all the features of Sjogren's.
Very good.
Viral markers we have to do before diagnosing primary. And if the salivary gland biopsy is normal, we need to talk with the pathologist. Sometimes some mild infiltrates they will not report. Okay. So unless the pathologist knows what we are asking for, they have that Chelsea Mason grading. We have to tell them that they have to look for the infiltrate.
So next question is to Joydeep. The tear film is this is a theoretical question. Tear film is valence composite consisting of 3 layers: lipid, aqueous, and mucin. So which layer is affected in Sjogren's syndrome?
So it is usually aqueous tear deficiency.
Aqueous layer, exactly. So next is to Anupama. What are the available treatment options for xerostomia and xerophthalmia in Sjögren's syndrome? Immunosuppressants. I'm not talking about the ophthalmological because that part will be dealt by that.
Usually we give HCQS only, sir, and nothing else for that xerostomia or xerophthalmia.
So if there is no systemic symptom, there is no
sir.
role of
No, sir.
immunosuppressants. Then next question is to Abra. A 45-year lady with rheumatoid arthritis for 10 years. Her joint disease is in remission. She is on methotrexate 15 mg weekly, sulfasalazine 1 gram twice daily, and hydroxychloroquine 300 mg daily. Presents with scleritis for last 2 days. She has history of scleritis in the past also. There is no other extraarticular manifestations. What should be your next course of action?
So add steroids plus hike up the dose of methotrexate.
Okay.
And follow. And if the after increasing the dose of methotrexate also patient has recurrent scleritis, we go for biologics.
Yeah. So next is to Sakir. What are the rheumatic diseases with dry eyes?
So almost all the inflammatory rheumatic diseases are associated with Sjögren's syndromes. Plus systemic sclerosis, though it is non-inflammatory, it can also have dry skin, rarely dry eyes. Then the organs which affect the lacrimal gland, suppose IgG4 disease, they can also present with same dry eyes.
Yeah. So almost all rheumatological diseases can have dry eyes. So this is to Joydeep. A 40-year-old lady with severe dry eye referred from ophthalmology to rule out systemic causes. What test you will order and when will you do a salivary gland biopsy?
So regarding the severe dry eye, so look for the systemic causes regarding other systemic diseases. Actually, the dry eye is the diabetic and hepatitis C, and we should order serology for the hepatitis B, C. We should rule out diabetes and other among the rheumatological disease causing dry eye. As Dr. Sakir said, any rheumatological disease can cause dry eye. Among the immunological workup, we will advise ANA, rheumatoid factor, and CCP because these are the most common rheumatoid disease, RA and primary Sjögren's associated with the dry eye. And if by immunological workup diagnosis remain inconclusive, we will go for the salivary gland biopsy and we ask for the focus code in the biopsy.
So, Jyoti, do you have time? Jyoti is not here. So, this is to Anupama. A 50-year-old lady referred from ophthalmology with severe dry eye, but no joint symptom. Her rheumatoid factor is positive at high titer. How will you manage?
Severe dry, no joint symptoms, RF is 180. I think we should go for immunological workup like Roe and La. And if there is dry mouth also, we can go for salivary gland biopsy to look for any feature suggestive of Sjögren's and other systemic involvement. And if there is systemic involvement, we will treat accordingly. But only for dry eyes, we have to refer patient to ophthalmology.
Yeah. So basically, high titer rheumatoid factor positivity is more common in Sjögren's than in actually rheumatoid arthritis.
Yes, sir.
So patients should be thought about more about Sjögren's syndrome. So next patient is to Avrod. Do all patients of RA with dry eye require ophthalmological referral?
Usually no, but if a patient complains of any symptom, they may not always complain of dry eye, some foreign body sensation in the eye or stickiness in the morning, then they need a referral for dry eye screening.
Yeah. So next is to Sakir. Patient with recurrent scleritis, no joint symptoms, rheumatoid factor is positive at very high titer, more than 600. How do you manage this patient?
No, I think Dr. Rajkiran has given extensive elaboration on this. I will not classify him as rheumatoid arthritis only because that RF is positive, but recurrent scleritis we have to treat. Possibly we'll need systemic steroids with methotrexate, and if there is scleromalacia or eye threatening, then I'll directly go for something like cyclophosphamide or rituximab.
So next is to Joydeep, a 60-year-old lady with a 3 weeks history of scleritis and headache. She has no other systemic symptom. She has leukocytosis, very high ESR. Her ANCA is positive. PR3 is 35. So CT MRI brain was that was showed only lacunar infarcts. Other things like urine, creatinine, X-ray, everything is normal. So what you are going to do now?
So again, see, the lady had very high inflammatory markers with very high titer of PR3 and MRI evidence with lacunar infarct, which can be vasculitic infarct also, we cannot rule out. So considering this is a major organ involvement, we'll go with the immunosuppression, which could be steroid and maybe pulse steroid along with the immunosuppression, either cyclophosphamide or rituximab.
Aman sir, will you use rituximab or cyclophosphamide in scleritis? In this?
If patient can afford rituximab, otherwise IV cyclophosphamide.
Yeah. So, India.
The biggest dictum is in ANCA vasculitis, people quote RAVE trial, but RAVE trial showed only non-inferiority of rituximab over cyclophosphamide. There is no trial as such till now which has shown that rituximab in a primary induction is better than cyclophosphamide. No trial. RAVE trial could not reach its superiority margin. So it only showed that rituximab is non-inferior to cyclophosphamide. It is only in relapsing disease, relapsing PR3 positive disease and airway involvement where rituximab scores over cyclophosphamide.
So next to Abra, similar patient has scleritis. This is to?
Me, sir.
Anupama, yeah. So similar patient, but now patient has systemic symptoms, fever, cough, and she has swelling of the legs. Her urine shows 2+ albumin, plenty of RBCs, her creatinine is high, says excess of multiple nodules.
Most process ANCA associated vasculitis, sir, with nephritis, because his RBC are plenty, creatinine is raised, and X-ray showing multiple nodule. We will pulse the patient, and then we can go ahead with cyclophosphamide and rituximab.
So probably treatment will be almost, yeah, yes.
Here it's a case of ANCA positive mild to moderate scleritis. It's not a scleritis performance or something like that. So why should we go with rituximab cyclophosphamide in this case? Why not only steroid plus azathioprine or?
2-3 things. First, there are brain infarcts. So there is probably a CNS vasculitis. It's not just only, and what I will do differently from what is being done is less recognized, but temporal artery involvement is a very common cause of headache. So don't forget to put your hand on the temporal artery. So it is being recognized that the headache many times, which is a steroid responsive headache in GPA, might be because of the inflammation of the temporal artery. We showed that case. So unless we look for it, we will always be missing. The other causes are pachymeningitis, which of course MRI has not shown. And the other thing is there are enough studies which show that scleritis is always because of vasculitis. And in a disease like ANCA vasculitis, even in a limited disease, people have burned their finger. There are trials like NORAM trial, wherein there was no renal involvement and they only treated with steroids and methotrexate. And in the long-term follow-up of, because these are diseases which are eventually going to come and hit more organs. So the subtle things are subtle hearing impairment, subtle nasal symptoms. So if you do an audiometry, you might pick up a hearing loss, which the patient is not really conscious of. The vasculitis is also hitting there. And some numbness as paresthesia, which are not really manifesting as a foot drop or wrist drop. Unless you do a nerve conduction, those things are very easily missed. And even subtle skin rashes, some mild rashes are always missed. So this is just like the forest fire, actually. If you are able to douse it in the beginning, otherwise it becomes very difficult to control. And I think we've debated many times whether you should give, with these kind of patients, you should give methotrexate or azathioprine. But if you look at the EULAR EDTA recommendations, scleritis, you should not use methotrexate. If you look this 2016 EULAR EDTA recommendations, you should practically, that is with ANCA vasculitis. You should never give methotrexate or azathioprine. You should use rituximab.
Better to be aggressive upfront.
For induction.
So, yeah. So next question is to Abra. A patient with necrotizing scleritis is referred to by an ophthalmologist. OARC and choice of immunosuppression.
Generally, the investigations that we do, apart from the clinical history, is look for ANCA and for rheumatoid factor anti-CCP. And choice of immunosuppression, it is necrotizing. So hydrosteroids plus cyclophosphamide.
Exactly. So next is to Sakir. What are the diseases associated with peripheral ulcerative keratitis?
Sir, I think the answer is the same to the previous question about dry eyes. Almost all inflammatory rheumatic diseases are known to be associated. Almost 1/3 are associated with rheumatoid arthritis, but lupus, even the various vasculitis, everything can present with peripheral ulcerative keratitis.
So next is to Joydeep. How peripheral ulcerative keratitis is treated?
So peripheral ulcerative keratitis, if due to underlying rheumatological disease, then again the treatment will be the control of the underlying disease and immunosuppression will be needed. So if most commonly it is as the RA, so steroid and optimization of the immunosuppression, and if required, use of the biologicals as per the underlying disease status.
Actually, our personal experiences, these patients undergo perforation. So we go for cyclophosphamide.
Yes,
But once it perforates, everything is lost.
So next, we are almost coming to an end, Jyoti. Don't worry, almost finished. So 50-year-old female, severe dry eye with corneal melt. All immunological workup is negative. Will you add immunosuppression?
Severe. No, sir.
Yeah, we have to add. Yeah, because already corneal melt is there. So we have to treat aggressively. So last question, it is about episcleritis. This will be to Abra. A patient with recurrent episcleritis without systemic or joint symptoms, how are you going to evaluate for systemic diseases? If the patient does not have systemic disease, what will you advise? First, how to evaluate for systemic diseases?
Again, most of the rheumatic diseases can have episcleritis like lupus, but because the management won't differ much, so we generally there's no point in evaluating. If the patient has scleritis or uveitis, then we will evaluate. There's no point evaluating for
Clinically, if there is no symptom, better not to evaluate. Yeah.
We don't evaluate.
And if there is no systemic disease, not to treat. Okay. With this, this is the end of the year. And thank you all for, and thank you audience for staying back, and thank you Jyoti again.
Now I request the chairpersons, the panelists to give the mementos to our moderator, sir. I think this is the most interesting session of the whole day. I think please a big round of applause for them. These are the things that we learned from the conference. And now I request Pradeep Sharma boss to give a token of appreciation to all our young panelists. Please give them a big hand. So now we'll go to the last session, that is called case discussion. And we are very delighted that people from Cochin, people from Chennai, people from Calcutta, they have all given their cases. Most of them are published in the souvenir. And I'll request Professor Aman Sharma sir, Secretary IRA, to be the moderator, and Professor Dr. Ratinam ma'am. And sir, please. Okay, sir. Okay, sir. So I think sir will be there as the moderator, and we'll have two judges there, Dr. Abra and Dr. Pradeep Sharma. Sir. So we'll start without wasting any time. Where is the list? Aditi. Acha, it is there. Sir, you can
I'll invite the first team. The presenter can come up. I think Dr. Anirban Datta and team driving in a wedge, peripheral ulcerative keratitis and GPA. Yeah. I think what Jyoti has told me, you have 5 minutes to present and then we can have 1 or 2 quick questions.
Okay. So I will begin. Yeah. Right. So good evening, everyone. I'm Anirban, and I will be presenting a case titled Driving in a Wedge, Peripheral Ulcerative Keratitis and Systemic Associations. So progressive peripheral ulcerative keratitis is usually a manifestation of a systemic vasculitis. Most commonly, rheumatoid arthritis followed by granulomatosis with polyangiitis, previously known as Wegener's disease. So GPA is a multisystem disorder characterized by necrotizing granulomatous inflammation and pauci-immune small vessel vasculitis. It also has a few ocular manifestations, and they are seen in up to 60% of GPA patients and may be the initial presentation of disease in half of these. So coming to the case for today, a 57-year-old lady, a school teacher by occupation, came to us with complaints of redness and pain in the right eye for the past 5 months. She is a known case of polyarthritis on oral steroids, and she had no history of deafness or cardiac issues. So on examination, as can be seen in the figure, she had peripheral corneal thinning with diffuse necrotizing scleritis of the right eye. And as a school teacher, this was also hampering her professional life, and she was quite distressed by this. On physical examination, digital gangrene of the hands was noted, and which underwent eventual auto-amputation. So on presentation, due to the excessive thinning of the cornea, we went ahead and performed a tissue adhesive application for the corneal melt. Post-operatively, topical steroids and antibiotics were prescribed. So we sent her for some blood workups, which is routine on presentations like this. Our lab reports came back and we noted elevated ESR and C-ANCA to be positive. A rheumatologist consult was sought, and oral azathioprine and IV cyclophosphamide was started, and oral steroids were continued. She received a total of 6 cycles of intravenous cyclophosphamide over a period of 6 months. Ocular signs and symptoms resolved with corneal scarring, and a C-ANCA was noted to turn negative. So, sorry. The eye appears to be quiet here, as can be seen in this photo. There is no active inflammation, and there is definitely scarring in the previous area of inflammation and thinning. So, however, unfortunately, 1 month after completion of the
cyclophosphamide course, she complained of redness and pain in the previously afflicted eye, and she presented with a significant scleral melt in the same eye. So at this point, topical steroids were restarted, and rheumatologist consult was again sought, and intravenous rituximab once weekly for 4 weeks was administered. Thankfully, she responded well, and corneal and scleral scarring with thinning was observed on her last visit, which was noted to be stable. So this is a timeline showing the sequence of events in this case. So initial thinning followed by scarring, and again a reactivation, which in turn responded to rituximab, and finally scarring again. Unfortunately, she was lost to follow-up for the next 2 years, and she presented to us with a senile cataract this year. She did not give any history of reactivation of symptoms over the past 2 years. She underwent uneventful phacoemulsification with foldable intraocular lens implantation, and her visual acuity was noted to be 20/20 parts on last follow-up. She was also noted to be on low-dose immunosuppression, that is around 10 milligram malsulone. So coming to the discussion for today, GPA is a potentially fatal systemic disease. It usually presents in the 4th to 6th decade and has multi-organ involvement. Upper and lower respiratory tract, kidneys, and eyes are the commonly involved regions of the body. So ocular manifestations can be variable, ranging from pseudotumors, dacryadenitis, dacrocystitis, nasolacrimal obstruction, to peripheral ulcerative keratitis and necrotizing scleritis. Prevalence of digital ischemia and gangrene in the GPA population is less than 1%, and that was a surprising find here. C-ANCA against proteinase 3 is present in more than 90%, while P-ANCA is seen in 10% patients. The diagnostic value of ANCA in GPA is well established. However, the role of serial ANCA measurements during follow-up and their utility in guiding treatment remain controversial. Management for this disease primarily includes systemic steroids with immunomodulators and biologics such as rituximab in achieving remission. Ocular manifestations can be managed with additional local immunosuppressants such as prednisolone acetate 1% eye drops after ruling out infective etiology. So concluding, the detection of ocular inflammation in a patient with GPA should initiate a search to determine the extent of disease, and a multidisciplinary approach involving otorhinolaryngologists, oral and maxillofacial surgeons, rheumatologists, renal and respiratory physicians, and ophthalmologists is needed. These are my references. Thank you.
Yes, any questions or comments from the audience? So are you aware that what are the chances of relapse vis-a-vis PR3 positive disease versus MPO positive GPA? Rarely GPA can also be MPO positive.
Yes, yes, sir.
It's just for the sake of discussion while people are thinking about. Because this patient, why I'm asking this question is the patient was doing well, induced with cyclophosphamide, maintained with azathioprine, had a relapse. This is as such a relapsing disease.
Yes, sir.
I mean, the thing is that generally the relapse rates have been reported to be up from 25 to 50%.
Yes, sir.
But once you use rituximab in maintenance, then the subsequent relapses are lesser. So that's what one needs to know. I think the other thing which we wish to know was what was the dose of steroids on maintenance. Because when the rituximab was used for reinduction, was the steroids hiked up? I presume they were, because when the patient developed cataract, after loss to follow-up, the patient was on 10 milligrams.
Yes, yes, she was on 10 milligrams.
Any other questions, comments? Yes, Pradeep.
Yeah.
I presume it was because in the initial presentation said azathioprine plus cyclophosphamide.
Yes, yes, it was
but
combined.
in the images it showed that it was cyclo for induction and aza for maintenance.
Yes, sir.
Can you clarify that? I mean, I presumed from his pictures that perhaps cyclo was used for induction and aza for maintenance.
Yes, they were both were started by the rheumatologists. They were
Both were given together is the question.
Both were given together. Both were given together.
Generally, cyclophosphamide is given alone as induction, and azathioprine is given as maintenance.
Okay.
In the maintenance phase. So there are two phases. One is the remission induction phase, whereas either cyclophosphamide or rituximab is used, or a remission maintenance phase where people are now you tending to use rituximab 500 milligrams or methotrexate or azathioprine can be used. Generally, cyclophosphamide azathioprine is not given with azathioprine. Okay. Generally, unless it is a relapsing, difficult to control disease. Okay.
Big drug immunosuppression, there is no fun in adding azathioprine. That may increase the risk of infection.
Okay,
so that's why we are a little.
Okay, sir. I think Jyoti is very right. The only thing is, if you're reinducing in a difficult to manage patient, then you can use combination drugs, but not upfront for sure, because infections will go up significantly. I think we pardon?
Would mycophenolate be a better?
No, I think the mycophenolate can only be, do you know the answer? Perhaps you're from ophthalmology, right? Can I answer on your behalf? Mycophenolate is, there was a trial called MYC trial wherein it was shown that it is only non-life threatening MPO positive disease where you can consider as induction agent. Otherwise, in GPA classically, it is not a good choice. And even in maintenance, there was an improved trial which showed that it is inferior to both methotrexate and azathioprine. So both for induction and for maintenance, you can use it in a non-life threatening, non-organ threatening, MPO positive microscopic cholangitis, which will not involve the eye. So which will not present as scleritis. You just have some asymptomatic mononeuropathy, or you just had some minor organ kind of a microscopic cholangitis where you can consider MMF. Otherwise, it's not a good drug for ANCA-vasculitis.
It's a good drug for lupus, where it is equated with cyclophosphamide, but not a good drug for vasculitis.
Non-infectious scleritis. And well, maybe if there are personal choices, well, yes. Otherwise, if you go by the dictum and the EULA recommendations, if it is supposed to be any association with any rheumatic disease, more so ANCA-vasculitis, then it would be probably better to avoid it. I mean, avoid MMF, but rest depends upon the personal experience.
I totally agree with you.
Thank you, sir.
I call upon Dr. Ankita Kumari. Ankita Kumari.
We'll sound you after 4 minutes. That 1 minute is remaining for all of you. Just in the interest of time, after 4 minutes, we'll tell that 1 more minute is remaining for your presentation.
Thanks.
Good morning, sorry. Good evening, ma'am, sir, and everyone present here. I'm here to present a case. The demographic details of my patient was, she's a 11-year-old female resident of Nuagaon. She presented with chief complaints of diminution of vision, left eye more than right eye for the last 10 days. My patient was apparently well 10 days back when she presented to our outpatient department with diminution of vision, left eye more than right eye, which was associated with mild pain in both the eyes. There's no history of watering or photophobia, and it was not associated with any headache. Patient gives a history of pain in both her knees for the last 15 days and is having difficulties in getting up once she sat down on the floor. The patient also gives a history of having difficulty while walking, which was associated with fever and fatigue. And there's history of development of rash over sun-exposed area of the face, which was not associated with any itching. And there's no history of oral ulcers, no history of loss of appetite. Past history, the patient has similar episodes in the past, like joint pain and diminution of vision in the year 2017, which had even led to hospitalization of the patient, documents of which were not available at the time of presentation. The patient gives a history of recurrent episodes of cough and cold. The patient has no history of contact with tuberculosis patient, and there's no history of trauma to any of the eye, and there's no history of any drug intake. Personal history, the patient had an uneventful birth history, cried at birth and no history of birth asphyxia. My patient stopped going to school after her first attack, which was in the year 2017, and she also has a good relationship with her siblings. Family history, there's no such similar episodes in the other family members. Local examination, head is erect and facial symmetry was present. There was scoliosis present and small hypopigmented spots were present all over the body, and there was pallor present. General examination, patient is well oriented to time, place, and person. She was having a thin body build. Blood pressure was 100/10/60 mm of Hg. Pulse was 72 beats per minute. Cyanosis, clubbing, edema, lymphadenopathy was absent, but pallor was present. Systemic examination, CVS S1, S2 was normal. Respiratory system, vesicular breath sounds were heard. CNS sensory examination was normal, and musculoskeletal system, tone in arm, forearm, and hands were 4/5. Trunk was 3/5. Hips was 3/5. Legs 4/5, and ankles 5/5. Now coming to ocular examination, visual acuity in the right eye was 6/9 with pinhole no improvement, and the left eye 6/12 with pinhole no improvement. Fluorescein stain was negative in both the eyes. T-BUT was 12 seconds in both the eyes, and Schirmer's test was 15 mm both the eyes. IOP by NCT was 10 mm of Hg, and LPI was patent. Anterior segment, there's graying of eyelashes. Conjunctiva is squared of both the eyes. Cornea, there are few fine KPs were present. Anterior chamber was normal, iris was normal. Pupil was round, regular, and reactive, and lens had iris pigments over anterior capsule of the lens. This is a slit lamp picture. Then the fundus picture, right eye optic disc was normal. Size shape was normal, color was pink, even the vessels were normal of the right eye, only the macula seemed to be thinned out. FR was present. Of the left eye, optic disc was normal. There were FR seemed to be dull because of the scarring present, and there were numerous subretinal scarring present, which there were round regular regions and well defined, but they had pigments in the periphery suggestive of subretinal scarring, and they also showed numerous number of RPE alterations. B scan of the patient was normal. The OCT image of both the eyes, it showed slight thinning because in the right eye it was 174 micrometer, in the left eye it was 168. Provisional diagnosis was chronic non-granulomatous anterior uveitis of both the eyes. Investigations which were done, in that positive was ANA was positive, and hemoglobin was 7.4 gram per deciliter, which showed that the patient had pallor. RA factor. The patient was admitted in the pediatric ward and has been started with injection methylprednisolone, and rheumatology and dermatology consultation was advised. And from our side, eye drop prednisolone acetate 1% has been prescribed for the 6 times per day, and it has to be tapered weekly. Thank you.
But you didn't have posterior synechiae. Yes, it's only KPs. Yes. No posterior synechiae.
No, ma'am.
Okay. Audience want to add anything? Ophthalmologist? It's only KPs and vision is 6/6, and there is no posterior synechiae, no joint pain. Then
No, there were history of joint pain.
any marker for your systemic?
ANA was positive.
P?
ANA.
Is it ANA positive alone is enough for
No,
your?
ma'am, we've ordered for other investigations such as anti-dsDNA and anti-Smith. The reports are yet to come. The patient is admitted in the pediatric ward.
But still, only based on ANA, you have started immunosuppressive.
Yes.
Yeah, I think any other comments from the audience? Basically, for us to you said there was some rash over the face also.
Yes, and photosensitivity.
So there is photosensitivity, there is arthritis, so there is ANA positivity, and there is anemia. So we'll have to figure out whether this anemia is hemolytic, HB 7.4. So you'll have to use, you will have to look at the retic counts and look for the peripheral smear for indirect evidence of hemolysis and do the hemolytic workup. If it is hemolytic anemia, because platelet count was normal, right? And urine was also normal. There was no proteinuria, nothing. So then perhaps that's what we will have to do. And you're on the right lines. In addition to those immunological markers, the basic workup has to be done for this. Maybe the complement levels are. Yeah, next. I think we'll go to the, thank you very much. We'll go to the next case. Dr. Anurupa Vijayan.
So good evening all. I am going to present a case series of orbital inflammatory disease. These are the 6 cases recently came to our OPD. So introduction, orbital inflammatory disease represents a collection of inflammatory conditions affecting the orbit. It can be inflammation of the lacrimal gland known as dacryoadenitis, extraocular muscle myositis, or orbital adipose tissue. There is a wide heterogeneity in the clinical presentation that poses a great diagnostic challenge. So usual diagnostic pathway in orbital inflammation include clue from the clinical features of the patient, etiologic diagnosis of orbital inflammation with the help of pathological analysis, radiological and serological investigations. So this is the first case. This is a 71-year-old retired salesman with 9 months history of intermittent left eye followed by right eye pain, proptosis and restricted eye movements. And he had decreased vision with history of good response to oral steroids. On examination, he had bilateral 3rd and 6th cranial palsy, left eye proptosis with congestion in the left eye RAPD, and his vision was counting finger 1 meter. And the differential diagnosis thought were granulomatosis with polyangiitis, sarcoidosis, lymphoma, or IgG4 related disorder. And his investigations were essentially normal, including the anti-PR3, serum IgG4 level, everything were normal. An MRI orbit was done that showed right cavernous sinus thickening with extrusion to the orbital apex, right and left side, with soft tissue enhancement of the superior orbital fissure. So the DD were orbital apex syndrome or Tolosa-Hunt syndrome. So in view of episodic painful ophthalmoplegia with good response to steroids and soft tissue enhancement in the orbital apex and orbital fissure, he was diagnosed as Tolosa-Hunt syndrome, and he was treated with pulse steroids and later continued on oral tapered dose of steroids and mycophenolate as steroid sparing agent. Now his vision has improved to 6/9 both eyes and RAPD has resolved. So Tolosa-Hunt syndrome is a non-specific inflammation of the cavernous sinus and superior orbital fissure. Histopathological features can mimic idiopathic orbital pseudotumor, and clinical presentation is secondary to cavernous sinus inflammation characterized by cranial palsy involving the 3rd, 4th and the 6th and 1st and 2nd divisions of trigeminal nerve. Differential diagnosis may be sarcoidosis, pituitary tumors or lymphoma. And the disease is characterized by immediate and dramatic response to steroid therapy. The second case is a 14-year-old girl presented with left eye painful progressive orbital swelling with proptosis, extraocular muscle palsy and visual diminution. And on examination, she had ptosis, proptosis and restriction of abduction of the left eye. And investigations were essentially normal except for the raised ESR. CT orbit was done that was showing enhanced and thickening of the superior rectus muscle, lateral rectus muscle involving the tendinous insertion, and also there was involvement of medial and lateral rectus muscle and also involvement of the left lacrimal gland. So since there are multiple components inflammation, the differential was orbital pseudotumor. So she underwent lateral orbitotomy and excision biopsy, and this the biopsy showing extensive vasculitis with fibrinous degeneration in the vessel wall. And also this is the classic story from fibrosis with obliterative arthritis in this patient. So she was thought to have probable IgG4 related ophthalmic disease based on the diagnostic criteria of 2015. She was treated with oral steroids 1 mg/kg followed by rituximab. And a repeat MRI was done that was showing significant reduction in the muscle edema, and her pain and proptosis has improved. The third case is a 65-year-old male evaluated for weight loss. And on evaluation, he was found to have probable systemic IgG4 related disease based on CCT abdomen showing inflammatory tissue encasing the pancreas, inflammatory mass involving the paravertebral region from D6 to D12 vertebral levels, and also proptosis with diplopia of the left eye. CT orbit was showing proptosis of the left eye with involvement of the left extraocular muscles. There was soft tissue edema and involvement of the sinuses. So biopsy from the orbit was done that was suggestive of perivascular lymphocytic infiltrate, and his IgG4 level was very much elevated with a value of 2230 milligram per deciliter. So he was also thought to have possible IgG4 related disorder as the biopsy was not conclusive. And this is a fourth case. This is a 36-year-old lady presented with history of periorbital swelling, inflammatory polyarthritis, and she had improvement of these symptoms to steroids. And on evaluation with us, ANA profile was done that was found to have Rho52 3+. MRI brain with orbit was showing soft tissue swelling in the lacrimal gland suggestive of dacrocystadenitis. So she underwent biopsy of the lesion that was showing extensive perivascular lymphocytic infiltrate, but it is not obliterating the blood vessels. So it was suggestive of lacrimal gland involvement secondary to Sjogren's syndrome. She was treated with steroids 1 milligram per kilogram, and now she is doing extremely well with tapered dose of steroids and mycophenolate mofetil. And this is the fifth case. This is a 47-year-old nurse presented with left eye proptosis and diplopia since 2017. MRI brain with orbit showed involvement of multiple.
Done. We are off with the time. Is this the last case?
Yeah, yes.
Okay.
So she had multiple extraocular muscle involvement, and a Holter was done that was showing first degree AV block and supraventricular ectopic. A PET myocardial study was done which showed myocarditis. She was treated with steroids, and tapering dose of steroids with methotrexate was continued. A repeat PET scan showed complete resolution of the myocarditis. In April 2021, she developed complete heart block, and a permanent pacemaker insertion was required. That time, the cardiologist stopped steroids and methotrexate, but few months later, she again had relapse of the proptosis of the left eye, and workup done was negative for GP and IgG4 related disease. So in view of complete heart block and orbital tumor, she was diagnosed as probable sarcoidosis. Now she is doing well with tapered dose of steroids. One more case.
Any questions from the audience? Okay.
Thank you for interesting cases. I think all of them present a good clinical challenge when we are treating those patients. The next one is Dr. Ghazal Patnaik. Dr. Ghazal. So I think there are 1, 2, 3, 8 more presenters. In the interest of time, the other presenters can share the presentation with the team so that we don't have to change the laptops again and again. I think she can start her presentation.
Good evening, everyone. Respected panelists, myself, Dr. Ghazal Patnaik, and I shall be presenting our work on role of biologic agents in uveitis and scleritis. So before going into details of our study, I would like to say that in a day-to-day OPD of a uveitis specialist, we come to see patients with hypopia and uveitis more often, and it has been discussed since today morning that HLA B27 is kind of a ping pong type of uveitis. So the patient is treated, then again comes with recurrent like this. Patient is made understood that this is HLA B27, patient understands, but then again the patient asks why so much of recurrences, why so frequently. Another case we see with fluorescein angiography features of this type of leakage, well discussed about Behçet's disease, but apart from so much of immunosuppressions, combination therapy, but the fluorescein does not just go away. Third scenario is of a young lady with diffuse anterior scleritis, with so much of immunosuppression, again, patient relieved of pain, but redness still persists. Initially, after the corticosteroids came corticosteroid sparing agents, that is immunomodulatory therapy. But now what to do in these scenarios? So that was the base of our study to evaluate the effectiveness of biologic therapy in patients with refractory non-infectious uveitis and scleritis, and we had a retrospective study of those patients not responding or had a high recurrence rate with the conventional treatment and had received biologics. So it was a 6 years duration. 23 patients were treated with the newer biologic therapy. And we divided the patient into 3 groups: adalimumab, infliximab, golimumab, and all were under the rheumatologist care. We had 18 in the group of adalimumab, 4 in infliximab. However, 9 were lost in adalimumab and 1 lost in infliximab. So we took the remaining who had around 6 months of follow-up minimum for the further analysis. This is the detailed demographic profile of the adalimumab group. What I want to focus is, although the patient's recurrence rate has reduced after the arrow is not working. So as can be seen, after using the adalimumab, the recurrences rates has reduced. Only 1 patient of HLA-B27 has 1 recurrence after the adalimumab. But what is more eye-catching in this study was that apart from the recurrence rate, apart from the co-medication needed to control the inflammation, anti-glaucoma medication, the number could also be reduced from 3 to 1 in one case and 1 to 0 in another case. However, 1 was needed to be maintained on 1. Similarly, in infliximab, the recurrences rated and the golimumab 1 patient, the recurrence rate was 0. Also, in 1 case, I would like to highlight AGV, that is Ahmed glaucoma wall, that is glaucoma drainage device, that was being suggested, but after starting the infliximab, that could be deferred. So, like various studies are from abroad regarding the biologic efficacy. There is only 1 Indian study that has analyzed the study in 18 cases from South India. These are the cohort of patients that they analyzed, which is quite different from our patients. And what they have analyzed is the recurrence rates and the medications on the maintenance. In our study, we also have analyzed the efficacy in case of management of glaucoma as the silent killer. So I would like to conclude that biologic therapy is effective in non-infectious refractory uveitis and scleritis. Those are earlier resistant to conventional therapy, and they help in controlling the inflammation, the severity, and the risk of recurrences. Thank you.
Any questions from the audience? Is it all these patients received immunosuppressive and then new biologicals?
Yes, ma'am. Everybody have received either a combination. If permits, I can show. Okay. So most of them have received combination also, like methotrexate, MMF, Azora, and cyclosporin.
And only new finding you have found out is 4 cases glaucoma treatment was
yes,
not needed.
ma'am.
Okay, good.
Thank you.
There is one.
Yeah, so like I said, like 4 patients total that has to be on anti-glaucoma medications. So 2 were on 3 anti-glaucoma medications, medical therapy. So the number of drugs can be reduced to 1.
What medical therapy, what group of drugs they were on?
So that was managed by our glaucoma consultant, but they were on Combigan, Dozox, and Timolol, Combigan, that combination. So it was reduced to only glucomol at the end. And 1 patient did not need any glaucoma medication. And another patient had 5, all the anti-glaucoma medications, and was then posted for glaucoma drainage device. But after starting that patient did not need a single drop of anti-glaucoma medication.
Okay, thank you. You have a question?
No, I was just wanted to, I was wondering whether they were on pilocarpine or prostaglandin.
No prostaglandins. Pilocarpine I have to look because that was dealt by our glaucoma consultant.
Okay, thank you.
Thank you. Thank you.
Now we call upon Dr. Ipsita Muni. Maybe spelling mistake can come.
Good afternoon, everyone. My presentation is titled Peripheral Ulcerative Keratitis, a crossroad between ophthalmic and systemic management. So to introduce my topic, peripheral ulcerative keratitis is a destructive inflammatory disease of the juxtalimbal cornea associated with the crescent-shaped corneal stromal thinning, an epithelial defect, and stromal inflammatory cell infiltration, as can be seen through this representative image. PUK can be infectious or non-infectious. Nearly half of all cases of non-infectious PUK are found to have an associated connective tissue disorder. The objectives of my presentation are to demonstrate that ocular manifestations can be a presenting feature of connective tissue disorders and to highlight the role of multidisciplinary approach for the successful management of these conditions. Coming to my case, the patient was a 25-year-old male resident of Jagannathpur, Jharkhand, who presented with a chief complaint of pain and redness in the left eye since one day. Tissue adhesive and bandage contact lens had been applied elsewhere, and in the history, he had been treated as viral keratitis for 2 years. So on presentation, his right eye, the best corrected visual acuity was 20/40 parts. The eyelid and conjunctiva were normal. In the cornea, there was a vascularized nebular scar present inferiorly. In the left eye, the best corrected visual acuity was 20/320. In the cornea, there was a bandage contact lens in situ. However, underneath, there was a perforated corneal ulcer with iris tissue prolapse in the inferior quadrant, which was a sign, and the feature of a sterile corneal melt was present. So we went ahead and did an AC reformation, a tissue adhesive and BCL application for this patient. In the post-operative 1 day, the best corrected visual acuity was 20/200 and the tissue adhesive BCL was in situ. The patient was started on topical prednisolone acetate 6 times per day, along with a prophylactic antibiotic and topical lubricating agents. In the post-operative 11th day, the vision had improved to 20/40 and the topical steroids were tapered slowly. And in the post-operative period 1 month, the cornea had healed and so the TABCL was removed. At this time period, a systemic workup to rule out any connective tissue disorder was done, and the patient was found to have an elevated P-ANCA levels. However, the C-ANCA, HLA-B27, CBC, ESR, CRP, LFT, and RFT were normal. Based on these reports, the patient was, a rheumatology referral was done. In the rheumatology clinic, the patient was given 3 doses of cyclophosphamide 750 milligrams as per European Vasculitis Society protocol and was discharged on tablet methotrexate and tablet folic acid 5 mg. In the period between 2000 to 2029, he had on and off use of medications due to financial constraints, and he also had intermittent follow-up. He was not following up regularly. In the in the left eye, the best corrected visual acuity was 20/40. The corneal condition was stable. However, periodically inflammation was found. So the patient was given prednisolone acetate topically, QID for 1 week, followed by slow taper. And subsequently, he was lost to follow-up for 5 months. In December 2019, he presented with a chief complaint of left eye redness, pain and watering since 1 day, and he had discontinued his topical and systemic immunosuppressive agents. His best corrected visual acuity was 20/40, and as can be seen from this photo, an inferior desmetocele with surrounding vascularized corneal scar was found. A tissue adhesive with BCL application was done, and in June 2022, the TABCL was removed. However, after removal, the AC was flat, and so a repeat TABCL was done. And in September 2020, the TABCL was removed again, followed by AC flattening, and so a multi-layered amniotic graft was done. This is an image of the amniotic graft with multiple overlay sutures. In the patient a repeat rheumatology consultation was done. And in day 1, 2, and 3, the patient was given injection methylprednisolone 1 gram. In day 4, he was given injection cyclophosphamide, and day 19, he was given a repeat injection cyclophosphamide. Following this, oral corticosteroids was initiated. By January 2020, the AMG has disintegrated and ASOCD was done. The right eye was normal in thickness with a small nebular scars in the central cornea. Whereas inferiorly, the BCL, we can see the BCL and the disorganized corneal structure inferiorly with corneal stromal. The BCL was removed and the patient was continued on tablet prednisolone and topical immunosuppressive agents.
Hello.
The patient was lost to follow-up until July 2022 and presented in rheumatology department with complaint of left-sided hip joint pain. He was advised X-ray pelvis and referred for ophthalmology consultation to rule out active eye disease. However, the eye was quiescent.
How many slides are left, beta? Perhaps you will have to summarize. Yeah, yeah. Okay. Go ahead.
So basically, through this presentation, we wanted to highlight the importance of both correct ocular and systemic management of PUK. Initially, the patient has been misdiagnosed with viral keratitis due to a history of recurrent redness and a vascular scar. He had presented with a sterile corneal melt. So we had started him on topical immunosuppressants and the ocular condition had stabilized. So this highlights the importance of correct ocular diagnosis. And based on the presentation, we had conducted the required investigations. P-ANCA was found to be positive and the patient was started on systemic immunosuppressants as per rheumatology consultation. And the condition was stable until the patient himself discontinued the medication, which highlights the importance of systemic management. So to conclude my case, ocular manifestations such as PUK may be the presenting feature of serious underlying systemic disorder. Systemic workup and general physical examination is crucial in the management of PUK. Treatment results are generally disappointing unless aggressive management of systemic disease is taken into consideration. And in order to ensure compliance, patients should be educated about the need for long-term use of topical and systemic medications and long-term follow-up. Thank you.
Thank you. I think no more question, only one comment. P-ANCA, you said P-ANCA, but there was a level given with international units, 96 or 94. So ANCA is done by two methods. One is immunofluorescence, in which it is a cytoplasmic or perinuclear, where you don't have those levels. Because P-ANCA is relatively non-specific. And if these levels are given, I presume it is MPO. So P-ANCA, which is an immunofluorescence, can be due to various positive due to various antigens, and one of them is MPO. So it is probably MPO positivity. There can be non-MPO P-ANCA positivities also, which has less clinical relevance for the rheumatologist. That might be because of infections, drugs, various other things. So that is one thing which we all need to remember. Thank you. I think all those who finish within 5 minutes will get credits. And those who go beyond 5 minutes, yeah. Just there here. Yes, Obro.
How long was cyclophosphamide given? I think in the second case, it was only 2 doses, right?
3 doses.
3 doses.
Then again, the next time 2 doses?
The first time, it was only 2 doses. But generally, I mean, in vasculitis, we gave up to 6 months because just 2 doses, patient would recur. And ANCA-associated vasculitis.
The reason that it perhaps one of the reasons might have been in the previously also only 3 pulses were given. And now I presume it was September 2020. More such pulses, Dr. Abra is very right. More such pulses should have been given. I think this is inadequate treatment of a disease which can not only take away the eye, but can take away the life. Yeah. Yeah. Those are the challenges, yes. Those are real life challenges. But for academic purposes, one has to remember that if the patient doesn't get treatment the way it should be, the disease either will come back in the organ or in the eye or other organs. Thank you very much. So the next presenter is Dr. Pranavi. Do we have Dr. Pranavi here? Yes, please. We would appreciate finishing off within 4 minutes the first bus and definitely not beyond the second bus.
Good evening, everyone. I'm going to present a case of proptosis, blocked nose, and facial palsy. A 32-year-old female patient. A 32-year-old female patient with no prior comorbidities presented with epistaxis, nasal obstruction, productive cough, and with intermittent fever of 6 weeks duration. She also had ear discharge for 4 weeks. Then she went to a local outside hospital where X-ray PNS was done and it showed pansinusitis. And then she was prescribed antibiotics. But patient was not feeling symptomatically better after the treatment. Then she came to our hospital ENT department with headache and worsening of her previous symptoms along with deafness and trismus of 15 days duration. She doesn't have any history of joint pains, no history of hemoptysis, there were no recurrent oral ulcers, no history of any skin rash, there is no history of vomiting, diarrhea, abdominal pain or reduced nutrition. On examination, she has pallor, no other cyanosis, clubbing or icterus, and her vitals were stable. And local examination revealed gum hypertrophy with petechiae, left-sided proptosis, and ear examination showed bilateral active ear discharge with bilateral tympanic membrane perforation, and sinus tenderness was present. On systemic examination, the patient cardiovascular respiratory examination was normal, her abdomen was also normal, a nervous system examination was showing left-sided element facial palsy, and there were no other deficit. Features suggestive of left-sided element facial palsy, like she had a lack of thalamus and also deviation of the angle of mouth towards the right side, and there were absence of wrinkles on the left side of the forehead. And at this point, our differential diagnosis included bacterial pansinusitis, which was partially treated with CSOM, and fungal infections like histoplasmosis and ANCA-associated vasculitis and nasopharyngeal tumor with secondary infection. So we proceeded to the investigations. Our routine investigations revealed like anemia. It showed anemia with neutrophilic leukocytosis, and there was thrombocytosis, and routine urine examination was normal except for trace proteinuria, and acute phase reactants were elevated. And procalcitonin was done to rule out any infection. It was normal, it was in the non-sepsis range, and sputum for AFB was negative, and sputum for gram stain showed plenty of pus with few gram-positive cocci, and fungal staining was negative. So we, in view of the sinus tenderness, CT PNS was done, which showed like pansinusitis picture. There was haziness. There was haziness in the maxillary sinus and also in the ethmoid sinus, and also unilateral single-sided sphenoid sinus haziness was there. And the chest X-ray revealed a cavitating nodule in the right upper lobe of the lung. And HRCT thorax was advised at this point, which revealed a cavitating nodule in the right upper lobe and surrounded by hyperdense lesion. And it also showed ground glassing opacity with air bronchogram picture. And nasal mucosal biopsy was also done to the patient. It revealed an inflammatory like extravasation of the RBC in the vessel wall, and also there was a granuloma with central necrosis. And C-ANCA profile was done at this point, and C-ANCA was positive of 189, titer was 189, and the diagnosis of ANCA-associated vasculitis was made. So the patient was started with, she was pulsed with injection methylprednisolone with 15 mg per kg for 3 days, and then we proceeded to cyclophosphamide injection according to US protocol. So we gave like 3 doses of, 2 doses we gave initially. The patient was improving symptomatically. All her symptoms have reduced. And when she came for the 3rd dose of cyclophosphamide, she had increasing productive cough associated with hemoptysis. And she was unable to lie down because of the vigorous coughing. And we did a sputum culture was done at this point, and she had it was positive for Klebsiella and Pseudomonas, and HRCT was also repeated in view of the increasing cough and orthopnea, and it showed large irregular cavity in the right upper lobe of the lung and with new nodules. This is the repeat HRCT. The first HRCT, it was showing like a irregular cavity in the right upper lobe, and the second HRCT, there was a the size of the cavity has grossly increased, and it was also showing multiple nodules in the lung, periphery of the lung, And then she was started on antibiotics. After 1 week of IV antibiotics, injection rituximab 1 gram was given. It was repeated. Second dose also was repeated after 2 weeks. And now the patient is improving symptomatically. Her cough and dyspnea has reduced, and she is able to lie down comfortably. The discussion is limited GPA. Like this patient looks like a limited GPA. When she came to ENT department, she was having only the deafness epistaxis without any lung involvement, except for the cough part. And so the limited GPA is one with patients with clinical findings isolated to the upper respiratory tract or lung. Limited GPA disease is a confusing term because the disease could be severe. The current practice is to describe the locations of the organ involvement and severity of disease at each location. The take-home message is the person with lag ophthalmos, sinusitis, and facial palsy, consideration of GPA should be made, and the concept of a limited GPA is being reconstructed. Thank you.
Excellent. Nice presentation. Based upon your initial first slide, the patient presented with hearing impairment, sinus disease. In your differential, you said infection, something else, and then GPA. How common is it for infection to present for the first time with hearing impairment?
CSOM can present us.
I mean, we have a sinus disease, we simultaneously CSOM occurring without discharge and presenting with hearing impairment with the shortest history. How common do you think it would be? You see, what I'm trying to say is, when you have hearing impairment, that's what I was saying in the morning. It's a very strong pointer to a systemic disease like vasculitis. All right, so you have to reorder your, and can we have your presentation again? Can you show me your gums? What was there in the gums? The other clue, which would have been a clincher, would have come from the gums. Can we have the presentation on her presentation? Did you recognize there was something? Was it mimicking something? Can we go to the gums?
Gums.
One. You know what's probably this picture is not very good, but perhaps what is happening here, this is what you call as strawberry gums. And if you see strawberry gums are very pathognomonic of GPA. You've seen strawberry, no? Probably if you see this carefully, the changes, although it's not very good picture, but the changes here and the changes here are like strawberry gums. So if it is a but strawberry gums is quite a specific for, it's not only hypertrophy. You see something, you've seen a strawberry picture, you see the dots in that strawberry. So not only it is a gum hypertrophy, but you see those depressions also like a strawberry. So if this is there, this is GPA.
Even in conjunctiva, you can see similar.
Yeah.
Yes, ma'am. Actually, at this point of time only, we thought of a vasculitis when.
Great, good. I'm just saying this is for the learning point for the audience. Good presentation. We're just having discussion. Any questions? Thank you. And you finished in time.
We call upon Premchand Parida. Students can sit in front so they can come fast. We have 5 more presentations. Please proceed.
Slide put as well. Next slide. Good evening, everyone. My case is a rare case of ANCA-associated pseudotumor orbitalis. My guide was Dr. Soumya Ranjan Tripathi, Assistant Professor, Department of Rheumatology in SCV Medical College, Cuttack. The chief complaint was that there is a 24-year female presented with headache for 1 month and right eye retroorbital pain for 1 month. On history of present illness, the patient was apparently all right for 1 month. To start with, she developed right hemicranial, doll-lacking headache that was insidious in onset, gradually progressive and persisting throughout the day. It was not associated with any aura, photophobia, phonophobia, nausea, or vomiting. We noticed the maximum intensity of pain seemed to be behind the right eye. There was no changes in the visual acuity or field. On clinical examination, it pulse is 84 minute and BP is 116 by 84 millimeter mercury, and his afebrile, there is no pallor icterus, cyanosis, and clogging pedal edema, lymphadenopathy, raised JVP or thoramegaly. On systemic examination, nothing suggested. But on the local examination of the eye, there is minimal proptosis of the right eye, and the extraocular movement are full and free in all directions, and fundoscopy is normal. But the intraocular pressure also is normal in both eyes. And further investigation, there is only inflammatory marker ESR is elevated. This is 55 millimeter on faster, and rest everything is normal. Even thyroid is normal. On NCCT of right orbit, there is proptosis of the right eye one, and there is hypertense space occupying lesion of size 10 into 9 millimeter in the right retrovalvular region. On MRI, there is MRI brain and angiography are normal, but the MRI orbit reveals there is intensely enhancing soft tissue showing iso to mild hypointense T2 signal in the right orbit located intraconal retrovalvular fat with the involvement of medial and inferior rectus muscle. After getting this note, the differential diagnosis are 3: sarcoidosis, granulomatosis, polyangiitis, and IgG4 disease. On further evaluation, Monto is negative, serum angiotensin converting enzyme is normal, chest radiograph is normal, ultrasound is normal, serum IgG4 is also normal, CT-PNS is normal, and on ANCA, anti-MPO is 74.57 unit per ml, which is strongly positive, and anti-PR3 is 4.86, which is negative. And the biopsy was not possible because of the location of the mass after ophthalmological consultation. And the diagnosis was made as a pseudotumor orbitalis. Maybe etiology is ANCA-associated vasculitis, and patient was started on 40 milligram prednisolone and 10 milligram methotrexate per week. After around 6 weeks, the patient is completely pain and headache is subsided. Now patient is on 20 milligram methotrexate and on 2.5 milligram prednisolone. Thank you.
Any questions from the audience?
I think for how long is the follow-up since the patient is on 2.5 milligram prednisolone and methotrexate now?
Now patient, this case is around 6 months now. So now the patient is on 20 milligram methotrexate and 2.5 milligram of prednisolone. Sorry, we started 20, now it is on, I started on 10, now it is on 20.
Because to give, it's fine, the patient is doing well, you'll have to keep a follow-up because the risk of flare in such situation is higher. I think Dr. Abro has a question.
Is to you for orbital involvement, should we give methotrexate or cyclo?
I think I would have used cyclo or rituximab, either of these two, depending upon. Methotrexate is probably, if you have to use methotrexate, you know, if you have, see the EULAR EDTA recommendations, very, very limited conditions in which you can use methotrexate. Practically none actually. In all those where you could, and the concept of localized and a limited disease also. Yeah, localized disease, limited disease, a very old concept came in 1960s, wherein some people said that no lung, no kidney. The other people believe that it should be only nodules in the lung. These should be non-cavitating nodules. If you have cavitating nodules, there was evidence of lung hemorrhage in the previous patient. You can't call it localized disease. Lung hemorrhage is a systemic disease, capillaritis. So non-cavitating small nodules, you might say it is a limited disease or a localized disease. But in practical experience, all of them, the disease will come back with a bang. So perhaps it's a better idea to use maybe cyclophosphamide or rituximab, because the problem with this is, and we were discussing in the morning, even, you know, many times they just have joint disease and rheumatoid factor positivity and some nerve and some sinus disease, which can occur in GPA. You give steroid and methotrexate, it gets left for a while. But the next time the patient comes with RPRF, you see, because they cannot hold it forever. It can hold it for some time. And that holding back is also because of higher steroids. The fear is the moment you decrease steroids, this disease is going to come back and hit. That's the.
Sir?
If ANCA is negative, what would you do?
Because biopsy is not possible, you are telling. So if say supposedly ANCA is negative, then what will you do?
So we'll only go for steroids.
Very good. And given the differentials that you have, which drug would you use? You have a differential of IgG4, you have a differential of sarcoid, you have a differential of GPA. So what other steroid sparing drug would you use, which will practically act in all 2 or 3, even third one also?
Sir, cyclomethotrexate.
Cyclo or rituximab. Methotrexate doesn't do very well with IgG4.
Yes.
I mean, either steroids work in all, or perhaps rituximab, which works in all too, and perhaps in sarcoid also in some. There would be case reports of use of rituximab in sarcoid also. Thank you.
Thank you, sir.
So the next presenter is Dr. Rashwit UI from Padmanabha Shenoy Center. Dr. Rashwit, please.
Shall I start? Good evening, everyone. I am Dr. Rashwit, the R&B resident, Sudhindra Hospital, Care Kochi. I am going to present a case report. Coming to the introduction, the sclera is the white part of the eye, which is a strong tissue, which covers almost 5/6 of the eye wall, protecting the eye. The inflammation of the sclera is called scleritis, which is usually extremely painful and can be even destructive and potentially blinding condition also. When it comes to the scleral inflammation, the main thing will be differentiating episcleritis and scleritis. Usually episcleritis is associated with a milder pain and dilated vessels because of the superficial blood vessels and blanchability with phenylephrine drops. After differentiating this, scleritis is divided into anterior and the posterior, anterior being the most common, and later which is divided into necrotizing and non-necrotizing. Considering the potential dangerous condition of necrotizing scleritis, it has been discussed here, and its incidence also almost 10 to 15% when compared to others. Coming to the case report. Ours was a patient, 51-year-old female who was a long-standing diabetes mellitus who presented with history of recurrent attacks of pain and redness in the left eye for almost last 9 years. She was treated elsewhere with oral steroids, which went up to 0.5 mg per kg, and even anti-tubercular therapy with poor response. She did not have any other past significant CTD or family history. Later, when she presented to us with the persisting symptoms, she was evaluated. On examination, the best corrected visual acuity was 6/7.5, N6 in the right eye, and counting fingers at 3 meters and N36 in the left eye. The slit lamp examination showed inflammation of the temporal bulbar conjunctiva, anterior chamber cells, and diffuse swelling of the temporal sclera with areas of necrosis. And the fundoscopy revealed vitritis and the exudative retinal detachment. Hence, the diagnosis of necrotizing scleritis of the left eye was made, and since autoimmune association is there, she was worked up with autoimmune antibodies. ESA was found 25, serum AS level and chest X-ray were found normal, and antibodies ANA, rheumatoid factor, ACCP, MPO, PR3 all were found negative. Hence, considering inadequate response to previous systemic steroids, negative autoimmune workup, she was taken up for scleral biopsy. Looking at the normal biopsy of the sclera, which shows collagen fibers, scleritis shows inflammatory infiltrates. Coming to our patient's HPE, which showed dense infiltrates of the lymphocytes and plasma cells with perivascular arrangement of the lymphoplasmacytic cells and obliterative phlebitis, which was suggestive of IgG4 related disease. Hence, considering organ-threatening condition, she was treated with pulse methylprednisolone for 3 days, followed by 0.5 mg per kg steroids, and along with rituximab as the secondary immunosuppressant. We can see in the image, at the 3rd month follow-up, our best corrected visual acuity in the left eye was improved to 6/12, N12, and the scleral inflammation had reduced with the resolution of the exudative retinal detachment. Discussion. IgG4 related disease is a multi-organ disease which is characterized by the tumefactive lesions in the multiple organs, and the HPE shows IgG4 positive cells, storiform fibrosis, and obliterative phlebitis. In the image, we can see it can involve almost all the organs of the body. In the orbit, it commonly affects the lacrimal gland and can also affect other structures like extraorbital muscles, orbital fat, eyelid, and the infraorbital or supraorbital nerves. Even though diffuse and nodular scleritis have been reported with IgG4 related disease, necrotizing scleritis has been rarely reported. In our case, patient had a single organ involvement and distopath features suggestive of IgG4 related disease, and she was labeled as possible IgG4 and she was treated for the same. Systemic steroids are the first line therapies, with the second line being methotrexate, azathioprine, and rituximab. Since she had pre-existing transaminitis, she received rituximab as the second line, with which she had both symptomatic and clinical improvement. Coming to the conclusion, IgG4 related disease presenting as isolated scleritis is very rare and has to be considered in the DD of scleritis. And when there is inconclusive approach or non-responsive to treatment, always biopsy will be the gold standard. Thank you.
Good presentation. Any questions from the audience? Yeah, yes, sir. Occasionally we do scleral biopsies, sir. When we are not able to differentiate the infectious versus non-infectious, we do scleral biopsy.
Thinking of IgG4 disease is something
Yes, sir.
quite rare.
Can be published.
I think tissue is the issue. I mean, unless the thing is the spectrum of the presentations of IgG4 in only expanding. Previously, we had one patient with vertebral involvement and the world did. I mean, we sent for review. The people were not believing that the bone involvement occurs. Now we have more and more cases showing bone involvement, destruction of the bones and all that. So as more biopsies are done, as more case reports are published, we are going to see more and more spectrum of this presentation expanding like data to probably IgG4 is also expanding. Thank you very much. Nice presentation.
Thanks.
We call upon Pratibha Behra. The presenters can come in front, so you can come fast.
While Dr. Pratibha is coming up the dais, we would request Dr. Ghazal, Dr. Shanmugananda and Dr. Akash Sharma to be in the first row on my right side on the sofas. You can sit in front, no problem. We're going to occupy these chairs one day.
So can I start?
Yes, please.
Good evening to all the delegates present here. I am presenting a case under the guidance of Professor Dr. Suchitra Das. 41-year female from Khordha, Odisha, presented to our OPD with chief complaints of pain, redness, photophobia of left eye for 5 days. Coming to the history of present illness, the patient was apparently all right 5 days back. To start with, she developed pain, redness with gradual diminution of vision of left eye, which was associated with watering, photophobia and floaters. History of low-grade fever was present 10 days back. No history of any skin, oral or genital lesions present. No history of any trauma or any blood discarriage is present. No history of any drug intake. She had taken some eye drops from local store, but symptoms didn't subside. She had similar attack 3 years back, for which she had taken eye drops from the local store. She had similar 5 to 6 episodes in those 2 years, which was unilateral and alternating in nature. After that, she went to a private hospital for gross diminution of vision, where she was treated with posterior subtenon triamcinolone injection for both the eyes 1 year back. She had history of intermittent episodes of joint pain, mainly knee and the ankle, which worsens in the morning, for which she took medications 2 years back. No history of any other chronic illness is present. No history of any loss of appetite or contact with any TB patient present. General examination was within normal limit. Systemic examination was within normal limit. Coming to the ocular examination of the right eye, the visual acuity was 6/18 with pinhole improving to 6/12. Near vision was N8. The BCVA was corrected to 6/9 by giving plus 0.75 spherical lenses, and plus 1 spherical lenses is given for the near vision. IOP by NCT is 17 mm of Hg, LPI is pattern, and retinoscopy is plus 1.75 in both the meridians. Coming to the visual acuity of the left eye, it was CF 2 meters with pinhole, no improvement. Near vision was N36, not improving with glasses. IOP was normal, that is 13 mm of Hg, LPI was pattern, and in the retinoscopy, faint glow was noticed. Coming to the anterior segment examination, the right eye was within normal limit. Coming to the left eye, eyelid has mild edematous, eyelashes are normal. In the conjunctiva, conjunctival congestion, circumcorneal congestion is present. Cornea is mild hazy due to corneal edema. Few fine fresh capillaries are present in the corneal endothelium. Aqueous flare is present, which is 2+. Iris color pattern normal.
Pupil is round, irregular due to posterior synecdoche and sluggishly reacting to light. And in lens few pigment dispersion present over the anterior lens capsule. These are the pictures. Coming to the posterior segment examination, in the right eye, the ocular media is hazy due to vitreous haze, but macular FR is present. In the left eye, the macular FR is absent. Optic disc is within normal limit, but the periphery is not seen due to the vitreous haze. Then we have done the B scan of the patient. The right eye shows some vitreous opacities, and the left eye shows vitreous opacities which are more, and vitreous exudative membrane is seen in the vitreous. Coming to the OCD, the right eye is normal, and the left eye cystoid macular edema is seen. Coming to the provisional diagnosis, acute non-granulomatous anterior uveitis, which is complicated with vitritis and CME in the left eye, and vitreous haze in the right eye. Then investigation was sent. CBC shows neutrophilic leukocytosis. HLA-B27 is positive. CRP is positive. ASO titer is positive. Urine shows plenty of plus cells, and other investigations were within normal limits. Then we have treated the patient with eye drop prednisolone acetate, which was tapered weekly, the eye drop homide, and eye drop nepafinac, and oral steroids was given. And the patient was sent for the rheumatology consultation to start the methotrexate, oral methotrexate. Thank you.
B27, you never get bilateral simultaneously, and also you say posterior segment involvement as well, and in anterior uveitis, topical steroid is enough. You don't go for methotrexate when other systems are normal.
Madam, she has joint pain for 2 years, but it was a neglected case, ma'am. So,
but you told rheumatologist didn't agree with the diagnosis, no?
What?
Rheumatologist found the diagnosis, ankylosing spondylitis.
Actually, we have advised for the rheumatology consultation. She has gone. She has been being treated at a local store only.
Yes, so the diagnosis is not confirmed by rheumatologist as well. It is only ophthalmological finding and anterior uveitis only. Then it should be a topical steroid. Without confirmation, you cannot go for immunosuppressive, and it is a bilateral disease.
Yes. We have advised for rheumatology consultation to start methods.
No, even then it is a bilateral disease. It's not typical. Okay. Thank you.
Thank you, ma'am. Thank you so much.
Ghazal Patnaik. We call upon Ghazal Patnaik. A second, no? Okay. Then Dr. Shanmuga Sundaram. Shanmuga Sundaram. Come.
Shall I start? Good evening, all. A 14-year-old female presented with complaints of diminution of vision in right eye for 20 days, which is insidious in onset and progressive, associated with a dull aching pain and piercing sensation, also associated with a diffuse dull aching headache, which is more in the temporal area. Then it is aggravated on eye movements, relieved with medications. There is also a history of minor head trauma 20 days back. Then it is not associated with any other systemic symptomatic symptoms. Then not a diabetic, not a hypertensive. Then no history of any joint pain, no other systemic complaints. And there is no significant personal and family history, belongs to a middle socioeconomic status. Then patient is not taking any medication for this condition outside, for this complaint outside. And general examination, patient is conscious oriented. All the other systemic examination findings are within normal limits. Then on ocular examination, right eye is showing having the best corrected visual acuity of 660 and right eye is 6.6. On intraocular pressure by NCT It is 19 in right eye and 14 in left eye. Other color vision 25 by 25 on ECG graph chart in both eyes. Then extraocular movements are full and free, and it is mildly painful in the right eye. Then facial symmetry, eyelid and conjunctiva and other anterior segment findings are within normal in left eye, and sclera shows congestion of lateral canthus in the right eye. Then lens shows clear in both eyes and no retrolental cells and flare. And posterior segment examination, right eye showing a hyperemic disc with margins blurred and surrounding edema, and macula is foveal reflex is dull and suspective of subretinal fluids, and peripheral retina showing infranasally there is more dome shaped elevation suggestive of retinal detachment, and supranasally there is a raised deep lesion suggestive of choroidal mass. Left eye fundoscopy is normal, and differential diagnosis of posterior scleritis, choroidal mass and optic neuritis and VKH has been made. So choroidal mass has been ruled out because of pain and young age presentation, and optic neuritis has been ruled out because of good visual acuity and normal color vision and congestion, and there is no typical course. Then VKH has been ruled out as the patient has pain and there is no cells in the anterior chamber and the lens also. So the provisional diagnosis of right eye posterior scleritis has been made, and the patient is subjected to fundus fluorescent angiography. It's showing in the early phase of showing effervescence in the disc area, and in the late phase showing choroidal stains. And blood investigations were turned out to be normal and within normal limits and negative also. Then treatment started with IV methylprednisolone of 600 mg for 5 days and followed by oral prednisolone of dosage 1 milligram per kg body weight. Then capsule indomethacin 75 mg per day has been started, associated with other supportive treatments, and pediatric consultation to rule out any systemic autoimmune diseases. Then on post-treatment with IVMP, after 1 week, vision is improved up to 612 with resolving disc edema, and the B-scan findings of a post-scleral thickening has been reduced after 1 week. Then OCT, there is a subretinal fluid at the macula. It is also reduced after 1 week of IVMP therapy. So after follow-up of 2 months, patient has no complaints with vision 6/6 on both eyes with slit lamp examination. Anterior segment are within normal limits, and posterior segment examination showing mild disc margin blurring in the right eye only. So the patient is referred to pediatrics department to any need for immunosuppressives or not for further evaluation. So the scleritis is more important as because more than half of the scleritis patient will have an underlying systemic disease. So scleritis needs multidisciplinary approach. So like management from mainly from ophthalmology and rheumatologist, sometimes in special cases like pediatrics and any respiratory involvement, so pulmonology consultation also needed. Thank you.
Okay. Any questions from audience? See, this is a unilateral disease, and you are not supposed to have VKH in differential diagnosis because that is definitely bilateral. And you had a differential diagnosis of optic neuritis. When you have a scleral lesion with the exudative detachment, it cannot be pure optic neuritis. And one more thing, your differential diagnosis also had masquerade syndrome, metastasis. But you didn't do any workup to rule out that. You directly gone.
B-scan, it doesn't show any mass in the scleral or choroidal area.
Which one? Which one?
B-scan.
B-scan alone you have done. But if it is a secondary?
The further evaluation has to be done.
Yeah, and tuberculosis, that was also one of the differential diagnoses. So that should be ruled out. So
chest X-ray is done, ma'am. Then chest X-ray is clear, and patient is also having no symptoms of any cough.
But do you think only chest X-ray is enough to rule out tuberculosis? It could be extrapulmonary tuberculosis. You didn't present that you ruled out extrapulmonary and pulmonary tuberculosis.
Okay.
That should be added. Thank you.
Thank you.
Call upon Sharma, Dr. Sharma.
So good evening. I welcome you all to the last presentation of today. Everything inflammable, a diagnostic dilemma. So the objectives of today's talk are to understand the clinical and investigative workup to reach a diagnosis in complex cases like this one, to stress need of long-term follow-up of cases to see the broad spectrum of diseases, and to understand the role of early multidisciplinary approach in such cases. Coming on to the case, a 68-year-old female presented with complaints of pain, redness, and increase in diminution of vision since 2 months. She had undergone cataract surgery 9 months ago, and she had gradual painless diminution of vision since 7 months. Her uncorrected visual acuity was counting finger 1 meter.
She has 2 eyes. No, which eye she underwent cataract surgery and which eye had
Right eye.
painless.
Right eye.
Right eye had painless loss of vision.
Yes. Presenting the clinical signs from the image, we can see the lid edema and blocked orifices with diffuse conjunctival congestion and circumcorneal congestion. The corneal incision for SICS was also vascularized and inflamed. Coming on to the B scan, we see diffuse low echospike membrane echos. So the impression was post-cataract surgery, late onset endophthalmitis or non-granulomatous anterior uveitis with intermediate uveitis. So additionally, CBC, urea, creatinine, LFT and other investigations were also carried out, and patient was planned for vitreous biopsy, but in view of minimal vitreous echoes on B scan, AC tab was sent for PCR for mycobacterium tuberculosis and pine fungal, which turned out to be negative. Meanwhile, the patient was started on topical steroids half hourly and atropine thrice a day and dolo for pain. 1 month review showed that the patient's uncorrected visual acuity remained the same, but the best corrected visual acuity, which could be measured this time because of media clarity, was 21/25, and the funda showed normal appearing grade 1 media haze with normal appearing disc and choroidal mass lesion in the inferonasal quadrant with surrounding hard exudation. The OCT also showed the cystoid macular edema. B scan showed the plateau-shaped echoes with, so the impression was choroidal mass lesion versus peripheral exudative hemorrhagic chorioretinopathy. Patient was suspected to have the latter and was planned for intravitreal anti-VEGF. The echoes reduced on B scan after the intravitreal anti-VEGF, as well as the CME reduced. So patient was lost to follow-up and later presented after 2 months with diffuse scleritis and was started on prednisolone 40 milligram. Sorry. Yet again, the patient lost to follow-up for another 3 months and came back with cystoid macular edema and scleritis with mottled fluorescein staining and abnormal vasculatures as seen on the ICGA. In view of sclerouveitis with cystoid macular edema, differential diagnosis was revisited and the patient was tested for RA factor, C and P-ANCA, ESR, CBC and LFT. Yet again, patient lost to follow up for 1 month and finally presented with the PUK and still under investigation. So to conclude, a systematic and thorough workup is necessary, but it is imperative to follow up these patients and stress to these patients how important for them it is to come on repeat follow-ups to see the full presentation of the disease, and early multimodal investigations combined with the multidisciplinary management reduces the overall morbidity of the patients.
Do you have final diagnosis?
No, not yet. It's patient did not come up with the final reports yet after PUK.
Okay. You have any questions? So it's not worked up case, so we cannot
Not
comment on
completed.
that. Okay. Thank you.
Thank you.
We call upon Ghazal Patnaik to talk on role of biologic agents in uveitis scleritis.
Good evening, everyone. I won't take much time.
This is the previous presentation, no?
Actually, the order is
Order has reversed. Okay, okay. Okay, okay.
So I won't take much of the time. So not all is juvenile idiopathic arthritis associated uveitis in any young children. So hypopyon panuveitis is rare in children. It forms a diagnostic as well as a therapeutic challenge for the ophthalmologist. Crohn's disease is a chronic relapsing inflammatory bowel disease of unknown etiology. So ocular involvement is usually seen in 4 to 10% and usually in the form of acute episcleritis, acute anterior uveitis, marginal keratitis. HLA-B27 association usually manifests as acute non-granulomatous anterior uveitis. Till date, only one case of pan-uveitis in Crohn's disease has been reported, and that case was HLA-B27 negative, and the case underwent enucleation as it was a painful blind eye. We report the first case of pan-uveitis in HLA-B27 positive Crohn's disease that was successfully managed with adalimumab, preserving both the vision and the globe. So this was a case of 21-year-old male that presented to us with gradual painful diminution of vision in the right eye since 1 month. The best corrected visual acuity was counting finger closed face, and he was diagnosed as pan-uveitis after a comprehensive ocular examination. At the same time, he was complaining of pain in both the knees, which was almost simultaneous in onset with the ocular symptoms. Investigations, thorough investigations revealed HLA-B27 positive with a raised CRP level. There was a persistent dense vitreous echos, and for which the patient underwent urgent vitrectomy with lensectomy and silicone oil injection. And all the PCR polymerase chain reaction was done for the infection causes and was found to be negative. There was a clinical improvement after 2 months to 20/600. However, the patient developed GI issues and had a severe debilitating crippling arthritis, so much so that the patient was wheelchair bound. So an endoscopy biopsy was done, which was suggestive of Crohn's disease. The patient was started on injection adalimumab under the care of a rheumatologist. And to the surprise and to the joy of the patient actually has sent the mail stating that he was able to walk on his feet now. So it was only 1 week that he was able to walk, and the vision improved to 20/200. It is 1 year of follow-up. Patient is doing well. So panuveitis is considered as an atypical presentation. Our patient showed a dramatic improvement with adalimumab. So experts favors the role of anti-tumor necrosis factor in cases of posterior uveitis and scleritis. So to conclude, Crohn's disease is rare but serious inflammatory condition, and not all HLA-B27 positive patients with arthritis in young should be treated as JIA. Other systemic evaluation should also be done. To the best of our knowledge, this is the first case of HLA-B27 positive Crohn's disease with hypopia and panuveitis, highlighting the role of adalimumab. These are my references. Thank you.
Why did you go for urgent vitrectomy, lensectomy immediately?
Ma'am, the patient actually was saying that he was having more of haziness, and repeat serial ultrasound, as was seen in the pictures, was showing increase in vitreous haze. So just to rule out this possibility of infection therapeutically as well as for diagnostic
You
purposes.
sent for culture and sensitivity?
Yes, sir.
It was negative.
Sorry, ma'am?
Culture sensitivity,
Yes,
having
sir.
done
Culture, polymerase chain reaction, everything was done from the vid biopsy specimen and everything came negative.
Any questions from audience? Okay, thank you.
I think for those of you who are sharing the presentation and are wary of somebody else stealing the data, there is always we can do a password protection of the PowerPoint and send it, and then only you can access. I mean, even if you present to the common port, you can just put in the login, the password, so that there is no need to change the laptops.
Validate. And presentation prize, we have prizes for this case. So once again, thank you all. I think now we'll go ahead with the valedictory function. I think senior most faculties, sir and madam are there. So we'll just listen.
It was such a wonderful experience. We sincerely thank Dr. Parita to make this possible. And interdisciplinary meetings are very, very important. And we learned a lot. We really learned a lot. So many things were new. And the referrals will be better. And patient care will be better. And more such interdisciplinary meetings should be happening in future as well. Thank you, Dr. Parida, and thank everyone. Thank the trade people for helping us and financing, and students coming all the way from Kochi, Chennai, everywhere, presenting good cases, and all the faculty who presented so well. So even though it is one day symposium, it looks like we have attended for 4 days. It is a very good experience. Thank you, sir. Thank you, Dr. Parida. Thank you.
I think I'll echo what Madam has said. These kind of focused meetings to me are more, worth their weight, as if I could put it that way. You learn much more from these as compared to the generic meetings that we have. And I think I must compliment Dr. Jyoti Parida and also thank him for making me a part of this meeting. I think we do have some sessions in the USI, but that is only attended by the ophthalmologists. But herein, bringing both rheumatologists and ophthalmologists together on one forum is the way forward. I think this is a visionary approach wherein, surely, as Madam has said, it will definitely make a change in the understanding of both ophthalmologists and rheumatologists, which surely is bound to affect the patient care. And if at least 1% is sensitized, he is going to go back and sensitize his colleagues, and is going to have a cascading effect. And I think these specialties have reached a stage where we need more of such meetings with ophthalmologists, with dermatologists, wherever there is an overlap. And I think we learn much more. The highlight has been he's been able to get the senior most people from the uveitis, one of the top, starting off from Dr. Jim Rosenbaum to all the big names in the uveitis, and exposing them physically to the people who are here, and also through, you know, the virtual world. I think I was told that there were more than 100 attendees, and some were rather sending messages on the IRA group, which means people are keenly looking forward. They're just a bit wary of the COVID still going on. The talks were just fantastic. I learned so much. And then the session which Pradeep conducted with the three people was really something which was really, it was very good. And more so in the post-lunch session, this was something which probably learned maximum from that session. And I think these cases, we learn so much from the cases. The residents, I'm sure all of them, they would go back enriched. They learn so many things. They learn science. They learn how to conduct themselves. They learn what to do. And sometimes they also learn what not to do. I think all these things are important for you to evolve as a human being. I think I must thank, I must thank Jyoti again. Thank you very much for making me a part of this meeting.
Thank you, sir. I think we need a big applause for Sharon Madam, who stayed till 6 o'clock when everybody have left, and part of this academic experience. And I think these PG students also who are sitting there, they actually are the main beneficiaries. We also should clap for them because they are also sitting there listening to all cases. This is time for the prizes actually. We had beautiful cases actually. We have seen some cases for the first time. That scleral biopsy and IgG4, I think that was something out of the box.
I think if I could say, all the residents, they presented well. If we interrupted some people for going over time, don't take it as a criticism, take it as a learning exercise, because you are going to learn from each and everything. And eventually you will see your own presentation, you will see presentation from the other people, assess yourself, and you are only going to improve. All of you have done a good job, and all of us can improve. With that, I think it's time for the awards. For Jyoti to announce the awards.
So the first case, the third case presentation has gone to Dr. Ghazal Patnaik. Please. And for that biological series of patients that she had shown. So congratulations. So she is getting an Amazon voucher of 2,000 rupees. The second one goes to Miss Pranami. Please give a big hand, and she is getting Amazon voucher of 3,000 rupees along with a certificate. Miss Pranami. And the first prize go to, he deserved that because he had came from far, Cochin, Mr. Raswit V. For that IgG4 scleral disease.